series are, renal cysts are usually few and asymptomatic but have a high risk of increasing with age. So these basically warrant yearly surveillance, 1 to 3 yearly surveillance by USG or MRI, so that we can look for the transformation of renal cysts into renal angiomyolipoma, though it is extremely rare. Also, as far as central nervous system is concerned, SEGAs rarely demonstrate malignant transformation. mTOR inhibitors, particularly everolimus, provide rapid and sustained tumor control, which can help us plan the further management of the patient. Echocardiography should be planned every 1 to 3 years in patients with cardiac rhabdomyomas. However, malignant transformation of cardiac rhabdomyomas is exceedingly rare. In TSC-associated lymphangioliomyomatosis, which was not present in both of the cases because it's more commonly seen after the second decade of life, HRCT screening in women above 18 years every 5 to 10 years is warranted. mTOR inhibitors like rapamycin remain central to the surveillance and management for the same. Discussion and conclusion. TSC demonstrates variable clinical penetrance and multi-system involvement. So this warrants monitoring at multiple levels and neurological and oncological manifestations which may evolve over time. So early surveillance can prevent various complications due to the mass and tumor compression effects. Multidisciplinary care improves the long-term survival of these patients. Routine neuroimaging is essential for SEGA surveillance. mTOR inhibitors for multi-system involvement. Long-term structured monitoring is crucial in pediatric tuberous sclerosis complex. These are my references. Thank you all for being patient listeners. I invite any questions or discussions. Thank you, everyone.
My question is whether prenatal diagnosis of tuberous sclerosis is possible or not.
Thank you for the question, sir. On fetal echocardiography in high-risk patients, we can get rhabdomyomas in the prenatal period itself. That is the only manifestation which we can find in the prenatal period.
And how about chorionic villus sampling? Can we detect?
Chorionos and sir, there are not very many evidence for CVS sampling for a TSC complex.
What is the prognosis of these patients and what is the incidence first?
Incidence is, ma'am, 1 in 5,800 live births worldwide incidence. And prognosis, ma'am, long-term prognosis basically depends. It's more about the neurological manifestations than the malignant transformations of the various multi-system involvement. So as far as the neurological outcome is concerned, 50% of the patients have behavioral issues and epilepsy disorders. However, out of them, 25% have obstructive hydrocephalus and pressure and mass effects that can actually hamper the survival per se of the patients.
Is there any registry for the same?
I'm not aware of that. I'll check.
Okay.
Thank you.
How you manage seizures in this case?
Vigabatrin is the drug of choice for seizures, sir. And if they are associated with infantile spasms. Other than that, mTOR inhibitors for the other extracranial manifestations and tumors and tuberous sclerosis.
Did you find any genetic association?
Sir, it follows a autosomal dominant mode of inheritance with TSC1 and TSC2 gene predominantly in tuberous sclerosis complex.
Hello. Just one question from this side. I'm Dr. Vijay. It's a very nice presentation. You said that there are gene mutations. Whether these gene mutations can be found on chorionos villus sampling or it can be so that it can be used as a prenatal diagnosis. Do you have any idea about that?
Sir, two genes basically code for the hamartin and the tuberin protein. So it is less likely to be found on chorionic villus sampling as such.
So did you find any ocular manifestation in these two cases?
Yes, sir. First patient had retinal achromic patches, which is one of the minor criteria for the same. And the second female patient of mine had retinal hematomas, which is one of the major manifestation for the disease.
So how did you manage the retinal hematomas?
Retinal hematomas, sir, as such don't have a risk of malignant conversion. However, every 6 monthly fundus examination is warranted to see if the size of the same is increasing and if it affects the optic disc area as such. Thank you, sir.
Thank you.
Thank you.
Thank you so much, Dr. Vrinda, for this wonderful presentation. Now I would like to call Dr. Kanika Jain for the presentation.
Good morning, respected judges and my dear colleagues. Today, I present a rare case of pediatric MIT translocation-associated renal cell carcinoma. So, renal cell carcinoma itself is a very rare disease, and it accounts for around 2% of all the pediatric renal tumors. Hence, this is a very important case. And amongst this, the MIT family translocation associated RCC is a major subtype. Clinically, they can present with non-specific symptoms of either hematuria, flank pain, or palpable abdominal mass together, which is known as the renal cancer triad. Now, the diagnosis and awareness about this tumor is crucial, as it differentiates in the treatment and prognosis with the other epithelial tumors. With this background, we move to our case report. So, a 5-year-old girl presented with complaints of recurrent painless hematuria for around 11 months, and there were no other constitutional symptoms. Her per-abdomen examination was also normal. Radiological investigations were performed. The renal artery Doppler, which was done outside, showed a multilobulated soft tissue mass involving the left pelvic calyceal system with moderate vascularity and degenerative cystic areas. On CT, we could see a heterogeneously enhancing, here as you can see, we can see a heterogeneously enhancing mass in the left pelvic calyceal system, which was extending to the left upper ureter. Few enlarged lymph nodes were also seen in the left para-aortic area. When PET-CT was done, it shows an FDG-avid lobulated heterogeneously enhancing soft tissue density mass in the renal pelvis extending to the proximal ureter, which gave suspicion of a neoplastic etiology. Here, the left para-aortic lymph nodes were inactive. So, considering these investigations, surgical management was suggested. Frozen section of the tumor was sent to our pathology lab, and it was reported as malignant. Hence, left radical nephrectomy was performed. On histopathological examination, as you can see, the cut section showed a friable growth in the middle third of the kidney, which involved the calyx and protruding in the renal pelvis. On histopathological examination, the tumor cells showed a characteristic granular eosinophilic to clear cytoplasm, and these were arranged in sheets, clusters, and papillary pattern, which is very specific for a translocation-associated renal cell carcinoma. Also, we could find Samoma bodies, and these favored the MIT translocation family. The staging was PT1NX. Other special investigations to confirm our histopathology was done, which is IHC, which came out to be positive for specifically TFE3 along with other IHC markers. The molecular study, like FISH and NGS, the results are still awaited, as this case was recently came to our department recently. Moving on to our discussion. So, renal cell carcinoma itself accounts only to 2 to 6% of the malignant renal tumors, and this MIT translocation forms a major subtype in pediatric carcinomas. Majorly two subtypes are known, which is XP11.2 translocation RCC, which shows a gene rearrangement of TFE3, and second is translocation 611, which shows a gene rearrangement of TFEB. As no confirmed radiological investigation is known, hence the diagnosis depends upon histopathology, IHC, and molecular examination. So currently the treatment of choice for this modality is nephrectomy. On histopathology, we ruled out clear cell carcinoma, papillary renal cell carcinoma, and clear cell papillary renal cell carcinoma because all these tumors are majorly found in adults and they show specific histopathological characteristics. The confirmation of MIT family RCC is achieved through IHC, FISH, and genetic detection of this translocation, which is the gold standard, and our case showed positivity for TFE3. Moving on to the conclusion, renal cell carcinoma is rare in pediatric group, but translocation associated RCC predominates. Major treatment is still surgical intervention, and the prognosis varies on the tumor stage, lymph node involvement, distant metastasis, and its fusion type. Thank you. These are my references. I would be happy for questions.
What is the common translocation observed in adult RCC?
Ma'am, again, it is TFE3 is the most common found. Along PRCC, TFE3 gene rearrangement. Yes.
Okay. Is MIT translocation ever observed in adult old-aged RCC?
Yes, ma'am, it is observed. Though the incidence is low, but it is found.
So, what is the difference in treatment modality
Basically,
based on translocation?
Ma'am, based on translocations, majorly these MIT have a very indolent course, and the treatment is usually surgery. But if we find that there is a metastasis or some or high aggressive behavior, then chemotherapy is being studied about it, like mTOR inhibitors, PI3 TKI inhibitors, and PD1 and PDL1 inhibitors. Yes, thank you.
So, nice presentation.
Thank you.
How this MIT translocation, is there any role of this translocation in prediction of prognosis?
So these MIT translocation usually have a good prognosis, but if we need to be very vigilant, because these MIT translocations, if found in pediatrics, they can show metastasis after 20 to 30 years. So we need to have a follow-up of this till the age of 20 to 30 years if found in pediatric patients. Thank you.
Thank you so much, Dr. Kanika. Now we would like to call Dr. Ananya.
A very good morning to everyone present here on this fine morning. I am an ophthalmologist, and I like to call myself an ocular oncologist as well, and might be an ectopic for this gathering. But I really thank Cancer Hospital and Dr. Anil Sharma sir and Srivastav sir and ma'am for having me here. I'm here to present something about a 13-year-old male I'm here to present a case of a 13-year-old male who came with left eye prominence noticed since 4 months. It was painless, gradually progressive, no double vision, well associated with left eye decrease in vision. On examination, there was left eye abaxial proptosis of about 10 millimeters with inferior dystopia of 3 millimeters with resistance to retropulsion. There was no change with Valsalva or position, no thrill or pulsations. Extraocular movements were limited in all gazes, and as expected, CT scan showed a mass in the superior orbit. This was in the intra and extracorneal space, relatively homogeneous isodense mass in the left superior orbit. MRI confirmed the same findings, and it showed a iso-intense lesion on T1 and a hypo-intense on T2. The superior rectus was not seen separately from the lesion. My differential diagnosis here first was a rhabdomyosarcoma. Considering the age of the patient, I couldn't help but keep schwannoma on the list because of the superior orbital location of the lesion. Lymphoma, though uncommon at this age, I had to keep it on my list, and a myeloid sarcoma was there as well. We went ahead and did a left eye transcutaneous orbitotomy that gave me access to the superior orbit, and I was able to take an incisional biopsy, taking adequate sample from superficial and deep parts of the lesion. Histopathology revealed sheets of small round blue cells that had all the features suggestive of a malignant round cell tumor. Immunohistochemistry showed MPO, CD117, CD34 and CD99 positive. No surprises, it was a myeloid sarcoma. At this point, I referred this patient to an oncologist, and I do not have documentation, but the patient's father tells me that PBS and bone marrow were negative, and hence we're looking at a presumed primary myeloid sarcoma of the orbit. He was started on chemotherapy with vincristine, doxorubicin, cyclophosphamide, alternating with vincristine, etoposide, and ifosfamide. After 7 cycles, the proptosis reduced significantly, and ocular movements and vision improved with no diplopia. What I learned from this case was childhood proptosis requires urgent evaluation, and any hematological malignancy or to stage a disease requires its biopsy, peripheral blood smear, bone marrow, and CSF wherever required. Early initiation of systemic AML-directed chemotherapy is required, and multidisciplinary management. The take-home message from this case for everyone here would be that an orbital myeloid sarcoma can be the first presentation of AML. Progressive unilateral proptosis in a child should always raise a suspicion of a malignancy. Early orbital biopsy is critical, and systemic AML-directed therapy is required. Thank you so much for your patient listening.
Nice case, Dr. Ananya.
Thank you, sir.
So, what about the systemic manifestation in this patient? Systemic workup was done?
Systemic workup was done with the oncologist, so I do not have photographic documentation of the same, but bone marrow was negative as well as PBS was negative.
Thank you.
How common is this condition, primary myeloid sarcoma?
It's not very common, ma'am. It's about 1 to 9% of patients with that have in the future have found to have AML. So, ma'am, what I read in literature is 0.7% is primary, and 1 to 9% is patients having AML.
So there was, as you say, there was no evidence of the AML in peripheral blood smear or bone marrow?
Not in this patient.
Not in this patient, but do they present later in other cases?
Yes, ma'am. What I found in literature and what we've studied is they can progress to an AML, and that's why the chemotherapy is directed to AML and not focal or local therapy.
Okay. Interesting case. Good
Thank
one.
Nice presentation. What are the other presentation in pediatric age group of this myeloid sarcoma?
So the most common involvement with a myeloid sarcoma would be skin lesions or cutaneous leukemia, that is called, or lymph node involvement, and orbit is a much rarer presentation of the same.
Yeah, so this side, Dr. Vijay here. So it's a wonderful case. Thank you for the presentation. So do you suggest post chemotherapy any sort of bone marrow transplantation or stem cell transplantation to this patient, because these myeloid sarcomas are notorious for recurrence. See, we recently had one patient which is still admitted in our ward of myeloid sarcoma of breast, although it's adult patient. Bone marrow was negative and everything else was negative. But the point here is, I'm not sure which chemotherapy. I think it's a BFM protocol, because usually we give very intensive 7+3 regimen in such patients, and then after that we would like to do a stem cell transplant also to sort of complete the treatment. Thank you.
Thank you for the comment and question, sir. It is me learning about this from you rather than the other way around. My expertise is limited to the ocular findings, so I will be happy to learn more about bone marrow transplantation in these cases. However, I have also read about the 3+7, but this is what was given for this patient, and hence have documented the same. Thank you.
Thank you so much, Dr. Ananya. Now we would like to call Dr. Paras Bhonsle.
Good morning to all of you present here. Today I am going to present a paper on the thesis topic which I have completed under the guidance of Dr. Shweta Sai ma'am. My title for thesis was the prognostic value of neutrophil lymphocyte ratio in a patient of sepsis. Sepsis is a life-threatening syndrome of organ dysfunction precipitated by a dysregulated host response to an infection. Sepsis, which refers to means in this thesis I have referred to sepsis. I have called a sepsis in the patients who are having the Q-SOFA score of more than or equal to 2. The Q-SOFA score consists of 3 parameters consisting of respiratory rate more than or equal to 22 and systolic BP of less than or equal to 100 millimeter of mercury and altered mentation status. Rest septic shock is defined under this as there's a persisting hypotension requiring vasopressors to maintain a mean arterial pressure of more than equal to 65 and lactate more than 2 millimole of liters despite of adequate resuscitation. This is a Q-SOFA score which is equal to more than equal to 2 score, which indicates the sepsis. Background of this study was sepsis was a life-threatening organ dysfunction caused by a dysregulated host response to an infection. High mortality rates were seen in the patients of sepsis, which increases the resource burden. So we need a rapid markers which can predict the outcome and future prognosis of the sepsis. We need for a rapid and cost-effective prognostic markers for the same. Rationale of NLR, absolute neutrophil by absolute lymphocyte count can be a marker which reflects innate activation and adaptive suppression of an immune system. It is easily available from CBC and it is a low-cost bedside marker. Aims and objective: to study the prognostic value of NLR in the patient of sepsis. Objectives: association of NLR with the prognosis and to compare it with old scores such as Apache score and SOFA score, and to prove its association with the bedside Q-SOFA score or quick SOFA score. Methodology: it is a prospective observational study conducted in the Department of Medicine, GR Medical College, in the patients admitted in the medicine ICU. My sample size was 82 and inclusion criteria was Q-SOFA score more than equal to 2 and age 18 and 65. Exclusion criteria involves the radiation therapy, malignancy, PLHLI condition, patient on immunosuppressive therapy, age less than 13 and refusal to be enrolled in the study. Study variables was NLR ratio on day 1 and day 3. association with SOFA, Apache and QSOFA score, CRP and other lab markers which can be used as a which can be also used as a predictive marker for the sepsis, hospital stays and outcome. Amongst this, the study shows that as the age group increases, the chances of sepsis increases, in which predominantly 41 to 60-year-old individuals were having more prone to sepsis. Male, 63% of male were having prevalence of sepsis, prevalence of sepsis in a comorbidity pattern. My study shows only hypertension is relating to the severity of the sepsis. Rest, diabetes mellitus, CKD, COPD and other mixed comorbidities have no correlation. Amongst the system-wise infection, the respiratory system predominates the patient in which there is a poor prognosis, poor outcome of the patient with sepsis. In summarized, mean age was about 47 and standard deviation was about 14 years. Majority of people 41 to 60 years of male with male preponderance. Hypertension being the 39% and most associated comorbidity. Results, NLR ratio, I have categorized the patient in an NLR ratio less than 10 and more by 10. On the day 1, the frequency of the patients were having more than 10 NLR was 42 amongst the 82 patients. On the day 3, the frequency of patient with NLR more than 10 was 36. That may indicate that patient are responding to the antibiotics and having a good outcome. Next, NLR ratio on the day 1 more than 10 showed a poor outcome and having the significant p-value. Same with the day 3 patients, same with the NLR ratio on day 3. CRP also showed a significant value in the patient of sepsis. Literature evidence, there is a high NLR associated with mortality. NLR, thank you.
So NLR is a rapid and inexpensive test. It can be derived from CBC itself. And what are the important limitation in our clinical setting that we should be aware of while using NLR scores?
So certain infections like malignancies can elevate the lymphocyte ratio. So
no, you said certain infections like malignancy.
No, sir. Certain conditions like malignancy, which can increases the lymphocyte count, which can alter the results. Certain infections such as tuberculosis, which can also have a high lymphocyte ratio. Some atypical and viral infections can also elevate the lymphocyte ratio, lymphocyte counts. So that can also alter the NLR ratio.
Yeah, and other is post-surgery patient and autoimmune diseases.
Yes, sir.
Also are there where we cannot use this score with confidence.
Yes, sir. That are included under the exclusion criteria. We are not included the patients. Thank you.
You validated this with, two basically questions. The first one is how you arrive on a sample size. The first, why 82 only?
Sir, we have I have contacted the data analyzer and PSM department. According to the data and study and demographics, they have told me sample size.
You should also know how you calculated.
We have, sir, sample size. We have formula for calculating the sample size. So according to that.
Okay. And the second thing is this. Do you have any validation for this score as of now? I mean, is it valid? Because QSOFA is validated.
Yes,
all
sir.
other scores are validated. So, do you see any validation studies? Is it there in the literature, or are you planning to validate this?
Sir, there are studies, but they are not validation. Or
Thank you.
Thank you, sir. Thank you.
Thank you so much, Dr. Paras. Now we would like to call Dr. Manish Sharma.
Good morning to all of you. Today in my paper presentation, to study the clinical demographic profile, clinical presentation and management outcome of retinoblastoma in tertiary care center. Abstract. Background. Retinoblastoma is the most common primary intraocular malignancy in children and account a significant proportion of pediatric ocular cancer worldwide. Early diagnosis, prompt management are essential to improve survival, preserve vision, and reduce metastatic complication. Delayed presentation remain common in developing country due to lack of awareness and limited access to specialized ophthalmic oncology services. Material and method. A hospital-based observation cross-sectional study was conducted in Department of Pediatric and Ophthalmology at CME and PGI Indore. Total 60 patients diagnosed with retinoblastoma over a period of 18 months were included. Result, the mean age of presentation 3.2 plus minus 1.4 year. Leukocoria is the most common presenting complaint, followed by strabismus, diminished vision. Bilateral involvement observed in 28.3% patients. Conclusion: retinoblastoma commonly present in children younger than 5 years with leukocoria as a predominant symptom. Early screening and prompt referral significant improve survival and globe salvageable rates. Keywords: retinoblastoma, leukocoria, pediatric ocular malignancy, enucleation and chemotherapy. Introduction. Retinoblastoma is the most common intraocular malignancy of childhood arising from primitive retinal cell. It occurs due to mutation of RB1 tumor suppression gene located on chromosomal 13q14 chromosome. The disease may hereditary or non-hereditary. Most commonly affect children below 5 year age. Globally, retinoblastoma accounts for approximately 3% of childhood cancer. The incidence is estimated around 1 in 15,000 to 20,000 live births. The developing country delayed diagnosis contribute to increase morbidity and mortality. The common presentation is leukocoria followed by strabismus, redness, pain, visual impairment. Advance in chemotherapy, focal therapy, multidisciplinary management have significantly improved survival outcome. Matter and material. Study design is hospital-based observational cross-sectional study conducted in CME and PGI Indore. Study area: Department of Pediatric and Ophthalmology at a tertiary care center. Study duration 18 months. Inclusion criteria: child age less than 10 years, diagnosed with retinoblastoma, patient who gradually provide informed consent. Method and material. Exclusion criteria: incomplete patient with incomplete records, previously treated with unavailable treatment detail. Investigation: fundus examination, ultrasonography, B scan, MRI and brain histopathological examination. Treatment modalities: systemic chemotherapy, enucleation, laser therapy, cryotherapy, radiotherapy. Results: variable. Age less than 5 years 44%, age more than 5 years 26%, male 58.3%, female 41.7%, unilateral disease 71%, bilateral disease 28.3%. Presenting complaint results: leukocoria 68.3%, strabismus 40%, redness and pain 30%, diminished vision 23%, proptosis 15%. ICRB group. Group A include 6.7%, Group B include 13.3%, Group C include 16.7%, Group D include 35%, Group E include 28.3%. Discussion. Most patients presented with advanced stage, highlight delayed diagnosis, referral patient. Leukocoria remain most common presenting symptom. Enucleation was the most common treatment modality, advanced disease, while chemotherapy and focal therapy are useful in early stage with globe salvage. Public awareness program and routine red eye examination during pediatric visit can help in early diagnosis and improve survival. Conclusion: retinoblastoma is potentially curable childhood malignancy with early stage. Leukokaria is most common presenting complaint, required urgent ophthalmological evaluation. Delayed presentation lead to advanced disease, increased enucleation, early screening, timely referral, multidisciplinary management are essential for the improving survival.
Good morning. Very impressive numbers. 60 cases in 18 months was very impressive. I want to know what was your primary mode of treatment?
मैम अर्ली स्टेज में अपन कीमोथेरेपी क्रायोथेरेपी करेंगे और एडवांस स्टेज में मैडम इनुक्लेशन करेंगे उसमें.
How many cases of orbital retinoblastoma did you get?
Yes ma'am.
Orbital retinoblastoma.
क्वेश्चन समझ नहीं आया. 60 case.
60 was your total, right? So orbital is when it spreads outside the eyeball. So when it involves the orbit, so that dramatically reduces the survival of the patient. So now treatment protocols have changed for that, wherein we use chemo followed by surgery, followed by radiotherapy, followed by extended chemo, and that has dramatically improved the survival. Otherwise, it was almost like a death sentence.
Yes, ma'am.
But very nice study. And what drugs are you using for chemo?
Yes, ma'am.
What drugs?
Madam, vincristine, etoposide or vinblastine. Sorry, etoposide.
Thank you.
You have mentioned that the leukocoria is the most common presenting symptom, and what are the differential diagnoses of leukocoria in children? What are other conditions associated with leukocoria in children?
सर एक तो ग्लूकोमा हो सकता है मैडम. सर वो सॉरी चाइल्ड ग्लूकोमा, कंजेनिटल ग्लूकोमा, सॉरी कंजेनिटल ग्लूकोमा.
No, it's cataract, toxocariasis, retinal detachment. These are the conditions associated with leukocoria.
Yes, sir.
And PHPV.
Yeah, hi, good morning. देखिए, I am Dr. Harish Gupta and I am from Cankids Kids Scan. हमारे retinoblastoma पे for the last 10 years we are having a project called Fight Retinoblastoma, but I have never seen such a big number in Indore, SAMS or maybe PGI. 60 is a huge number in the 18 months, and you know, if you can share with us the data, the 60 number, and secondly you have seen the D and the E number is a very high, group D and group E. So what is the means after treatment, are you able to save the eye, save vision of these cases in group D and E? Are you also doing intraarterial chemotherapy in these cases or not? My question is this. And what steps are being taken by the hospitals to get the patient in the early stages, group C and group B and group A? Are you doing something? Are you creating some awareness in the remote areas or in the peripheries?
सर अभी तो कोई डाटा नहीं है मेरे पास.
अभी कोई डेटा नहीं है, but you have put up 60 patients in 16 months, where I think 21 patients are in group D and 17 are group E, if I am not wrong, the data that you have presented. So in these two group D and group E, what is the survival rate of the patient? Do you have any idea for that, or I am just
सर एडवांस स्टेज में सर्वाइवल के चांसेस कम रहते हैं.
So that is my question. Out of 60 patients, what is the mortality? Out of 60, what is the abandonment rate? 60 बच्चा तो आ गया, उसमें मान लीजिए 50% is abandoned. So this is 30 patients, and out of 30 patients, 50% is mortality. There are 15 patients. I am just trying to understand. मैं वो जानना चाहता हूँ बस. आपका डेटा तो 60 नंबर का बड़ा ह्यूज नंबर है. मैं देखिए, we people are currently working in more than 60 hospitals pan India for retinoblastoma. That includes Center for Sight Hyderabad, LBPI Hyderabad, Arvindas, Shankaraz, Shroff Charity Eye Hospital, RP Center, right? I'm just trying to understand this number. This is, if you can explain, then otherwise I will talk to you later on also. If you can't explain right now. Okay.
Cancer registry?
Yes, ma'am.
You are aware. So are we reporting it
Yes, ma'am.
to the registry? Is your hospital reporting it to some registry? Because as mentioned, it's a very huge number.
Sorry, madam.
You're not aware?
So yes, number is huge, and I think the recently published collaborative study from INPOC, it mentioned the most of the people from the UP area where the densely population is there. So
yes.
In INPOC study, mostly the incidence is more in UP and
yes, in UP and Bihar.
UP and Bihar, right?
Look,
So
INPOC.
I agree, sir, and I think that number is quite astonishing for all of us.
Yes,
In the
yes,
interest of time, I'll take the permission of the judges to move ahead with the program, please.
Thank you so much all the participants for their active participation and great insightful presentations. Thank you so much to our esteemed judges for their active participation and giving our judgments for all the participants. Thank you so much. So we are moving forward for our next session.
A very good morning to all. It gives me an immense pleasure to welcome our respected dignitaries, faculty members, delegates and participants of CME 26. To begin this auspicious ceremony, I would like to invite our esteemed dignitary on the stage for the lamp lighting ceremony. May I request Dr. Priya Srivastav sir, Dr. G.S. Rajput sir, Dr. S.P. Tripathi sir, Dr. Narendra Patidar sir, Dr. Ravi Ambe sir, Dr. Jyoti Priyadarshini ma'am and Dr. Rajiv Sagwaria sir to come forward on stage and grace the occasion by lamp lighting. Please join us on stage, sir, please.
शिशु है अज्ञानी माता, इन चरणों का प्यार दे। पीरा पारी तार दे, तार दे, तार दे। माँ सरस्वती शारदे, माँ सरस्वती शारदे।
academic sessions. Before we move ahead, I would like to request you all that inside your folders you have 2 test papers. One of them have to serve as a pre-test and the second one would be a post-test. I'll request all of you to take out the pre-test question papers and do fill in the answers while we initiate the academic sessions. We won't be putting up the extra time for that, so please do it while the sessions are on. Thank you.
We now proceed to our scientific session. I would like to respectfully invite our esteemed chairperson for this session, Dr. Kamalpreet Likhari ma'am, Dr. Priyamvada Bhasin ma'am, Dr. Nidisha Agrawal ma'am, Dr. Rajiv Sagwaria sir, and Dr. Jyoti Priyadarshini ma'am to kindly join us stage. Ma'am, sir, ma'am, please join us stage.
I invite Dr. Anil Sharma to give his talk. He is a consultant in hematology and pediatric oncology right here at the Cancer Hospital.
Thank you, Chairperson, and all the delegates to come here for the conference. So, our first topic is, if we know the problem, then only we have some solution. So, the setting the context epidemiology of pediatric cancer in India. So, we have to objective our understand the pediatric cancer burden in India, then review epidemiology pattern and regional variations, discuss the diagnostic and treatment assess challenges, highlight gaps in pediatric oncology services, and suggest the priorities for policy and cancer control. If we know the burden, if we have evidence, then we have to do some actions. So, global burden, around more than 2 lakh children diagnosed worldwide annually. Among them, 80 to 85% of cancer occur in lower middle income country. Leukemias are the most common pediatric cancer. The survival rate is more in the higher income country, more than 80%, but in lower middle income country like our country had some gaps between the treatment and outcome. So the global picture is defined by a large burden concentrated in LMNCI with survival strongly linked to health system capacity. The India burden is around 4% of the all children, all cancer malignancy, pediatric malignancy is 4%. Among them, if we think about less than 14 years, every year 52,000 newly diagnosed pediatric cases is there. If we include the 0 to 19 year of age, around 76,000 estimated case per year. So the higher burden is seen in population like Uttar Pradesh, Bihar, Maharashtra and Madhya Pradesh. So the incidence is 38 to 124 per million children per year. So the urban registries show the higher incidence than the rural registry. Rural India may have underdiagnosed and underreported. So Delhi reports among the higher age-adjusted Indian rates. So observed incidence is not just the biology, it also reflects the diagnostic reach, registry coverage and referral access. So this is the paper published recently 2 years back addressing the alarming rise in pediatric cancer prevalence in India, a call to action. So recently more than 2 lakh children impacted annually, but it is projected to escalate 21 million, means 2.1 CR cases diagnosed, new cases by 2030. अभी ओनली 2 लाख केस हैं तो 2030 तक ये 2 CR हो जाएंगे, तो ये एक अपकमिंग बर्डन है हमारे पास. So this is the age standardized rate. So the most common cancer is leukemia, brain tumors and all the things, and the mortality according to, because the leukemia is the most common cancer in pediatric malignancy, the mortality is also according to that. So which are the most common childhood cancer? Leukemia, as we know, then CNS tumor, lymphomas and retinoblastoma. Retinoblastoma relatively higher incidence than many developed country in our country, like developing country. So why is burden is increasing? Everybody told that कि कैंसर बहुत फैल रहा है. ऐसा नहीं है, पहले भी कैंसर होता था, but now there is a improved detection rate, urbanization, referral system. So there is a improved awareness and referral reach and demographic shift, population growth and survival from the infection. Gender and regional variations, so there is a male preponderance, possibly include healthcare seeking bias and access differences. So this is the pediatric cancer incidence in India between 0 to 14 years. So Uttar Pradesh and Bihar is the every year more than 5,000 cases per year. In our state Madhya Pradesh, around 3 to 5,000 cases per year newly diagnosed pediatric cancer. So why there is a challenges in pediatric oncology? Because delayed diagnosis. So if there is a delayed diagnosis, the disease is advanced. Limited units of pediatric oncology and its capacity. Limited resource of the pediatric oncologist and oncological nurses, and financial toxicity in developing country. So there is a system gap. Specialized pediatric oncology department are absent in many tertiary hospitals. So there are 3 pillars: diagnostics, referral pathway and supportive care. So as we know, there is a more than 80%, means out of 10, 8% of pediatric cancer is survived in developed country. But in like India, lower middle income country, there is a 60 to 70% of survival rate or below that, because there is a late presentation, infection rate is high, malnutrition, child is already malnourished before the treatment, and treatment abandonment. So supportive challenges: if the diagnosis is okay, financial is support by the government, but blood and nutritional support is the first challenges to treat the pediatric cancer. Then followed by psychological and socio-economical stage. If we counsel the patient to treatment, but due to some surrounding condition, they are not ready to start the treatment. if we told that up to 80 to 90% of survival rate, and survivorship care, long-term follow-up system are still evolving. So this is the cancer registry which all over the India from north to west and east. So there is a assessment of children cancer care survivors in India, gaps, challenges, and the way forward. So if we think about the government hospital, NGO and private hospital, so almost average is 30 to 40% of the hospital only have a pediatric cancer drugs. Means out of 10, 6 hospital are not available for the pediatric cancer care provider. National Cancer Registry Program. So if we have a registry data, population based and hospital based cancer registry data, so we have to plan about the disease and diagnosis, and if the number of patients is increasing, the expansion of the services we will provide, and incidence of gap between the diagnosis and treatment and supportive care will improve. So dedicated national childhood cancer policy, early diagnosis and program, pediatric oncology infrastructure in public hospital, insurance and financial support are our priority for treatment for the malignancy in pediatrics. So message is childhood cancer is an emerging public health priorities in India. True burden is likely underestimated. Major disparity exists in access and outcome. Policy, infrastructure and research investigation are urgently needed. So this is our data last for 3 years, Cancer Hospital and Research Institute, Gwalior. This is the retrospective observational study between January 2022 to 25. Total pediatric patient is 304 registered below the 18 year of age. 283 patient is analyzed after excluding abandonment and incomplete treatment. So 8 year is the mean age of diagnosis. As we know, male is the preponderance, 60% is the male and female is 40%. A male predominance consisted with broader registry and observation. In our hospital, mainly the patient is from the nearby Gwalior, Datia, Dabra, Jhansi and Uttar Pradesh, Agra, Etawah and other cities. So spectrum of malignancy in our cohort is 66% is acute lymphoblastic leukemia out of 283, which is 23%. Then Ewing sarcoma and soft tissue sarcoma is 13%, followed by Hodgkin's lymphoma. Osteosarcoma, bone tumor is 20 case, around 7%, and other malignancy are there. Treatment outcome is 63% patient is receiving active treatment now, and around 7% is treatment abandonment observed, and 21% is relapse refractory cases, which is equivalent to the national registry. These are our pediatric ward, which we have regularly celebrate the birthday celebration of the pediatric patient, and there is a weekly parent doctor meeting and support group meeting in our hospital with the help of the Cankids team. And if the patient is survivor, so survivorship is more than the cure. Recreation, peer connection and rehabilitation is the important for the survivor. Thank you so much for kind attention. Yes, sir. Yes, sir. This is this. Yes, sir. This is the article.
If you are talking about India, then it cannot be 2 CR.
It is global burden, sir.
Has a global burden, then 5% to 4% is India's burden, right?
Yes, sir.
Right. So approximately 76,000 patients are currently incidents of childhood cancer in India at present.
Yes, sir.
And right now, you know, the fertility rate in India is decreasing and the aging population is increasing,
Yes,
right?
sir.
So we cannot have the burden more than 80,000 if there is a study further.
Yes,
The
sir.
first study has been done in 2021 by Mr. Dr. Nikhil Bhakta, Dr. Ramandeep Singh Arora and Poonam Bagai, which listed the incidence of childhood cancer from 0 to 19 years of age. And after that, there is no further studies on this topic. Till we have got the new study published on that, we people will go with the incidence of 76,805 in India. This is my opinion, and 2 CR, so I think this is a number which is a doubtful number to me.
This is the, you are saying, sir, burden of children, childhood cancer
This is
in
okay, this is
in
okay.
India.
This
But
is
this
okay.
is, I took from the, this paper, which is projected to escalate, sir. This is not a confirmed data.
And is right,
Yes,
Koki
sir.
sir, right now if there are 4 lakh incidents of childhood cancer globally, 4 lakh if I can say, right, तो sir उसके हिसाब से भी यदि हम करेंगे तो 5% is 80,000, it is 76. So 20.1 CR is unrealistic. This is
सर यही मैंने सोचा कि जब इसमें total number.
Yes sir, right now it is 4 lakhs. Right now it is 4 lakhs. So 4 lakhs sir, 2 CR is a huge jump. My question is, मेरा सवाल बस
एक्चुअली
यही
आप
था.
सर सही बोल रहे हैं. जब मैंने भी 21 मिलियन उसमें पढ़ा तो मैंने उसको गूगल पर दिया 21 मिलियन 20 लाख होते हैं कि 2.1 CR. दैट आई हाईलाइट दिस डाटा.
सर ये थोड़ा
कि 20 मिलियन
अनरियलिस्टिक है.
यस सर.
इसको एक बार देख लेंगे डेटा को, क्योंकि
Yes, sir.
we people have got our own
Yes, sir.
advisors. Right, Dr. Manas Kalra is going to be here in the next couple of hours. So he's our advisor. So we people will discuss. But this is, for me, it is unrealistic.
January 2025. This is a recent data from
This
the
is
global,
unrealistic. But we
yes,
people
sir.
will go with this data.
Yes, sir.
This is
The
unrealistic.
study is from which journal? जो ये डेटा दे रही है 2.1 करोड़.
Actually, ma'am.
हाँ, even
I will.
it's not visible, and we can of course cross check.
And
the
secondly, though ICMR की study को sir ने quote किया है, next to next slide, where you people have done the next is next.
This.
Next.
I think this.
Next. This is the study done by ICMR.
Yes, sir.
Under Dr. Prashant Mathur.
Yes, sir.
Right. तो उसके अंदर ये बताया गया कि they have done the situation analysis of childhood cancer means services in India. So
Yes.
where they have listed public hospital, private hospital, trust
NGOs
hospital,
hospital.
and NGOs hospital. So they have done this study. This is the latest study by ICMR, and still childhood cancer अभी भी government के NCT programs के अंदर नहीं है.
नहीं है, sir.
If we are going to ask the government की childhood cancer के separate policy, that is not possible, frankly speaking. 76,000 is not a big number. इस देश में रोज 500 आदमी मरता है रोड ट्रैफिक एक्सीडेंट से. It is 15,000 in a month. So government does not going to give a leverage to this, but we people can push कि under NCT we people can have a policy for childhood cancer. Rather than going to ask for a separate policy for childhood cancer, it is better to push कि under NCT program we people can have a separate, you know, something for childhood cancer. So that will help us.
Yes, sir. Thank you, sir.
I am
Very
sorry.
nice, Dr. Anil. Just one small rider here. You said that the incidence is more in India. So at least for retinoblastoma, the incidence in all populations across the world, there is no predilection for anyone. Only thing is because we have more population. So among the Asian countries, among the low middle income group countries, we find more cases, and also we find lower results, poorer results, with the exception of Japan.
Yes.
So that is
Because
one very valid point.
retinoblastoma is the one of the cancer. If we treat it completely, the 100% survival.
100%, yeah.
But there is abandonment is more.
Yes. So that is, I think, a gap which we have to bridge. That is, the onus is on us to,
Ma'am,
step across
as
this.
per the incidence that I am mentioning, 76,000, as per that study, the incidence of retinoblastoma is 1676 in India. This is, because I am worked very closely in retinoblastoma, and we people are able to have the access to 1676 children right now. हमने एक अभी publish करने वाले हैं, and in the Indian Journal of Ophthalmology हमारा एक article आया है Cankids का, where we people have listed कि कैसे we people are able to work over the years to have this retinoblastoma figure. Right, so this is the thing I would like to mention.
Thank you, sir. Thank you, ma'am.
Next is my presentation by myself. Can come over.
Thanks, Dr. Anil, for nice presentation. Now I'd like to invite Dr. Haresh Gupta. He is Deputy CEO of Cankids, and he is a senior professional having 25 years of experience. He holds master degree in business administration and graduation in Ayurvedic medicine and surgery from Delhi University. And he has been significantly working for change of childhood cancer across India.
So, good morning everyone. I am thankful to Dr. Srivastava sir and the team of Cancer Hospital for inviting us to make a presentation. Let us start with a video of Cankids of the last 22 years, what we people have achieved over here. Volume mic?
25 years ago, I had cancer and survived. I pledged to use my privilege to purpose to ensure that no child in India loses their life to cancer because of where they are born. Cankids was born from lived experiences and built on the belief that every child deserves not just to survive, but to live, learn, and dream again. With Yana, You Are Not Alone, we hold the hands of the family. We work across the entire continuum of care, from detection, diagnosis, referrals, treatment, shared care, and continuity of care, palliation or survivorship. With more than 140 hospital partnerships across 60 cities, 32 care centers, 8 state government memorandum of understanding, and 22 state Change for Childhood Cancer projects in India, we have driven access to care from 29% to 53% in the last 5 years, and secured financial protection for families through direct support and facilitating access to government funding and schemes for over 22,000 children each year. Under the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, thousands of children now access free quality cancer treatment in public and private hospitals. From Delhi to Chennai, from Mumbai to Kolkata, Cankids has built a comprehensive ecosystem of care that bridges hospitals, government schemes and families, filling gaps, enhancing service delivery, providing medical support, nutrition, hygiene and infection control, blood support, accommodation, transport.
Using a holistic approach, Cankids has created a model where medical treatment, humane care, family-centered care has been all brought together and scaled up in so many parts of the country.
We empower the patient and the family to build the patient voice for their right to be heard. Mera hak, I deserve the best treatment, care and support.
मेरा मुझे हॉस्पिटल के लंबे लाइन में नहीं भेजना है। मुझे दर्द वाला इलाज नहीं चाहिए। मैं चाहता हूँ कि कैंसर की दवा सस्ती हो। मेरे घर के पास ट्रीटमेंट के लिए अस्पताल हो।
We train and offer internship and employment opportunities for them to be patient navigators and patient advocates and ambassadors. In 2013, we launched PCRI, India's first patient-centric pediatric oncology research hub that is CHRI certified by the Department of Science and Technology. We promote and support research. We study what matters, why children drop out, how families cope, and what systems must change. Families often travel hundreds of miles for treatment. That's why we've built Home Away from Home, safe, nurturing spaces where healing continues through food, education, and love. This is social sustainability in action, where dignity is designed into care. At Kanshala, India's first school for children with cancer, learning never stops, not even during chemotherapy.
जब मैं वापस स्कूल में एडमिशन लिया तो एक फाइनेंशियल ट्रबल था उस टाइम पे फैमिली में, तो मेरा एजुकेशन शायद कंप्लीट नहीं करवा पाते। उस टाइम पे कैनकिड्स आगे आई और कैनकिड्स ने सपोर्ट दिया।
Cancer affects not just the body, but the mind, the heart, and the soul. Through psychosocial programs and palliative care, we ensure that no child and no family walks alone. Our CHRI therapy transforms hospital spaces into circles of healing and resilience. In 21 years, we haven't just cured children, we've healed families, inspired systems. Together, we've shown what compassion, commitment, and collective action can achieve. We've built a nation that believes no child should die of cancer because of where they are born. Cankids Kids Can is India's hope for every child with cancer, and we invite you to be part of this change.
So this is a brief presentation. This is a brief video of what we people are doing right now. We people have started working in 2004 when our founder, Mrs. Poonam Bagai, has got a colon cancer and she was treated in Warsaw. And once she came back to India, so she has decided to dedicate her life for the children, those who are suffering from cancer. So together, let us do cancer को डिशुम डिशुम. This is our logo for the year 2026. कि कैंसर को यदि हम डिशुम डिशुम करेंगे तो कैंसर भाग जाएगा. तो this is a catch for the families as well as for the children. कि they should not be afraid of the suffering that they are going through. So जो भी डॉक्टर अनिल ने presentation दिया, there are around 4 lakh children globally, and out of that around 20% cases are in India. So incidence of childhood cancer is 76,805 right now in this world. So we have seen in this presentation ki if you go for the high income countries, so there are 80% survival rates, and in the low middle income countries the survival rate is around 20 to 30%. यदि हम बात हिंदुस्तान की करते हैं, इस इंडिया की करते हैं, so यदि it varies from hospital to hospital. If you go to a private hospital like Apollo, like Max, where you will get the survival rate of approximately 80 to 85%. But if you go to a public hospital, the survival rates are around 40 to 50%. Again, depending upon the type of cancer, ALL ka survival rate is different, retinoblastoma survival rate is different, osteosarcoma survival rate is different. So if you can see this code, where a child lives should not determine where a child lives or not. So what is the need to focus on childhood cancer? If you go by a report of Lancet Commission, if you invest $1 in childhood cancer, the reward is $3. Because children are the future of any country, and investment in childhood means they can be more productive to the country later on in their lives. Improving childhood cancer care offers an important opportunity to save lives and to reduce suffering, to catalyze progress towards a more inclusive cancer control program, and to demonstrate success in the broader child health and non-communicable disease agenda. Our mission and the vision is to ensure global standard of survival for childhood cancer in India, to ensure quality of life, holistic care for children with cancer and their families throughout their journey, to secure the 5 rights of the health impaired child: right to health, right to education, right to childhood, right to pain and palliative care, and right to be heard. What are our core values of Cankids? Engaging patients, parents, survivors, community with passion, dedication, collaboration and partnering with all stakeholders. That includes partnering hospital, that includes government, central government, state government, that includes association with Indian Academy of Pediatrics, that includes association with Ophthalmic Society of India as well. Working with honesty and transparency, creating a strong, sustainable organization to make a change for childhood cancer, developing a low-cost and sustainable model and solution that best suited for our country, working professionals to ensure efficiency and accountability. Now, in 2017, WHO has mandated that by 2030, 100% access to the children with cancer, 60% survival by 2030, and 100% universal health coverage to the children by 2030. What does it mean? Then WHO, it means that by 2030, if we have 6 index cancer that WHO has listed, that includes leukemia, ALL, that includes retinoblastoma, Wilms tumor, low-grade glioma, NHL, and Wilms tumor. These are the 6 index cancer that WHO has listed. If we are able to focus on only these 6 cancers, then we people are able to reach a 60% survival by 2030 and 100% access. As per the report by Lancet Commission, only 45% children are able to access any healthcare facility. It means out of 76,000 patients, only 38 to 40,000 children are able to reach any healthcare setting. It means, I am talking healthcare setting, I am not talking about any tertiary care hospitals, any healthcare setting. So we have to work very hard by 2030 so that all the children will get access to healthcare facility. Then we should have a proper referral system so that the children from PSC will go to CSC, from CSC to DH, from DH to any tertiary care hospital. And we people are there right now from 13 hospitals in 2013 where I have joined today. We have a partnership with 142 hospitals pan India, where currently we people are there in around 60 cities and 22 states. This is the, you can see our network. It is a pan-Indian network. So you can tell me any hospitals pan-India and I can say that we people are there. And our social support teams are there to hold the hand of the family from the date of diagnosis till the survivorship or till the family is briefed. And till this date, we are able to reach out to around 1,55,000 supported children. We are able to reach 142 hospitals. We are able to get 53% access by our doing the capacity building of the Anganwadi and the Asha workers in the remote areas of Uttar Pradesh, Bihar and the Madhya Pradesh. And by doing the state MOUs, we are able to reach 67% of the incidence of childhood cancer. And this is our leadership. It is started by these 2 ladies, Poonam Bagai and Sonal Sharma, and Mukul Marwa Sahab is our vice chair. And I am very much on the left-hand side. I have joined in the capacity of Deputy General Manager in 2013, and right now I am leading the organization in the capacity of Deputy CEO. So if you can, again, this is the statistics I have already spoken about. Now, how Cankids can help? We people have got home away homes. There are 17 home away homes pan India where we people are. How home away home is helping the hospitals? Because if the patient needs only daycare chemotherapy, the child can go back to our home away home and the child come back to the hospital next day for the chemotherapy. It is able to save 1 bed in the hospital and you are able to treat more and more patients in the hospitals. Then we have our pediatric palliative care. We have got a Subhita Pediatric Palliative Care Center in Delhi. It is a nursing home by Directorate of Health Services. It is 10-bedded hospital. It is run by a palliative care physician. There are 6 nurses. There are 2 nursing attendants. अभी तो मैंने शुरू ही किया. Cankids बहुत लंबा चलता है मेरे हिसाब से. But I will close down in next 2 minutes, right? So Cankids, we people are providing treatment support by providing blood support, by providing SD kits, and we even arranging the blood donation camps. We people are providing psychosocial services. We people are providing counseling services as well. And these are our partners, right? And these are the 9 state MOUs that we people have already done with the various state governments, and Madhya Pradesh is also there. So this is our MOU with the Madhya Pradesh government, where Additional Chief Secretary Sir was there, right? So this is our model. You are not alone. This is our model. You are not alone. From the date of diagnosis, our teams are there to hold the hand of the families. That is why we are saying you are not alone. And you can see the number of services we people are providing through our YANA model. Again, holistic care, what we people are doing, it is there. The statistics of Madhya Pradesh. I don't have the time, otherwise I will take another 10 minutes. Right? So level of support, these are our 2 projects. And this is the traffic light poster that we people have designed based on the WHO PAHO. Right? Red, yellow and green. If it is in the red, then the child is definitely has got some chances of cancer. In yellow, there can be, and cancer nahi, it means green. Right? So, thank you very much. I have given less time, I can say only this. Thank you very much. You can ask any question if you have.
It's a very nice, very impressive. I think we are all moved, and we are all, we wish that Cankids should grow further and further to benefit more and more people. I would just like to know how this home away from home model works. What
home away home model is basically, it is a model where the families are staying. It is a free of cost facility that we are providing. If the family is coming from a far off place, they does not have a place to live. So we are providing accommodation to those families. We people have got bunker beds. There are around 10 or 12 rooms providing bunker beds where the families are staying. We people are providing them the ration. There is a vehicle over there. The vehicle will take them to the hospital in the morning. The children will have the chemotherapy over there. Again the child is coming back to our home away home in the afternoon or in the evening. The child will stay there, and again next morning child will go to the hospital. So there are 17 home away homes right now we are operating in India. And apart from Cankids, there is an Intas Foundation who is running home away home. Then there is St. Jude's Child Care Center that is also running home away home. And there is one more organization that is also running home away homes in India.
Let's say a child needs a chemo like every 21 days. So this child will undergo his chemo, go back to his village or wherever he has come from.
Yes, in case the child needs any kind of support to go back to the hometown and to come back, we people are providing them support by providing them ticket, by providing them any small amount so that the child will come back to the hospital.
Okay.
Most of the time, out-of-pocket expenses are much more than the expenses child has to incur while doing the chemotherapy in the hospital. So we people are helping the families for that also. Okay. And Dr. Seema Das is here. She is one of our advisors. And Dr. Shalini Mishra is here. She is also one of our advisors for. And Dr. Manas Kalra will come later on. So thank you very much.
Thank you, Haresh sir. It's a wonderful presentation. I can say most of the patients in our ward, now the pediatric patients, are getting Cankids support with full heart. And because of the Cankids, we are able to manage such a quite good load of children with leukemias or lymphomas or other cancers also. Just one request, if you can make to your committee of doctors who advise the test, can you please include next generation sequencing into your panel of tests, because AML and ALL reflex panels are now really outdated. So this is one request from our side. Can you please make NGS inclusive in your panel of tests so that we can. Thank you, sir. Thank you.
Thank you, Cankids, for the Herculean task that they have taken up. Now it's my proud privilege to invite and welcome Dr. Narendra Patidar for the next talk. He'll be speaking on approach to retinoblastoma. He's a consultant, Orbit Oculoplasty and Ocular Oncology, Sadguru Netra Chikitsalaya, Chitrakoot. He did his PG diploma in ophthalmology from Mahatma Gandhi Medical College, Indore. and long-term oculoplasty fellowship from Sadguru Netra Chikitsalaya, Chitrakoot. He has authored about 26 publications and delivered presentations at various conferences. Welcome, sir.
Thank you. Thank you, kind invitation and kind introduction. At the outset, I would like to thank Dr. Srivastava sir for this opportunity and organizing team and Dr. N. Salma. So I will be talking about approach to a patient with retinoblastoma. No financial disclosure. As we have seen, it is the most common intraocular malignancy in children, and incidence in India we talked about in previous presentations, about 1500 to 2000 new cases every year, and which is about 1/4 of global burden of retinoblastoma. Male and females are equally affected. Unilateral and non-hereditary cases are common. Approach to case of retinoblastoma requires systematic sequence. We begin with presenting symptoms followed by detailed history taking and gross initial examination. Based on finding, we decide appropriate imaging, and for detailed anterior and posterior segment examination, we need examination under anesthesia, and then we group and stage the disease for appropriate treatment planning and prognosis. Now coming to the presenting symptoms, the most common presenting symptoms for retinoblastoma is leukocoria, which is seen in about 50% of patients. Second most common presenting symptoms is squint. Patient can present with reduced vision if it is involving the macular area or bilateral cases. Redness can be a presenting symptoms. It may occur when the eye is inflamed and under tumor necrosis, when there is ciliary body invasion, which usually indicates an advanced tumor. A child may also present with proptosis when the tumor extends beyond the ocular cords. This usually suggests extraocular spread and indicates advanced tumor. After assessing presenting symptoms, we take a detailed history including birth history to rule out retinopathy of prematurity. Any history of minor trauma causing vitreous hemorrhage and hyphema can mask the tumor, and we should be careful. A family history pedigree chart to 3 generations should be drawn to assess hereditary risk. Since the child may not be cooperative for detailed examination, we begin with torchlight examination to assess gross vision, look for proptosis. If child is cooperative, anti-segment examination can be done using slit lamp and operating microscope if available to look for leukocoria, a visible mass, and detailed posterior segment examination. Fundus evaluation should be attempted if possible. Depending on primary evaluation, we choose the appropriate imaging modality. If the media is hazy and fundus cannot be visualized, B-scan ultrasonography is used as an initial imaging. If diagnosis remains uncertain even after B-scan, a CT scan may be considered. However, the extraocular extension, to know the extraocular extension, we preferred MRI. On B-scan ultrasonography, we can identify an intraocular mass with calcification as shown in these images. The calcification appears as a hyperechoic foci within the mass, and corresponding A scan shows high spikes which is suggestive of calcification. CT scan usually avoided because the radiation exposure which can lead to which can increase the risk of secondary tumors. It is reserved for confounding situation where detection of calcification is essential, otherwise MRI is preferred. We can see in image there is intraocular calcification with optic nerve thickening. MRI is done to see extraocular extension like optic nerve and choroidal invasion, and in bilateral cases to rule out pinealoblastoma. MRI images show an intraocular mass that appears hypointense on T2 weighted images and hyperintense on contrast enhanced T1 weighted images. UPM is mandatory for anterior chamber seeds to rule out ciliary body invasion. Coming to the differentials, the diagnosis of retinoblastoma, we should consider other differentials that can present with leukocoria. There are many differentials, but 5 common differentials are CODS, PHP, toxokeresis, astrocytic hematoma, and medullopithelioma. I will go one by one. So CODS disease usually present with yellow reflex known as xanthochoria, and it is associated with intraretinal and subretinal exudation with telangiectasia. In these images, we can see typical xanthochoria in first image and bullous retinal detachment and peripheral dilated vessels with telangiectasia in second image. B scan is to be done to where we can see the exudative retinal detachment with retinal thickening. Next is the persistent hyperplastic primary vitreous, which is usually present since birth. It may show leukocoria, relative microphthalmos, cataract, and prominent ciliary processes. In the image, we can see fibrous membrane behind the lens with prominent ciliary processes. On B scan, a persistent hyaloid vessels or fibrovascular bend may be seen. Next is toxocaresis, which may have either anterior or posterior predominant disease. Anteriorly, it can cause spillover uveitis presenting with a white reflex, cataract, and postosynechy. Posteriorly, it may show a direct disc appearance due to vitreoretinal traction. Astrocytic hematoma, it is of three types: non-calcified, calcified, and mixed one. Calcification in astrocytic hematoma will be yellow translucent, while in retinoblastoma it will dull chalky white. Finally, we should keep medullophthalma in our mind as a differential. It is usually a peripheral tumor arising from ciliary body and can be associated with lenticular or zonular coloboma. In such cases, UBM is helpful to identify and confirm the presence of ciliary body mass. Coming to the masquerades of retinoblastoma, eyelid edema, chemosis, and proptosis can sometimes simulate orbital cellulitis. Because retinoblastoma is a rapidly growing tumor, it may outgrow its blood supply and leading to tumor necrosis and secondary inflammation. So in any child with orbital cellulitis or severe lid edema, it is imperative to examine the posterior segment. And child with uveitis should be considered to have retinoblastoma until proven otherwise. Tumor cells can pass through the zonules and seeds the anterior chamber, leading to pseudohypopion, as we can see here in image. It is hypopion without any inflammation. Retinoblastoma can mimic congenital glaucoma due to raised IOP causing corneal enlargement and haze. Therefore, any child with raised IOP or enlarged cornea, posterior segment examination is important. Next, masquerade is phthisis bulbi. Any child with unexplained phthisis should be taken seriously and imaging is mandatory. B scan or CT scan should be done to rule out calcification. In simple phthisis, calcification is usually peripheral and sclerocorneal, whereas in retinoblastoma it is intraocular. In this patient with right phthysical eye, CT shows intraocular mass with calcification. Next is masquerade is traumatic hyphema. In retinoblastoma, iris neovascularization can bleed even after minor trauma, leading to hyphema and masking the underlying mass. Any unexplained hyphema in child should prompt careful posterior segment evaluation. Now coming to the next step, examination under anesthesia, which allows a detailed or complete ocular examination. We need following instruments or equipment for during the EUA. So we need indirect ophthalmoscopy, 20D lens, tonopen for IOP measurement. We may need laser treatment for laser machine, cryotherapy. UA should be performed before every chemo cycle. During UA, we assess corneal diameter, measure IOP, examine the anterior and posterior segment in detail. Findings should be documented with color drawing and RETCAM images. Lymph node must also be examined, and the focal treatment like cryotherapy, TTT, or bone marrow incisive sampling can be done if needed. After detailed examination, next step is to classify the tumor. For this, we use both grouping and staging system. The ICRB grouping is used for intraocular disease, where the main outcome is eye salvage. The IRSS staging system is used for extraocular disease, where the survival is the key outcome. TNM classification include both intraocular and extraocular disease. This is the international classification of retinoblastoma, which include group A to E, depending on severity. So group E is a small intraretinal tumor less than 3 mm away from fovea and disc, as we can see in the image, red circle. Group B is tumor more than 3 mm macular or juxtapapillary location or with subretinal fluid, as we can see here in the image. Group C is tumor with focal subretinal or vitreous seeding within 3 mm of tumor. Tumor with diffuse subretinal vitreous seed, which is more than 3 mm from tumor, is considered group B. Now group E is important because in our settings mostly we see group E patient. So group E includes diverse variety of advanced intraocular conditions such as extensive mass occupying more than 50% of globe with or without neovascular glaucoma, hyphema, vitreous hemorrhage, invasion of tumor to optic nerve and antechamber, aseptic orbital cellitis and thysis bulbi. When eye salvage is not possible or tumor has spread beyond the eye, we use a staging system, international retinoblastoma staging system, which stages the disease from 0 to 4. 0 is patient treated conservatively. Stage 1 is eye is enucleated, but tumor is completely resected, which we can know by histopathological examination. Stage 2 is eye is enucleated, but microscopic residual is there on histopathological examination. Stage 3 is regional extension to orbit or lymph node. Stage 4 is hematogenous or CNS extension. So till stage 3 there is high chance of live salvage, more than 90%, but for stage 4 it is less than 5% chance of survival. Coming to the TNM staging system, it includes grouping and staging framework for retinoblastoma. T1 disease generally correspond to ICRB group A and B, while T2 include ICRB group C and D. T3 represent advanced intraocular disease as seen in ICRB group E, and it is further subclassified from T3A to T3E, and T3 is renal extension. T4 is renal extension, sorry. An important update in TNM classification is addition of age for heritable trait. This highlights the genetic basis of retinoblastoma and brings the genetic screening to the forefront of evaluation. By identifying hereditary disease, the classification emphasizes the need for family counseling, surveillance at risk relatives, and individualize the follow-up. Coming to the management, once we have decided the treatment based on grouping and staging, our aim is to follow a clear stepwise priority. First to save the life, next preserve the globe, and finally to restore or maintain the best possible vision. These are the various treatment options available. Depending on tumor grouping and staging, we may choose one modality or combine multiple modality to achieve best outcome for the patient. Coming to the focal therapy, it is used as a primary treatment for group A and selected group B tumors, for treating small tumors and for consolidation during chemoreduction with intravenous or intraarterial chemotherapy. The available focal therapy options include transpupillary thermotherapy, cryotherapy, and laser photocoagulation. First focal therapy is TTT. We perform transpupillary thermotherapy using diode laser with an indirect ophthalmoscopic delivery system. The laser induced hyperthermia lead to tumor cell apoptosis and destruction. Multiple laser spots are applied over the tumor. During treatment, we can see gray-white uptake, which indicates good laser uptake. And complications can be focal cataract or iris atrophy. Here we can see the laser machine displaying the treatment parameters along with fundus images. The first image on the left shows a mid-peripheral group B tumor. The middle image demonstrates immediate post-laser tumor whitening, indicating the adequate laser uptake. The last image from another patient shows flat and calcified scar after TTT, which was done as a during IVC to consolidate the tumor. Next is cryotherapy, which is primarily used for peripheral group A and small group B tumor. It can also be combined with chemocryotherapy as a chemotherapy to enhance the effectiveness of treatment by increasing drug penetration into the tumor. This technique involves triple freeze thaw cycle achieving the temperature nearly -90 degree, which induce tumor cell destruction. Complication can be large chorioretinal scar as compared to TTT, and there can be serious retinal detachment. So here are the fundus images of child with group B retinoblastoma. First image shows the tumor before treatment, while right fundus image demonstrates a flat chorioretinal scar following cryotherapy, indicating successful tumor regression. Laser photocoagulation, it is rarely used nowadays. It should be avoided as it can restrict the drug reaching to the tumor. Coming to the intravenous chemotherapy, it is most commonly used treatment modality in low resource setting. It indicates indication include group B to group D for chemoreduction, bilateral retinoblastoma, germline tumors, group E tumors requiring adjuvant chemotherapy, or orbital retinoblastoma. The primary aim of treatment is to reduce the tumor, and commonly used drug is vincristine, etoposide, and carboplatin. Globe salvage rate with intravenous chemotherapy is excellent for group B and C retinoblastoma, ranging from 90 to 100%. However, success rate is significantly lower in advanced group D and E disease, which ultimately requires radiation or enucleation. Treatment-related side effect can be significant, therefore careful monitoring is important. Here is the fundus images of patient before and after chemotherapy and TTT for consolidation. We can see the completely regressed tumor with flat and calcified scar. IC is standard of care in many developed countries. It is a fluoroscopy guided drug delivery directly into the ophthalmic artery. It ensures that the eye receives higher concentration of drug as compared to IVC with minimal systemic toxicity. Indication include non-germline retinoblastoma, unilateral tumor, recurrent subretinal vitreous seeds, recurrence after IVC or plaque brachytherapy. For group B and C, single drug melphalan is commonly used, while for group D and E, with massive seeding, high dose and addition of topotecan may be needed. Complications are rare. If we talk about the intraarterial versus intravenous chemotherapy, then both are equally effective for group A to C, but for group D and E, there is 15% higher chance of globe salvage with intraarterial chemotherapy. Coming to the periocular chemotherapy, used as an adjunct to IVC or IAC to treat subretinal or vitreous seeds when intraocular tumor is active. Commonly used drug is topotecan. Next is intravitreal chemotherapy. It is given for seeds when tumor is regressed or as a second line for the recalcitrant or recurrent tumor. It has high success rate for vitreous or subretinal seeds. Most common drug used in Asian population is topotecan. Intravitreal injection is given through pars plana route. We choose quadrant lacking seeds and need to rule out retinal detachment, vitreous hemorrhage, or anterior segment invasion. We follow safety enhanced technique to prevent extraocular tumor seeding. Adverse effect is rare with topotecan, but melphalan can cause RP changes in Indian eyes. Intracameral chemotherapy used for as a in primary or secondary antechamber seeds, and again the topotecan can be used for antechamber seeding. Coming to the radiotherapy, plaque brachytherapy or EBRT are commonly used technique for radiation in retinoblastoma. Plaque brachytherapy is used for recurrent medium-sized tumor after failed IVC or IAC. Iodine or ruthenium plaque are commonly used. One complication of radiation can be radiation retinopathy or papillopathy. EBRT is indicated in after neoadjuvant chemotherapy and secondary enucleation in orbital retinoblastoma, and after primary enucleation for group E retinoblastoma with histopathological risk factors. Coming to the enucleation, primary enucleation includes unilateral bed group E retinoblastoma, and as a secondary enucleation when extraocular spread regress after neoadjuvant chemotherapy or recalcitrant tumor. This was a patient with advanced group E retinoblastoma who underwent primary enucleation of right eye. MRI shows an intraocular mass in right eye, which we can see enucleated eye specimen. The post-operative images demonstrate the good cosmetic rehabilitation with well-fitted customized ocular prosthesis. Histopathological examination is essential to identify the high-risk factors for metastasis such as invasion of choroid, optic nerve, ciliary body, antechamber, and sclera, which helps determine the need for adjuvant treatment and predict prognosis. Histopathological pictures shown here of the previous enucleated eye in previous slide as I shown had prelaminar optic nerve invasion and did not require adjuvant chemotherapy. Few points about orbital retinoblastoma. Orbital retinoblastoma is classified into 5 types: primary, secondary, overt, microscopic, and accidental. It is managed with multimodal treatment approach consisting of 6 cycles of high-dose neoadjuvant chemotherapy followed by surgery, then external beam radiotherapy, and followed by 6 cycles of adjuvant chemotherapy. Prognosis is good with multimodal treatment and protocol-based management. It is about 90% life salvage is there. Last is about genetic testing. The gene has been identified and the disease is predominantly monogenic. Ideally, all cases should undergo genetic testing. genetic testing facilitates early screening and long-term surveillance in patients with germline mutation while helping avoid unnecessary examination follow-up in those with non-germline patients. To conclude, retinoblastoma is life-threatening but highly curable when diagnosed early. With a systematic multidisciplinary approach and early recognition of leukocoria, we can preserve life, eye and vision. These are my acknowledgement and thank you. Thank you for patient listening. Happy to take questions.
Thank you, Dr. Patidar, for such an elaborate, lucid presentation. The house is open if any questions.
I really liked your slogan, when it's white, it's not right. Is it your own?
Yes.
Excellent. Very nice.
Thank you, Dr. Patidar.
Thank you.
Now we welcome Dr. Seema Das. She is Assistant Medical Director and Director Oculoplasty and Ocular Oncology and Medical Education in Dr. Shah Charity Eye Hospital, New Delhi, India. Her area of interest is ocular oncology and the eye tumor, especially retinoblastoma, ophthalmological medical education. She is involved in the eye care education and teaching and training of fellow and residents since 15 years. Her topic is retinoblastoma management, recent advances. Welcome, ma'am.
Thank you very much. Many thanks to the whole team for this opportunity. It's a privilege to be speaking in front of this audience, and it's a learning opportunity for all of us when we talk to an audience which is not ophthalmologist mainly. I think Dr. Narendra has given a very comprehensive background of retinoblastoma and set the stage. He has covered almost everything, so I'm just going to touch upon what's new going on in most of those areas. Is it audible? Okay. Am I audible? Is it better? All right, so we have already seen the spectrum of presentation. White is definitely never right, but we have a lot of other ways in which retinoblastoma can present, and that's how many times the diagnosis tend to get missed. It can be, in fact, half of the patients can present not with a leukocoria, but with a cellulitis, proptosis, squint, and we have also seen from a recent study that the second most commonest presentation of retinoblastoma other than leukocoria was squint, and that was when most of the cases were getting missed and coming back at a later stage with advanced disease. So grouping staging, we all know how to classify the tumor. Grouping is basically for the intraocular, staging is for, it's much more broader when the tumor is already out of the eye. And we have various classification systems which guide us how to treat the disease, how to manage them. But the recent work is going on to redefine those classification systems, because no classification system is perfect. There is a need for evolving over a period of time. If you see a stage 0 tumor where the eye is saved and the tumor is small inside the eye, stage 1 where we have to probably enucleate the eye is pretty clear, and these are usually comes under the grouping category. Problem comes in the stage 2 and 3, which is pretty big. If the optic nerve is involved, if it is just the anterior part of the nerve or the posterior part or wherever, everything is included under stage 2 and stage 3. It can be an anterior extraocular extension, it can be a posterior extraocular extension, it can be an extension involving the whole of the orbit, but it's a very big chunk which goes inside stage 3. And we know, depending on the bulk of the tumor, the prognosis is going to be very different, and that's what we also practically see. So our current work is actually focused on reclassifying the stage 3 into further subcategories which might give us a better prognostic system, and it's work in progress. And all this is possible. Grouping staging is only when we see the child under anesthesia. So an EUA is an absolute must if we have to diagnose and properly group and stage a retinoblastoma patient, and that's something which all of us here should know. We sometimes tend to get patients where the chemotherapy is already started and the patient comes to us only for the focal therapy after 2 or 3 cycles, but since the baseline EUA is not available, we really don't know what was the group and the stage of the patient. Chemo can mask all the changes and we might lose the baseline staging. And it's not that we are not doing EUA. In the recent INPOC study does show almost 90% of the patients had a baseline EUA before the treatment was initiated, but I'm sure there are still scope of improvement in that area. Staging, again, Dr. Narendra has already given a very broad overview. RB is a very unique disease because this is probably the first cancer where hereditary has been included in the TNM staging system. So because the hereditary has so much of impact on the management and the prognostication of RB, that is an independent factor which has been included in the TNM. So instead of TNM, it's actually TNMH now. So where do we stand when it comes to kind of doing the TNMH staging? And this is again from our data from the INPOC study where 20 centers had pulled in their data. If we compare with the global data as well as Asian data, we are not really doing very well. Just about 6% of the patient had a baseline genetic workup done, germline workup done, sort of where the information was available. So definitely there is a scope of improvement and support in this area also. So if you see the outcome of management, global versus our data, if we see the outcome from the low middle income and the versus the high income countries, there is a stark disparity, and we know RB is one of the most low hanging fruits in terms of treatment outcome, provided we detect it on time. So the survival outcome in the high income countries almost is 100%. Sorry, it's a typo, it's not 14, will be 95, 94 in fact. But LIC and LMIC is not really doing very well if we see an average figure. Management is multimodality. That's one thing which actually complicates the data. The part which are highlighted are under the purview of an ophthalmic oncologist, and chemotherapy, radiation therapy, intraarterial is where collaboration is absolutely required. So this is one disease where so many people have to come together if you have to give a very good outcome. So I'll focus a little bit more on the ISC, plaque, intracameral, intravitreal, genetics, and the new advances on the biomarkers. We have already seen the classification system, and the treatment is usually based on the grouping and the staging of the tumor. And we all know that focal therapy along with systemic chemotherapy, as Dr. Narendra showed, is extremely effective in the management of this patient. In the focal, we have laser therapy and we have cryotherapy also. These are the two focal modalities which we use based on the location of the tumor, and these are very time-tested treatment modalities, nothing new in that, but this has stayed in place and has shown to be extremely efficacious if used judiciously. So that's where the ophthalmologist comes into the picture in the management. IVC, we know that VEC regime is a very effective regime again. For the group D and E, these are the problem areas where many a times we are not able to save the eye, but now with the intracameral and the intravitreal as well as ISC, the eye salvage in these tumors also have gone up. So I'll skip the video part of it. This is something which an ophthalmologist does, and there is a specific technique of giving the intravitreal injection, but given it in the proper dose and for proper indication, it is again something which has improved the growth salvage rate in the group D tumors specifically, from a mere 30 to 40% to almost about 75% now. And we are, the work is now going on increasing on a higher dose of topotecan. For Indian eyes, typically is the topotecan, which is very effective. We used to give earlier very low dose, 30 to 50 microgram, and now we are going till about 200 microgram without causing any significant side effects. It seems to be a very safe and effective drug. Anterior chamber seeding, the seeding might not be in the vitreous cavity, it can be in the anterior part of the eye also, and these are the tumors which are more difficult to treat. You see this tumor, big one, ISC has been given, the tumor has regressed, but this UBM does show those small seeds which are now lying there, residual seeds, and these are the problematic one. If you do not treat them, they are going to come back with a tumor recurrence, and this is one area which is a very difficult area to reach. So for that, what is done now is something known as intracameral chemotherapy, which is basically along with the injection, which is given in the posterior part of the globe inside the eye in the vitreous cavity, you inject the drug into the anterior part of the eye, in front of the iris as well as behind the iris. So behind the iris is the posterior chamber, what we call, and that's a very safe sanctuary for the tumor. No drug reaches that area unless we directly put the drug into that particular space. So with bicameral, we call it as a bicameral injection. With bicameral injection, even those eyes can also be salvaged a little bit more now. This is the same patient. We can see these tumor seeds lying in the posterior chamber of the eye, and with bicameral injection, those seeds have gone now and the tumor has regressed, and we could save this eye. Intraarterial, again, Dr. Narendra has shown the technique, and we all know what are the indications. That's a very commonly used drug treatment modality. Cost is an issue definitely in our setup. So if you see how we stand globally in terms of intra-arterial chemotherapy, in the high-income settings, this has become almost like a primary treatment modality for many centers, provided the technical expertise and the cost is not an issue. For us, at least in the data from this study shows that just about nearly 3% of the patient actually was offered primary ISC. And I think it's just the technical expertise availability as well as the cost, which is the limitation. Otherwise, in terms of indication, all group A, B, C, D, I are candidates for intra-arterial chemotherapy if we can manage it. I'll skip the video part of it. This is one of the patients where the ISC was done as a primary treatment modality without need for any systemic chemotherapy. And this is the picture after 3 cycles, good tumor regression. And all the macular area is free of tumors, so some vision can also be restored along with the salvage of the eye. This is a very good treatment modality for recurrences post intravenous chemotherapy where we have exhausted the IV. So, and these are the areas where IV chemo does not work very well, recurrence over a calcification over a scar, and ISC is a very good treatment modality for those eyes. So overall, if we see the group D is the eye which benefits the most. From 55 we have gone almost till about 80% with ISC, and our data does show even selected group E eyes also we can say save with ISC. So almost about 54% of the eyes which otherwise would have been enucleated with ISC, we could save those eyes. Absolute contraindication, these are the eyes which should not be going for ISC. Any eye which is ophthalmos, very high pressure, there is no visual potential, neovascular glaucoma, and there is a potential risk of optic nerve involvement on imaging. These are the eyes ISC is not recommended. ISC doesn't take care of the systemic metastasis, so we might land up with the eye getting saved but coming back with systemic mets. Plaque is another very good treatment modality, usually used as a second line treatment for residual or the relapsed tumor. Again, the good indication are post chemo reduction when we have a tumor which is very well localized to a particular area, and this is the typical tumor which can be salvaged with additional plaque brachytherapy. So this is the picture after about 2 years of follow-up. You can see the whole tumor is gone and the area is become a completely flat scar. So this is again one area where having collaboration with an ophthalmologist can help in saving many of those eyes. And now with the availability of the indigenous India-made, BRC-made plaques, the cost of plaque brachytherapy is actually come down very drastically than what used to be there earlier. So another child, peripheral tumor, recurrence over a scar where most of the treatment modalities are not going to work, and with ISC we can see the tumor is gone, it's almost flat scar. So this is our data, it's in the process of publication, but globe salvage is almost 84% with the use of plaque brachytherapy. But we have to be prepared with the sequelae, treatment-related sequelae, both with ISC and plaque. We might save the eye from the tumor, but sometimes we might land up losing the eye because of the complications of the treatment per se, which again needs a very close monitoring after the tumor is gone. So that's one area where again a regular UA by an ophthalmologist should be done. Orbital RB we have already touched upon, the chemo regime we have touched upon, but the problem is when it comes to the extraocular RB, there is a lot of variation in the regime that is used even in India. So there are centers who use a standard dose regime, there are centers who use a higher dose carboplatin regime, there are standard who use the alternative VEC, VDC regime. So which one is a good regime is something which we still don't know, and that's the scope of research, and I think there is a recent ICMR funded study going on specifically on this question, and hopefully at the end of the study we might get a good answer which is the regime which should be used for extraocular RB. But if we see the European and the Western setting, ERIT is the regime which is usually used for extraocular, they don't use the VEC, with good results as per the reports, and even in stage 4B some survival is reported, which is almost 0 in our setting right now. Enucleation has already been discussed. We all know the indication. Primary versus secondary is one area where there is a role of pediatric oncologists for chemo. And why is it important? Sometimes we see eyes where there is a very subtle optic nerve thickening here, the eye is slightly prominent. Doing in primary enucleation in those settings, there is a risk we might leave behind tumor if we don't get an adequate optic nerve stump. So it's a good idea to chemo reduce. We can see the proptosis which is gone now, and then go ahead and do an enucleation so that we can be very sure we are not leaving behind any extraocular tumor. Optic nerve stump has to be really long if you are doing an enucleation, and if we see this optic nerve, we can see appreciate this thickening of the nerve, Had we taken a small stump, we would have left behind residual tumor in the orbit in this area. So now that the tumor is still here and our stump is still here, so we still have a clear margin, and the prognosis can change very drastically. First line enucleation advice, at least in our setup, it's almost 20%, but the problem is moment you do a first line enucleation advice, compliance becomes a issue. They all tend to run away, and we all have experienced it. Treatment abandonment, at least in this study, was about 7 to 3%, and the most common reason was enucleation refusal. So we had a small study with some intervention a couple of years back, trying to see if we can, with some intervention, some financial support and other logistic support, can we improve the compliance. To our surprise, despite all kind of support given, the non-compliance still persisted in about 22% of the patient. It came down from 63 to 80, but it still persisted. So there is many other issues, the social, cultural beliefs, and many other factors which we have to work on simultaneously if we have to improve the outcome. Histopath again is extremely important to look after enucleation, specifically looking at the high risk factor. But if we see the studies which talk about the outcome of giving adjuvant chemo in high risk factor, just about 24% of the eyes probably are the suitable, or the eyes which potentially could have developed a metastasis, which we are preventing by giving a chemo. So 75% of the eyes with high risk factor still probably does not develop metastasis. So we need better markers other than histopathology to guide us which are the eyes which are actually high risk factor, and that's where there is a lot of work which is going on the role of biomarkers in retinoblastoma. Is it only the histopathology, or there is something else which decides that the tumor is going to behave very aggressively? So there are several biomarkers, and these are the current list. This list is something which is still not very concrete. There is work going on. But TFF1 is one of the factors. High expression has been found to be associated with poor prognosis. Other than that, there are separate copy number changes, other genetic changes also, which has been associated, but still we don't have a clear-cut answer. What is most, the maximum work which is going on now is on the cell-free DNA, which seems to have a very global application in the management of retinoblastoma. It can be done from the plasma, from the CSF. These are the two areas where retinoblastoma usually metastasize. If you see this child comes back with a group E retinoblastoma with a very subtle optic nerve enhancement in the proximal part. We give chemotherapy, the nerve seems to have shrunken very nicely. We do an enucleation at this point, but the child comes back few months down the line with CNS metastasis. The histopath was clear at this stage, so probably the metastasis already happened when the child had presented, which was not detected by the conventional imaging as well as the cytology. So a minimally disseminated disease, our conventional test might not detect, and that's where the role of liquid biopsy comes into the picture. And in our very small pilot study, we have found that those patients, the stage 3 disease without any obvious CNS disease, who had a positive liquid biopsy, CSF liquid biopsy at presentation, all of them eventually developed CNS metastasis over a period of time. So tomorrow it might help us in guiding, in instituting very early treatment if we can validate it on a larger cohort. So precision treatment is something which we know, and genetics is where there is a very important role. Genetic testing and screening, how is it important? Why is it important to have a genetic status of the patient? Because in RB we can't go and screen all the children, unlike many other diseases. It has to be targeted screening because the disease itself is so rare. So there is targeted screening can be done based on the germline status, sibling of the patients who are already has RB, or maybe the children of the patients who had RB when they were child. So if you see this child, small child, unilateral retinoblastoma, very advanced disease, other eye at presentation was absolutely normal. So we enucleated the eye, and since we knew the germline status, he had a germline mutation positive, we kept the child on follow-up, and after 3 to 4 months down the line, we see this small tumor coming up in the other eye. Had we not kept this child on follow-up, we would not have been able to pick up this tumor, and the child would have come back with an advanced disease. So in this stage, it can be easily treated only with focal therapy or laser, nothing else is required. And we must remember 15% of the unilateral retinoblastoma can actually be germline positive. It's not that only bilateral tumors, bilateral of course germline, but even unilateral 15% can be, this is the data from the Indian cohort, our data, and it is at par with the data which is reported worldwide. Another area is the prenatal testing, where genetic status seems to have a very important role. This family, the father had bilateral retinoblastoma, bilateral enucleation. This was the index case. This is the child for which the family came to us. We could not save one eye, other eye we could save. When he saw the sibling, the second sibling, she also had a bilateral small tumor, and she was asymptomatic at that stage. But since we detected her slightly earlier, we could save both her eyes One eye we could not save the vision, the tumor was in the macular area. Now this family, the mother was pregnant once again. We offered them sort of prenatal diagnosis, a CBS was done, and the child which was yet to be born was found to have the same mutation where the other two patients had. But they refused a termination, they went ahead with the pregnancy, but since we know that this child has a very high risk of developing the tumor, we did a very early UA after 2 weeks of birth, and we could pick up those very small tumors in the retina. So at this stage, we can just treat it with focal therapy. So prenatal, preconceptional counseling, prenatal diagnosis is an extremely important part. The last bit is precision treatment. Like any other tumors, RB is one tumor where there is scope of a lot of precision treatment. This is small tumor which can be seen by the eyes, which can be now picked up by imaging called optical coherence tomography. This is a common modality which otherwise ophthalmologists use, but the good part is that it can actually pick up tumor which is not visible to the even the naked eyes. So if you are able to treat it at this stage where clinically it is not visible, there seems to be nothing here, we can simply treat it at this stage and just the tumor is gone. And we can also monitor the scar post-treatment. There is nothing here, but down the line we see this bump which is coming up. This is basically an optical cross-section, just like histopathology. So we know that the tumor is coming back, but clinically looking, we probably would have missed this. So this is something which is probably going to help us, and in our cohort we have found that with the use of this precise diagnostic modality, the recurrence rate has come down from about 18% to about 10%, and this is the clinical recurrence which we are talking about. So to conclude, we know that these are the advanced treatment modalities. ISC brachy definitely helps in globe salvage, and probably with the availability of expertise, we'll be using more of them for many of our patients. Multimodal imaging is probably going to come up and help us in more precise diagnostic image-guided treatment of RB, and genetics, liquid biopsy is definitely where the implication is going to be beyond staging and diagnosis, but also in the prognostication and tomorrow maybe for treatment purpose. I'll skip this. Okay, this is the team which I wanted to acknowledge, and of course, Cankids and all other partners who help us help our patients. Thank you very much.
Thank you very much for the nice presentation with the special focus on intraocular chemotherapy, brachytherapy, and the genetic counseling and genetic testing. Thank you very much.
Thank you, Seema. It is my honor to invite Professor Ishan Patro. He is a distinguished neuroscientist and academic leader, and it is the pride of Gwalior that he established India's first university teaching department of neuroscience at Jivaji University, Gwalior. He has more than 30 PhD scholars who have received his guidance and has several research projects to his name. Dr. Patro.
Thank you very much, Dr. B.R. Srivastav, the entire team of organizers of this CME, and ladies and gentlemen. The National Academy of Medical Sciences advised me that I should be here and talking to all of you about the academy and also giving them a feedback how it all went through. I'm so happy to see such a good academically active and live population over here sitting and discussing about a very important issue of health issue in the country, the cancer. I'm personally very happy that of 7 patients from my family and friends that I knew, all of them survived. So I'm very sure that the country is going quite good, and it's not very alarming the way it is being shown, and there is a little gap between the numbers and what we really feel. Although we are being called as a developing or middle class, middle economic group country or whatever, but I am sure the medical science and medical facilities in this country is really going great, and in years to come we'll see very good opportunities in future. There'll be a small video after I talk for a few minutes, a couple of minutes, that will speak to everything about the academy. But I want to introduce you to the National Medical Academy, National Academy of Medical Sciences India, which is a autonomous body of Ministry of Health and Family Welfare, Government of India. It was established on 21st of April 1961 to promote medical science in this country, and I'm pretty sure the Academy has done a great effort in that. The first convocation was held on the 8th December 1963. We call it convocation because there we honor the people with the fellowship and things like that. So the best part of this academy is we have got two Bharat Ratnas, Dr. B.C. Roy and APJ Abdul Kalam, 10 Padma Vibhushans, 32 Padma Bhushans, and 96 Padma Shris as fellows of this academy. I feel really proud to be one of the fellows of this academy, and we have totally about 1,172 fellows all over the country, and 160 associate fellows, and 2,915 members, and 12 international fellows. There are about 24 annual awards on medical sciences that is being awarded by the academy, and fortunately, NAMS has been identified as a nodal agency for all the CMEs in medical science and biomedical research. And they've got a emeritus scientist program, so people like me who superannuate and done some good work, fortunately, get some more time to do work, although the Indian Council of Medical Research has got a better one, which I am enjoying now. There are young scientist fellowships. This is for the students sitting over there, and there are PG research fellowships and institutional networks of medical sciences there. And the academy also has got a very good publication. It's called the Proceedings of the National Medical Academy of Medical Sciences, which is now indexed and got a impact factor also. So I'll encourage all the young people to write into that. And I need not be doing that, but I would be very happy to know, because I have to report it. How many of you are members or fellows of this academy? Please raise your hands. So I'll request all my elder friends, all my colleagues sitting over here, to make an effort to become fellows and members of this academy. And the students particularly, I must say, you enjoy the different facilities available. And for the younger faculty like lecturers and interns and people who are in postdoc should now become members, so that gradually you become fellows of it, because fellowship is a very competitive thing in this. So may I request them to play the glory one. So please enjoy this as I join you there.
of Medical Sciences, India, focusing on NAMS Vision 2030. NAMS is pleased to share some of the important activities like membership, associate fellowship, and member of
So while you are enjoying these pictures, I would now request all of you to, when you go back home, visit the website of the Academy, apply for all the possible things that are there. Huge opportunities for young scientists, younger doctors here, medical scientists here. And I would request all the senior members sitting over here to do try and be a fellow or a member of this academy. This is a very competitive one. I wish all of you very good success in this. And I must say at the end, this is a very wonderfully done CME. And I request all the senior people sitting over here to do more such activities in your own places when you go back home, or I can request Professor Srivastav to do more of such things here, and AMS would be very happy to support these activities. All the best and enjoy. Thank you.
Thank you so much, sir. I would like to thank our esteemed chairperson for providing such good guidance throughout the session, and also wanted to thank the session speakers for giving such insightful session. Now I would like to request our chairperson and our session speakers to join us on stage for group photo, and B.R. Srivastav sir also. Sir, please. Session speaker Dr. Anil Sharma sir, Dr. Haresh Gupta sir. Thank you so much, everyone. Now we proceed to the next step of this session, which is a panel discussion. And I would like to invite respected moderator, Dr. Ankita Jaiswal, ma'am. Ma'am, please join us on stage. ये लगना ना
Good morning, everyone. I would like to invite my panelists on stage. Dr. Sudha, Dr. Vinay, Dr. Shweta, Dr. Sanjeev, Dr. Ashok, and Dr. Pankaj. Please join me on stage. So, good morning, everyone, and I thank the organizers to have me here. It's my first time in Gwalior, and use these conferences as an opportunity to meet many of my clinicians whom I keep talking to on a very day in, day out basis, and I get to see the faces behind those voices. So the topic for today is approach to pancytopenia, art of bone marrow examination. And this is a panel discussion, and we've structured the talk in a way that I'll be talking just 4 cases. So we have 20 minutes time. We'll try to wrap up 1 case in 5 minutes each. And let's begin. So case 1. This is a 19-year-old male who has severe pancytopenia, and the patient has fatigue, gum bleeding since 6 weeks, no organomegaly, absence of fever and B symptoms, and no medications or toxins that one knows of. A hemoglobin of 5.2, WBC is low, 1.1, ANC is very low, 0.4, platelets is 12. The peripheral smear showed pancytopenia, no blasts, no dysplastic forms, and no parasites. So Dr. Shweta, we begin with you. What is your differential diagnosis?
In the absence of splenomegaly, we have almost ruled out any parasitic infections, infestations, etc. So what I feel, this could be a case of, it could be anything, of course. Early leukemias, we have to think, because that is the commonest, if you think about the commonest cause. So always keep it in mind, because it is a young patient. Of course, splenomegaly is absent, and we should look for a sternal tenderness and other lymph nodes if they are inflamed, if they are enlarged and all that. But definitely it could be a case of not a congenital, but another drug-induced pancytopenias are very common in our society, much less recognized. And as a clinician, over the years, I have been observing that the incidence is probably increasing day by day. And one thing which I personally feel is that the overuse of antibiotics and analgesics, that could be another possibility. And of course there are many, but then we have to go for the bone marrow and then find out whether the defect is in the bone marrow or it's in the periphery.
So absolutely, I agree with the one important differential would be a subleukemic or aleukemic leukemia. Another I would think of is aplastic anemia, because there is pancytopenia, no organomegaly, young male. And the other things, we do have a history of absence of medication and toxin exposure. So let's have a look at the peripheral smear and the bone marrow aspirate. So Madam Dr. Sudha, please highlight that what do you see in this?
Actually, I would like to add one more differential to that, if you allow me. Megaloblastic.
Absolutely.
Because, but then see, your reticulocyte doesn't go along with that differential, but then in our setup, we always have a pancytopenia come up, and then you do maybe the periphery may not be looking like this, but then you will definitely find a megaloblastic anemia coming up when you do a marrow.
Absolutely.
So that's one more differential I wanted to add.
Very true.
But then here, when you look at the smear as such, there are so many microcytes, and then you can see those macrocytes which have no central pallor. So it's a sort of a mixed type, and then there are some teardrops, and some of the cells have really, they are like pessary cells, So it's a mixed type of a smear. And one thing which is very striking is absolutely no WBCs.
Right.
No WBCs. So let me finish off with the RBC range. And there is, you don't find, for this amount of anemia, you don't find any polychromatophilia at all. So that is one more striking thing in the peripheral smear. And the second WBC picture, of course, there is absolutely, in this particular field, I'm not able to see even one leukocyte. And then obviously, the platelets are very low. So accordingly, when I'm seeing the marrow, again the marrow is full of it's a 19-year-old, mind you, and the marrow is full of fat. And I don't know, at this particular level of magnification. I can't say what are the precursors, but then there are some cells which are there. But the fat is very striking. For a 19-year-old, I expect more of
So
the
we'll enhance the
precursors.
magnification
Yeah.
for you.
Yeah.
And these were some more pictures of the same case.
So obviously, so you don't see, if you all agree with me, you don't see any precursors at all. You see some, there are some plasma cells. If you see those cells which have that eccentric nucleus.
So, agreed.
You're seeing some plasma cells and probably some mastocytes. That's all. That's and predominantly it is full of fat, mature fat cells. So that is what I can see from here. So for that age, 19-year-old boy, I don't expect this as the marrow.
So we move on to the biopsy. Please
Yes.
go ahead and you
Yes.
can.
So one thing is, in such cases, biopsy is very important for us to rule out. Now that we have seen that the marrow in a 19-year-old is full of fat, so now I have to confirm it with always a trephine biopsy. So we have a beautiful trephine biopsy here, and if you can see that high power, I don't see any cells at all. You see the trabeculae and that the paratrabecular region. If I think if it is, it's not a malignancy, it's not any infection, I should be seeing some cells, which is going along the trabeculae, which is absolutely, empty, and it's only having these fat cells there, and I can see some cells there, maybe just close by that trabeculae. Maybe they are the precursors at this level. Again, I cannot see them.
So yes, of course, there were lymphocytes and plasma cells, some residual, and very few erythroid colonies.
Yes. So this basically could masquerade as only an aplastic anemia. Now it's remains to say that what exactly it is.
So I would like to emphasize at this point with the description of pancytopenia, particulate marrow having fat-rich marrow spaces, and a bone marrow biopsy which is in sync, where we have to predominantly look for blasts. We have to exclude that there are no blast clusters or dyspoetic megakaryocytes, and we have almost come to the diagnosis of aplastic anemia. So Madam Dr. Shweta, what ancillary test would you order now and why?
Go in for a little bit of genetic testing. I'm not really remembering the exact genetic tests, but that would really clinch the diagnosis. And of course, we should keep the patient also on follow-up. And like Madam pointed out, that a lot of nutritional causes are also known. I mean, just for a minute, if we think it's not aplastic anemia, and we think that maybe there are a lot of megaloblasts, etc. So we can go for B12 levels, etc. And that should help us.
Sure. So I would like to add, in bone marrow biopsies, if we are very confident that they are fat-rich marrow spaces and the cells are just lymphocytes, plasma cells and erythroid precursors, then if it's a resource-poor setting, then we may just leave it there as aplastic anemia. But if the patient is financially stable, we should definitely order immunohistochemistry, be double sure that CD34 and 117 positive blasts are less than 1%. 117 will highlight some amount of increased mast cells. So that is to be kept in mind. Your lymphocytes are usually relatively increased. So CD3 and 20, which highlight the T and B lymphocytes respectively, will be there in a scattered pattern or maybe a nodular aggregate, but in a reactive ratio. That is 3 is more than 20. And usually on CD61, either it's no megakaryocytes or a rare megakaryocyte. So along with this, we should go for PNH screening in patients of aplastic anemia, and our patient had clone in all the 3 cell lines, RBCs, neutrophils and monocytes. The cytogenetics came back, the karyotype was normal. There was no MDS defining cytogenetic abnormality on FISH. So FISH panel for MDS is important. And all the parameters that Madam had suggested, B12, folate, TSH, HIV, hepatitis, they were all within normal limits. So we did not identify a secondary cause, and we did have an absence of history of drugs and toxins and medication. So I ask my next question to Dr. Vinay. Now the patient has been referred to you. What is your diagnosis? How do you classify this? And what is your management?
So this is most likely acquired very severe aplastic anemia. If we can also get chromosomal breakage studies done to see there is, although there is PNH clone here, but sometimes we may get it done. And then the classification would be very severe aplastic anemia. What was the
The ANC was it was just severe, yeah.
Okay, severe aplastic anemia. And management plan, of course, would depend on whether there is a matched donor or not. For those patients who are who have acquired aplastic anemia less than 40 years of age and full matched donor, the treatment of choice is matched sibling allogenic transplant.
Right. So one important thing as a pathologist that we have to remember is hypoplastic MDS is the most important differential and often ignored. Your erythroid colonies do come in the bone marrow biopsy. So that's a very important teaching point as a hematopathologist I would like to share. The reason is these erythroid colonies and your blastoid colonies can look very alike, especially when there is some megaloblastic reaction. So please do not take it for granted that these would be erythroid and you don't do your CD34s. Please go ahead, reconfirm. If you are not sure, you want a billing, write atypical, get a billing, and then only once you are 100% sure that the blast clusters are not there, then label the patient as aplastic anemia. Because on bone marrow biopsy, your MD is, the megaloblast is really similar to your blast. Another question I would like to ask is, if the patient had monosomy 7, would your management change?
Yes, it straight away becomes hypoplastic MDS with very bad outcome if not treated with bone marrow transplant.
So that is another learning point that we learn, that we must especially look for monosomy 7 also. So that wraps up our first case. So we have understood pancytopenia, one important differential of megaloblastic anemia versus aplastic anemia versus hypoplastic MDS. And in megaloblastic anemia, I think all of us have seen it from right from our MBBS and MD days, that you will have very hypercellular marrow with lot of erythroid hyperplasia and megaloblastosis. So it's very different, the look and feel of the biopsy and aspirate as compared to your aplastic anemia. I would also like to highlight my personal experience. Sometimes you get a lot of aspirates and you don't get the biopsy. And what happens is your hot pocket has been aspirated on the bone marrow aspirate. So hot pocket is the cellular foci which are still left in a case of evolving aplastic anemia. Now when you look at the aspirate, it is fairly cellular. You may not have megakaryocytes because they are the first ones to disappear in aplastic anemia. But you may continue to have a good number of megaloblastic erythroid precursors. And if the clinical picture of pancytopenia with no organomegaly may be the same. And we have ourselves committed this mistake more than once, that we've reported as megaloblastic anemia, and when the biopsy came and we got the full picture, the full length, it was very hypocellular and it was just one focus where actually the needle had struck. And that's why, as a pathologist, I will request my clinicians, always biopsy will take 3 to 5 days more. But in aplastic anemia especially, I would say that please hold on for the biopsy, because then the patient will get confused. Where one place you are reporting a normocellular marrow with megaloblastic erythropoiesis and one place you will end up reporting aplastic anemia. So that correlation is also very important, and hence highlighting that in pancytopenia, now as a practice I will say almost always bone marrow biopsies as essential as a bone marrow aspirate. They really go hand in hand. So next case is a 52-year-old male who had vague abdominal discomfort, weight loss since 3 months, pancytopenic picture, hemoglobin 8.1, WBC 2.2, monocytopenia was also there, platelets were 68, and LDH was slightly raised, 420. The patient had massive splenomegaly and lymphadenopathy was absent, but bone marrow aspiration was a dry tap. So Dr. Sanjeev, if I may ask, what is your differential diagnosis?
This triad of massive splenomegaly with dry tap and monocytopenia, it is classically seen in hairy cell leukemia, but we should also take in consideration bone marrow infiltration by other leukemias and lymphomas, particularly Hodgkin's lymphoma and myelofibrosis and hypoplastic MDS.
Right. And I think I would like to add primary myelofibrosis also to this category, or post-CML myelofibrosis which went undiagnosed. Because monocytopenia could be just a part of the whole leukocytopenia, and we have a massive splenomegaly with dry tap, then MPNs also become an important differential, especially PMF and post others myelofibrosis. So if you have dry tap on aspiration, again the same point emphasis is that trophine biopsy is mandatory. So that is, in yesteryears most colleges did aspirations only, private practitioners did aspiration only, but today I think everybody has switched to a combination of aspiration and biopsy. So we got the peripheral smear and a touch imprint. There was a dry tap, so we got touch imprints made. So could you describe it, sir, for us?
RBCs are normocytic, normochromic and normocytic hypochromic, and there are few mononuclear cells with indented nuclei and moderate amount of cytoplasm with hairy projections, and there is also thrombocytopenia. And in others, in the second slide, the low power lower magnification is these are the seen on lower magnification.
So actually this was slightly lower magnification, but if one could appreciate, there was more cytoplasm with hairy projections, and there was very pancytopenia, but this occasional hairy cell could be appreciated on the peripheral smear. In the biopsy, what would you like to say?
In hairy cell leukemia, bone marrow involvement can be focal, interstitial or diffuse. In this case, we see interstitial infiltration of marrow by hairy cell leukemia cells, and megakaryocytes are barely seen, and normal hematopoietic cells are also not seen. And in the and on higher magnification, we see well-defined nuclear borders and cytoplasmic borders with the perinuclear clearing, producing fried egg appearance, which is characteristic of hairy cell leukemia.
So yes, there was this typical fried egg experience, egg appearance that we should not forget. And so I think we've already revealed the diagnosis that this was looking like a case of hairy cell leukemia. Would you like to get a BRAF V600E mutation done here, Dr. Vinay, and why?
Yes, because it is virtually diagnostic of hairy cell leukemia, and it would differentiate this from other DDs, variant hairy cell leukemia.
Right. So we'll move a little quickly. So the flow cytometry was very typical in this patient. 19, 20 and 22 were positive, the typical B cell markers, and then the hairy cell markers 11C, 25, 103 and 123 were positive. And the BRAF was detected in this case. So does your treatment change with BRAF, doctor?
Mainly when it is hairy cell leukemia, BRAF positive, the treatment would be of classic hairy cell leukemia.
All right. So how do you treat these patients for the benefit of the...
So the treatment is very peculiar. There is a drug called cladribine. It is given continuously with infusion over 7 days. And the beauty of the disease is once it is cured, it usually never recurs. So it's just one-time treatment.
So for the audience, we would like to highlight that as pathologists, you have to differentiate your hairy cell leukemia from your other mature B cell neoplasm, because here the treatment is going to be different. So you can't leave your clinician hanging that it is or it may not be. So Dr. Sahai, if this patient comes to you first, what would you be your working diagnosis before the biopsy?
Considering the massive splenomegaly, my first diagnosis would be CML, because it fits into the bimodal pattern and of incidence, And definitely I would like to look for sternal tenderness, etc. And thinking about the TLC count, which wasn't really raised. So that could be just, one of the precursor findings could be possible. But first diagnosis would certainly be CML, because one important thing, it's the most common type of blood-related malignancy which we have in our society.
I think, but we did rule it out because of the.
We have to rule it out, exactly.
Yes. Thank you. So I'll just rush through the third and the fourth case in want of time. So third case was a known case of MDS, a 67-year-old, and the interesting fact was that now the patient had 8% blast, and then the last time when he had come to the lab, he had 4% blast, female, sorry. And we did have these peripheral smear showing these kind of neutrophils. So Dr. Pankaj, please, could you briefly describe this picture?
As per your history, you already told patient's symptoms are, I think, progressing. Patient is requiring repeated blood transfusion. So clinically, patient is progressing, I think, and this bone marrow shows, you can say in the first photograph, this is a hypolobated neutrophil. You can see pseudo-Pelger hue anomaly. And the second photograph shows a lot of erythroid cells, which are showing dyserythropoiesis. You can see binucleated erythroid cells and all. And the third one is, I think, dyspoetic megakaryocyte.
Yes, so we did
these are a lot of multinucleation in the megakaryocytes, a lot of cytoplasm having granules. And last photograph probably shows a blast, few blasts.
Yes, it did. And this was the biopsy which nicely highlighted the blasts and dysplastic megakaryocytes along with the megaloblasts.
A lot of CD34 positive cells.
Yes.
I think, no?
So when we did the count, it was 18% and not crossing the 20% threshold.
So how do you do these counts on, like, is there
so the right way to do it is we first scan the whole slide. If all these areas are okay, then we can take random 2 to 3 areas and do the count. We do it in oil on an IHC slide also. And if there is a marked difference, sometimes we do find a lot of variation. Then the right way would be you take 2 low count areas and 2 high count areas and then take an average.
I think in coming future, a lot of AI algorithm will be developed for this.
Yes.
Maybe.
So then the ancillary was supportive of MDS with the mutation of TP53 and ASXL1, and the IHC also showed increased blasts. So we'll keep it as the last case only. And the aspirate, interesting question here is that if the aspirate is showing 11% blast and your biopsy is showing 18% blast, what do you do?
I think, as you said, bone marrow is already having the higher percentage of blast. So we will go with the flow cytometry, as well as we want to test for further that NGS panel to see additional any abnormality on the cytogenetic ground to see whether.
Right. So here the take home was that you report both separately maybe, but for a clinician I think it will be the higher count which matters to them, and they will take their treatment decisions based on the higher blast cell count. And you have to remember as a pathologist that it is okay to have discordant counts on your aspirate and biopsy because of the fact of hemodilution on your aspirates. So thank you. We'll wrap it up. Yes, please, sir. Actually, there was one more case. That's why it's okay. I'm so sorry, sir.
Okay. Can we have one more case? If you have time? 2 minutes? Okay.
So I'll wrap it up. So the whole thing is that this was about pancytopenia. So while the talk we heard of so many topics, that was megaloblastic anemia, the most common. Here was another nice case of HLH that I would wanted to show, and on both on the aspirate and biopsy. And the key takeaways would be that cellularity matters, context matters, and therefore without picking up the phone you cannot decide. Aplastic anemia versus MDS is very important to differentiate between with PNH and cytogenetics. Dry tap always demands biopsy, but I will say biopsy is not optional, and blasts must be counted and correlated. So don't do eyeballing, count your blasts. So thank you. And HLH is a hematological emergency. Thank you so much.
Thank you so much, ma'am, and sorry for wrapping it up so early.
I'll request all the panelists and moderator to please join us for a photograph.
I request next session chairperson, Dr. Dinesh Bhurani sir, Dr. Ankita Jaiswal ma'am, Dr. Om Prakash Jatav sir and Dr. V. Jalas sir to join us on the stage for next session.
चेयरपर्सन वाली स्लाइड ये
I would like to invite Dr. Shweta Pathak for the next topic. She is a pediatric hemato-oncologist and BMT physician, and it is my pleasure to have her here. Her major achievements include established pediatric hemato-oncology units across the State Cancer Institute, Jabalpur. She has established a pediatric BMT unit in Madhya Pradesh, pioneered thalassemia and sickle cell transplant programs under government support schemes, awards and recognitions to her name. So, welcome.
Good morning all. Thank you respected chairperson for a nice introduction. I can see a variety of audience here, the postgraduate, seniors, hematologists, oncologists. So I would like to be very comprehensive. So my topic today is acute leukemia. So the epidemiology which has already been discussed earlier, etiology, the clinical feature, few cases which we have dealt with, and diagnostic workup, and the last management. So though acute leukemia looks very, very simple to all the postgraduate, see I am focusing on postgraduates because you are the target audience, so that in future we don't miss even a single child with suspected leukemia. So please, this is going to be your exam question also. So I just want to teach you like so that you can just write the exam paper and then you can treat the patient well. So childhood leukemia, it is one of the most common pediatric cancer, comprises of 25 to 40% of childhood cancers. 60 to 85% of all leukemias are ALL. So you have two types of leukemia. One is acute lymphoblastic leukemia and the other is acute myeloblastic leukemia. So acute lymphoblastic leukemia is more common. Incidence is increasing day by day. In the last consensus only we found total around 40 to 50,000 children in across the country, and around, if you take 40 to 50%, around 20,000 children are with acute leukemia. So the burden is not less, it is more and more, and the beautiful thing is it is very much treatable. So acute leukemia is a malignant clonal disorder. Precise etiology is unclear, but for each and every cancer, this is known that there is an imbalance between proto-oncogene and anti-oncogene. So there are some genetic syndrome which predispose a person with, with certain disorder for leukemia, like genetic syndrome, Down syndrome, Fanconi anemia, neurofibromatosis, Klinefelter's, Cosman syndrome, and so on and so forth. So whenever you see a patient with leukemia with some atypical cell, with some abnormality in peripheral smear, always keep a high degree of suspicion. Then other risk factors are ionizing radiation, which increases the risk by 5 times, siblings again increases by 2 to 4 times. That's the reason whenever we check the patient with leukemia, we always ask for the family history. That is very important. So the common clinical features are fever, which is one of the most common. Around 70 to 90% children will present with fever, but there is some 10 to 20% chunk which do not present with fever. Then pallor, again a common finding, bleeding manifestation, they have petechiae, bruise, purpura, multiple bleeding episodes, hepatosplenomegaly, lymphadenopathy, bone and joint involvement, loss of appetite, weight, seizure, testicular swelling. So these are the common presentation which we all see. Testicular swelling is something which sometimes we miss. So whenever you have a child with leukemia, always check for the testis. Now coming to the interesting part, which is case scenario. So this is very common in your practice, so we'll go one by one. One is the common presentation, the other is which is difficult and little tricky. So first, this is a 4-year-old boy presented with 4 months fever on and off. There is lymph node, petechiae, hepatosplenomegaly, hemoglobin is 6 gram, total count is 64,000 with 90% blast, and platelet is 24,000. So it's very typical that the count is very, very high, and you're seeing blast on the peripheral smear. So my message is, when you have so much high count in a small child who's sick, I think even with peripheral blood, you can see the blast and you can send the blood for flow cytometry. So you don't need to do a marrow in such cases. When you have peripheral blast percentage that high, just take the peripheral blood and send the sample for flow cytometry. Flow cytometry is a must. So if you do not have facility for flow cytometry, please do not do a marrow or do not attempt it, because it is very invasive investigations. Once you do it, and if you don't do the proper molecular cytogenetics and everything, you're going to miss the case. Because not just the flow cytometry to categorize between B cell leukemia, A cell leukemia, T cell leukemia and another leukemia, but molecular and karyotype is equally important, because this is going to help you in your risk stratification. So we are not living in an era where you just have to diagnose the case and dump it. You have to treat the child, and all your risk stratification right from day one, even your therapeutic measure, all depends on the molecular and karyotype. So if you have diagnosed a case of leukemia, and if you miss BCR-ABL positivity or some other high-risk molecular test, then we will not be able to start the imatinib at some important drug on time, and we'll miss the case. So it is always important to not just send the blood for morphology, you have to send the blood for flow cytometry, molecular and karyotype. So each time take 4 sample, at least 2 in EDTA vial, 1 in a parent vial, and 1 more extra sample. Then, 6-year-old female, fever persisted on and off for 3 weeks. This is next case. No obvious focus of infection. So whenever you have a fever going on for many weeks, always focus on CBC. One more key message. Just don't look at the fever and think about enteric fever, dengue fever, XYZ, malaria. See the CBC very clearly. So you see the pattern of the thrombocytopenia which is going on, worsening. Then always see make a chart of differential. That I always used to say my postgraduate. So when the fever is not going off, just make a chart of CBC. Don't just write hemoglobin, total count and platelet. Always write total count in terms of differential count, neutrophil and lymphocyte. So on day 1 your total count is 4,000, lymphocytes is 40-50%. Next day I'm sure it will be 3,000, lymphocyte will be 70-80%, and on day 6-7, by day 6-7 the lymphocyte will go up to 90%. So but still you are in early phase of standard risk. So don't miss this window period. Always just don't look at the fever and other things and rule out the basic infection. Just see the serial CBC, your job is done. So you don't have to do a higher investigation. Keep a high degree of suspicion, keep a close watch on child, look at the liver, spleen every day, see the node. But lymph node, liver, spleen, it goes on enlarging in a little later time. Initial phase, when the blasts are compact in the marrow, you will not see the organomegaly and lymphadenopathy. What you see is pancytopenia, and your job is to detect the case in that pancytopenic phase, because that makes a difference. If you diagnose the case early, the induction phase is going to be smooth and the prognosis is going to be great. So it is very important to see the CBC and keep a close watch on CBCs. Okay, so this is how the case used to be missed. 3 weeks the child was kept on, they were evaluating for fever, focus was not found, child was on broad spectrum antibiotic. 3rd week the child became irritable, pallor, everything became evident, and now this is a clear picture of acute leukemia. So this was a pre-B cell ALL. Then the 3rd case scenario, a 10-year, again very interesting case, very, very important for a pediatrician and for anybody, the postgraduate who are working in pediatric, general pediatric ward and diagnosing ITP day in, day out. Please remember this case. A 10-year-old child presented to local doctor with petechiae, bruises, epistaxis, so clear-cut bleeding episode, low-grade fever, coryza, Child was quite well looking, which usually don't happen with normal WBC count and isolated thrombocytopenia. So here you have isolated thrombocytopenia and there is no organomegaly. As I said, in early stages when the blasts are compact in the marrow, they are not infiltrated the peripheral circulation, so you would not see the organomegaly and lymphadenopathy. What you see is only the mild low count thrombocytopenia, because first class of cell which is affected is platelet. So platelet will be low. In any child who is having suspected leukemia, your platelet is never going to be normal, that is for sure. So platelet here is severely low, whereas other cells are fairly normal. So the child, unfortunately, I am saying unfortunately because this happens most of the time, that the children, they go to the peripheral doctor, they just think that it is clear-cut case of ITP without ruling out the other possibility, and they start the child on steroid. So the message here is, do not, if you are working in a tertiary care center, if you you want to start steroid and ITP, please do a marrow. It is very, very important, because marrow is for us, it's just like taking a sample, the blood sample. So it's very easy investigation. Please learn it well, do a marrow, and then you can start the steroid, so that you at least don't miss a case of leukemia. What happened in this child is, it was missed, not done, steroid was given, child went home, because we use steroid even in leukemia also. So you, even with 1 or 2 doses of steroid, your blast goes off and the child started feeling well. So we feel that even platelets start improving. So we thought that the patient is improving, and then we sent the patient home after 4-5 days of steroid. Child went home, and 3 weeks later he came to us with this hemoglobin of 6.8, WBC 1,20,000. All the peripheral blood is filled with blast, and platelet went down to 16,000. So this is what happens when you miss the case in the initial stage. Within 3 weeks you have changed standard risk ALL into high risk ALL, and you don't know what are the problem with this. The child is now at this point of this thing, he is at high risk of TLS, which poses him to even the risk of death is there due to TLS itself. And then bringing the child into remission and getting good prednisolone response, again it takes longer time for us to get the child into remission. So everything goes opposite. Okay, so once it is poor prednisolone response, they are high risk. So simple case of standard risk ALL has been converted into high risk ALL, just with one mistake: we did not do the marrow before starting steroid. So this is very important message, please do that. Then detailed study of peripheral smear is a must. So even if you do not have, if you don't want to do marrow right away, please see a peripheral smear properly. You could see pseudothrombocytopenia, EDTA causes clumping of platelet, acute, some atypical cell, if there are no fresh, clear blast, at least some atypical lymphocyte you should see, and ask a senior pathologist who's there around to see the peripheral smear at least. At least he could guide you that what he's actually thinking of, because you could see some clues on the peripheral smear itself. Then another interesting case of GRA, many times this is also missed. 5-year-old girl presented with joint pain, left knee, ankle limping, malaise, lethargy, poor appetite, 1 month. See, because in GRA there is no clear-cut definition. Okay, the joint pain for more than 6 weeks, age less than 16 years. So we just fix with, this criteria is fixed into our mind that we just think, okay, joint pain, no other cause, it is GRA, and start steroid. That is absolutely wrong. That should never be done. So whenever you have a child who's having pain, so just don't look at the joint. There is a difference between pain in leukemia and pain in GRA. So usually here your bony pain will be more marked. Whenever you touch the sternum or the distal extremities, they will feel pain. Okay, so don't just look at the joint, just touch the extremities as well, so that you can differentiate between the two. So here in examination, the movements were restricted, the pain was not localized, X-ray was normal, ASO titer is negative, and in GRA also you have a category where RA factor is negative, everything is negative, still the people are diagnosing this as GRA. So do not miss this diagnosis. ESR is high, so GRA versus RH fever they were thinking of, and started the child on aspirin, fortunately not on at least steroids. Referred as GRA, not responding to NSAID. This is a very beautiful case report where they have seen, which I was telling you, that serially when you see the CBC, you could see the fall in WBC counts, here 4.7, 4.3, 3.9, 2.8, and then you could see the rising lymphocyte. They have not written, but there would be rise in lymphocytes, and the platelet will be on the falling trend. So you have to see the trend, which is very important. Then the last case, 4-year-old boy, hemoglobin, here the child presented with anemia. Again, another important clue for us. So hemoglobin dropped from 9.4 to 5.8, low grade fever on and off, dimorphic anemia. Again, very important point, because whenever you have biphenotypic anemia, adolescent patient or young baby, what we think of megaloblastic anemia. So please, very important point is history is very important. Megaloblastic child presenting with bicytopenia, look at the typical dietary history. They were very peculiar with their diet. You could see the hyperpigmented knuckles, and the child, they will be walking on to your clinic. They'll be absolutely normal. They would say just little fatigue, they are feeling nothing else. Whereas a child with leukemia, they will, just by look, they look very, very sick. So by look also you could diagnose just by going with the dietary information, the fever and overall pattern. So it is not just the lab-based diagnosis, the CBC based, it is overall diagnosis of your clinical history, the examination and the lab report. So everything should be seen together. You cannot see them separately. See the child, take the history properly, do the examination properly, do the lab test and correlate everything. That is the key of success, and that is the key for early diagnosis. So this child was treated with iron supplement, B complex, folic acid, did not improve, liver 2 centimeters, spleen just tip was palpable, no bruises taken, referred for anemia. And then the clue is the lymphocyte, 85% lymphocyte count, which is very, very unusual in a child with megaloblastic anemia. Usually their differential is normal. Platelet could be low, it could be very, very low also. But the key is lymphocytosis with the dietary history, with the sick child. Always think of leukemia first, do the marrow, and then you can find the diagnosis. So when to suspect, you should have a high, these 5 cases are very, very important. ITP, JRA, megaloblastic anemia, every time the child will be misdiagnosed and referred to us in a later stage. So high degree of suspicion when you have fever on and off, not going, recurrent pallor, fatigue without lymph node enlargement, hepatosplenomegaly, mucocutaneous bleed, CBC, pancytopenia, bicytopenia. Focus on differential count. I am again and again telling you, if you are a good clinician, always see the differential, see the trend, how it is going. If the lymphocyte is going up and up and up, child is deteriorating, think of these possibilities first. One more important clue is lymphocyte count in small infant, it could be misleading, because in smaller infant, even 80% lymphocyte you could see in viral infection, it could be normal also. Just see the serial count and then decide. So if it is falling or if it is static, which means there is nothing and child is healthy looking. So that is why it is not just the one parameter which is important and should be looked for. You have to see everything in total, and you have to correlate with the age. So peripheral smear, immature cell, very, very important, not just the blast. You have to, if you are pediatrician or if you are hematologist or oncologist, it is a must thing to see the smear, because that will give you the clue. 5P you should remember if you want to take a message: pyrexia, pain, pallor, petechiae, pancytopenia. See everything in single picture. So don't miss anything. If it is undiagnosed and if you are not able to rule it out, just do the marrow. So these are the common thing which we see in clinics. Differential possibility, we have already discussed: JIA, EBV induced infectious mononucleosis, ITP, aplastic anemia, acute infectious lymphocytosis. All these parameters comes in the non-malignant condition. Malignant condition, sometimes neuroblastoma, retinoblastoma and rhabdomyosarcoma, they infiltrate the marrow in stage 4. So they also mimic like that. Okay. So now approach, I have already discussed: history, examination, high degree of suspicion, and very important thing is peripheral smear. More than marrow, peripheral smear. All of you should see the peripheral smear. If you have a time, please go to the lab and see the peripheral smear. Take your patient, take the history, discuss with your pathologist, and refer the patient early to a senior pediatric oncology center. What are the clues in CBC? I have already told: leukocytosis, especially lymphocytosis, pancytopenia, neutropenia, thrombocytopenia, anemia. And you might see only one cell line decrease, other cell line would be borderline. And CBC, only CBC, if you look and say that, okay, I can diagnose just because I have got these clues, this is absolutely wrong. There are multiple other disorders, for example, CMV infection, EBV infection. So there are multiple infections which can mimic with this. So you have to correlate everything. Bone marrow aspiration, flow cytometry has to be done, karyotype has to be done, FISH has to be done, because you have to risk stratify and then only treat. Because pH positive ALL without imatinib, the child is not going to go into remission and you are going to miss the bus. So ALL, again, I am not going to go into the detail. This is very important. Why I have said cytogenetic? Because your favorable risk varies with that. If The child age is 1 to 10 year WBC count less than 15,000, they will be standard risk. That is why you should diagnose early. Once you miss the bus, the count will go up and then the child will become unfavorable risk. These are the things which you cannot change, like cytogenetics will remain same, but it is important to do it so as to risk stratify on an early basis. And then for your this in WBC you have a control. If you diagnose early, you can at least pick it up in an early stage, and you can the child will not land up into non-favorable stage. The clinical response to the treatment, MRD negativity at the end of the induction. Opposite is unfavorable. 2-3 important thing: age less than 1 year is unfavorable, more than 10 year is unfavorable, WBC more than 50,000, T cell is unfavorable, whereas B cell is favorable. Cytogenetics, hypopleidy, translocation 411, 922, and we have treatment for this, hence it is important to do it early. And poor response to prednisolone. So we give prednisolone for first 8 days, and after 8 days we check the peripheral smear. If the absolute blast count is less than 1,000, we call it as standard, good risk, and if it is more than 1,000, it is poor prednisolone response. And then MRD after 30 days of induction therapy. Chemotherapy, I don't want to go into the details. Supportive care is very, very important. There is, I just want to club it. We do 6 months of extensive 5 cycles of chemotherapy, and then afterwards 2 years of maintenance therapy. This all depends on the protocol which your institute is following. So as we follow BFM induction to 2002 protocol, so we give 2.5 years of treatment. These are the drugs that we use, that you all know. Do's and don'ts: do refer patient at the slightest suspicion, as early diagnosis improves the outcome. I have already explained what are the clues and how to diagnose early. Do not give steroid prior to referral. Please, this is the must thing which you should remember. Do not give steroid. Please refer the child. The pediatric oncologist, hematology, they will do the marrow. If you are in medical college, you can only do the marrow and then give steroid. Do not transfuse unless the patient is severely anemic, because it can change the picture. I mean, even if the child is in need CCF, give transfusion. I mean, there is no contraindication for doing it. You can still do a marrow and biopsy. Do start antibiotic if there is fever, because they are immunocompromised patient. Okay, so you have to start antibiotic on an early basis. When to refer? Whenever you have a suspicion, please refer it. There is no delay. AML is another thing. It is also, poor prognostic leukemia. The type, I don't want to deal with that, but I would just want to focus that AML is a bad prognostic, and you have to have early suspicion and referral whenever you have a case of AML. Last thing is APML is another entity. Very good cancer if you diagnose early. We have 8 cases of APML and we did not see even single death. Why? Because APML has a very good survival, not more than 80, now it is more than 90-95% in standard risk ALL. They present with pancytopenia. If you don't diagnose early, they will present with that DIC wala picture which you see in your textbook. So if you don't want to go that, just see the pancytopenia. If bleeding manifestations are more, they look like pancytopenia on an early thing, but once you do a marrow and if you do translocation 1570, you get to know that this is APML. Immediately start with ETRA-ATO. They don't even require chemotherapy. We just use targeted therapy in standard risk, that is ETRA-ATO, and we have seen beautiful response. So the key message is, please diagnose these cases early, refer them early, and have a very high degree of suspicion. And if one message if you want to take, whenever you have a child which you are not understanding and diagnosis is not clear, just see the serial CBC 4-5C, write in your notebook, see the serial count, platelet count, lymphocyte percentage, and then you can get the clue. Thank you very much for this opportunity. Thank you. Any questions?
Thank you, Dr. Shweta, for this great talk. And I would completely agree with her on one thing, because we are a referral center. Please send 2 EDTAs and 2 heparin always, along with all bone marrows, on the slightest suspicion that it will turn out to be acute leukemia, because you need 1 EDTA for flow cytometry, 1 EDTA for your PCRs and NGS, 1 heparin for karyotyping, and 1 heparin for fish. So if required, at least there will be no shortage of samples, and usually these are different sub-departments. So less sharing of sample leads to less confusion. We all can have our each vial. So please go ahead.
First of all, I would like to thank Professor B.R. Srivastava sir inviting me as chairperson for such wonderful CME that really that really give the impact in the mind of the clinicians, that none of the patient of the anemia to be overlooked unless until once you decide, once try to look the peripheral smear. Always pay the attention to the peripheral smear. When we were the house physician, we used to prepare it and we used to see personally. One. Number two, if very nice message given by the madam, now I am inviting the learned person, good teacher from my own alma mater, that is MGM Medical College, Dr. Akshay Lakhoti. I am very well aware about his name, fame and working, and lot of credits to in his academic field. Now Dr. Akshay Lakhoti, please elaborate the one of the common malignancy, the journey of CML we have seen from mile around to the imatinib, now up to the BMT that he is doing at Indore. Dr. Lakhoti, please.
Thank you, sir. Thank you so much, sir, for the kind introduction, sir. And this talk I have made very basic because we have many students with us. And with this, we will be able to understand, most of us will be able to understand what is CML and how do we treat them clinically. So this topic was assigned and this made me understand it more. Thank you, first of all, the organizers, Dr. Vijay and Dr. Anil, and the entire team for organizing this fantastic CME. So coming on to CML, so this is the other end of spectrum. What we have understood from the previous talk, that was acute leukemias, which is quite acute. And those people, those patients do not give us much time. So it is being diagnosed within a month. You need to treat them within a month. Otherwise, the patient has poor prognosis. On the other end of the spectrum, we have these chronic leukemias where you have plenty of time. So we are not in a hurry, but yes, we need to diagnose these patients so that we can treat them also. But this is not life-threatening for almost 6 months down the line once the patient is diagnosed. But those acute leukemias are life-threatening unless they are treated very early. So seeing a CML patient in the clinic do not give you any goosebumps. It makes your life and the patient's life at peace. On the other hand, the acute leukemias makes the life miserable for both. So this is a chronic myeloproliferative disorder which is marked by an excess of myeloid precursors in the blood and the marrow. And yes, we will be discussing this, that there is a molecular level which is known as BCR-ABL1 fusion gene. So approximate, this is a data which has been taken from the multiple papers. So this is an approximate data that we have around 15 to 20,000 new cases every year. We have 4 to 6,000 deaths every year as compared to US, which is lesser. So in India we have a problem of diagnosis, we have the problem of compliance, we have the problem of more of blast crisis because of the later presentation. So we have more deaths and somewhere around 1.5 to 2 lakhs prevalence of CML patient we have in India. So coming on to the era which was pre-TKI era, this disease was as fulminant as acute leukemias, and this was rapidly progressive, often a fatal disease, giving an expected life of around 3 to 5 years to most of our patients. So 3 to 5 years median survival for most CML patients before TKI were introduced. What is TKI? We will discuss again. This was the only hope during those time where allogenic transplant was considered as the only cure for most of our chronic myeloid leukemia patients. But again, the allogenic transplant is a high risk procedure. It carries significant morbidity, GVHD, transplant related mortality. Therefore, but this was the only cure hope for the younger fit patients. This was applicable in 1980s and 90s, the only realistic chance for long-term disease-free survival. But there were limitations because now the transplant thing has also evolved over time. We have many newer drugs for the GVHD prevention, for the CMV prevention and the treatment. So the complication of transplants are taken care more efficiently now, which were not taken before. So there were high transplant related complications including infections, damage, GVHD. There were strict eligibility criteria because we were not able to take older patients. So only younger fit patients were applicable or eligible for bone marrow transplant in 80s and 90s. And limited availability again because of the non-viable candidates, leaving most without a curative option. Now the TKI revolution. So when we understand that the patient only could live around 3 to 5 years, what TKI has done, and what is TKI? So there is a discovery of this Philadelphia chromosome. This is a molecular driver of CML, and this discovery made the research from broad spectrum cytotoxic therapies toward the highly selective molecular targets. Peter Nowell and David Hungerford were two scientists and who were the first to ever find any chromosome abnormality linked to any human cancer. And this chromosomal translocation made a BCR-ABL fusion gene. To our surprise, to an everybody's surprise, sir, none of the scientists for the CML discovery and treatment have ever received a Nobel Prize. So this is unfortunate. So nobody has received any Nobel Prize for this discovery. But yes, this is a molecule, this is a gene which transforms this BCR-ABL1 translocation into a gene which basically activates. So it has a spontaneous activation which causes this tyrosine kinase activation, and thereby there is a downstream pathway which causes the more and more of cancer cells to be produced. So this tyrosine kinase activity, मतलब एक ATP कहीं से produce हो रहा है, so this tyrosine kinase activation has to be diminished. So now we have these tyrosine kinase inhibitors. So these are TKIs. Imatinib was the first breakthrough TKI. So when you target this tyrosine kinase activation, so thereby you are killing all those. So basically you are preventing them cells to growth, and thereby there is an auto-apoptosis of these cells. So thereby you are killing all the CML cells. So this was the regulatory milestone, FDA approved in record time, and it has achieved a cytogenetic and molecular responses which were not attained previously. So you have a molecular target discovered, you have a molecular target inhibitor discovered, and thereby you have made those life to cross as more as 10 years, which has exceeded more than 80% of the population. So with a single drug which can be taken as a pill, 80% or more of the people can survive for more than 10 years with a single imatinib drug, which is a dramatic improvement for pre-TKI era. So we are targeting the root cause, and yes, this has dramatically improved the survival, and this discovery has led to the formation of second and third generation TKIs also. So these are a broader BCR-ABL mutation coverage. So when we have a first generation, we will have a second generation, we will have a third generation, so that we can have more efficient drugs and we can cover more of these targetable enzymes. So thereby we have nilotinib, dasatinib, bosutinib, ponatinib. So many drug options we have for our CML patients now. And this is a fantastic guideline which is available to everybody free, and this is a European Leukemia Net recommendation for CML which tells us how to treat, how to monitor, and how to make these life more better with lot of recommendations which can be easily accessible and easily applicable also. So this is timeline of progress. In 1960 there was a discovery of PH chromosome. 80s and 90s was the prime era where these allogenic transplants were being practiced. 2001 Glivec, that is imatinib, became approved, and then 6 to 12 we have second, third generation TKIs, and now between 2021 and 25 we have another target which is known as asciminib. So with the TKIs most of the life has become better, but there are few patients who develop this TKI resistance too. So what to do for these patients? So we have now a new drug which is known as asciminib, which targets a next enzyme. So it is a novel inhibitor. So it is targeting the ABL myristoyl pocket, so which is different from the TKI. So if any patient has a TKI mutation, so these asciminib can be given to those patients very easily, and this can treat the remaining patients who are not responding to TKIs. So this is a new point of attack which has been told that it do not attack the ATP site, it binds to the myristoyl pocket and thereby inhibit it. This has shown the promising efficacy. So it is more efficacious than TKIs in the phase 3 trial, where it has been compared with lot of other TKIs and has shown that it has achieved a better major molecular responses as compared to the second or third generation TKIs. It has a good safety profile too as compared to the other TKIs. And it can be used in the first line, second line, and also there are emerging researches for the pediatric CML2. Now, coming on to the other aspects of the CML part, where there is a revolving role of stem cell transplant. So when you fail SMA, when you fail TKIs, still there are few patients who can undergo this allogenic transplant because there is no other option left for these patients. So now where allogenic transplant was given to the majority, it is now only restricted for the minority of the patients who fail the other drugs or who transform into your accelerated or the blast crisis. So now CML is not a fulminant disease, but it is a chronic disease. So you need to take care of so many things in a patient because these are on sustained therapy for many years or throughout their life. So you need to monitor their side effects. Comorbidities के हिसाब से we give the TKIs, whether there is any diabetes, heart disease, dyslipidemias, pulmonary disease. So when you have more options, you can take care of all the comorbidities and you can give them individualized TKIs. So we have now patient-centered goals where quality of life becomes more important along with keeping the disease under remission. When to stop TKIs? So now there is a provision to stopping TKIs also. So when you have achieved a major molecular responses for at least 2 years, in few patients you can give a chance of stopping their drug. So probably you are curing this disease in 3 years with more advanced treatments, and around 40 to 50% patients can be advised to stop their treatment after 2 or 3 years of therapy. Family planning and fertility considerations has to be taken care. So most of the male patients who are suffering from CML and are on a TKIs, they can be advised to continue TKI and they can conceive or become a parent. For females, obviously we need to stop these TKIs before conception and during the first or second trimester. There are many papers and many suggestions which suggest that in the second and third generation these TKIs can be resumed if the patient is not doing well with your interferon or hydroxyureas. So yes, you need to manage this chronic condition. It is not a death sentence anymore. And the future is novel combinations, SMA, personalized monitoring with more NGS sequencing, ultra-sensitive MRD assays, which give you more precise response assessment. And this is something which is future. ELN guidelines we need all to check. They are continuously updated. And this is something beyond imagination for when you think of any leukemia or any cancer, that you have made the life of these patients from less than 5 years to as long as normal with the treatment which is easily manageable on the OPD basis. So key takeaways: you had a transplant era, it was limited by high risk and strict eligibility. There was a TKI revolution, you have now an asciminib era, and now we need to take care of the long-term management, TFR and quality of life for all our patients who are living well with CML. So the journey of CML stands as one of the most modern medicine's most powerful testament to the impact of scientific discovery, perseverance and precision. With this, I would like to thank you for your patient hearing and the organizers for giving me the opportunity.
Practicing in the USA, and he has written a very beautiful book which is known as The Emperor of All Maladies, in which he has focused on the how cancer developed in the human body, and like it's a very beautiful iconic book. I think all medicos should read it. And in that he has made a very beautiful observation about the scientists who discovered Glivec or imatinib. That scientist, he said that I am actually responsible for increasing the prevalence of CML in the society. And that was a funny remark, because by increasing the prevalence, he actually meant that the survival has increased so much that now we are having so many more living patients of CML. So really hats off to your presentation. It was very erudite, very clear, and very impactful. Thank you so much.
Thank you so much, Dr. Lahoti, for excellent presentation and giving the clear-cut view that in case of CML, with advancement in the chemotherapy, we can increase the survival up to a decade and rather more than that. And now, if audience have any more questions, Dr. Lahoti will be happy to reply.
So, if a patient get pregnant over imatinib, so what is your view?
Ma'am, at that moment we need to stop the drug and then probably we need to continue it only. If it is a very precious pregnancy, obviously it is advisable that you need to discontinue your TKS before conception.
Yeah.
So, if it is a precious pregnancy, we tend to continue it. Sir, otherwise we give them the option of abortion also if at all we can.
There are many pregnancies over the imatinib, and there are some congenital abnormalities have been reported.
Sir.
So the family should be aware if they are. So we should advise it in early when you are starting. You should not get pregnant. So prevention will be better. If it's early, you should stop it. If it's late in the pregnancy, then the family's decision whether they want to continue. There are normal babies, but there is some chances of abnormal. So there is a big series has been published. But there is a risk of anomalies are there.
Sir, actually, patients को usually amenorrhea रहता ही है just because of chemotherapy and other things. तो सर उनको पता ही late चलता है usually 6 weeks
They
या.
should not have amenorrhea with imatinib. So if they have amenorrhea, check the pregnancy.
Okay.
And ma'am, it is much safer, although it is not recommended, but you consider it is safe in the second and third trimesters now. We have a discussion with the international people also, sir, few months back for a patient, and their criteria was if the patient is not responding to deferral. So for your question, obviously we need to stop, but if the patient has progressed during the pregnancy in the second and third trimester, we tend to challenge the TKS again during pregnancy again.
Okay, thank you.
एक छोटा सा क्वेश्चन है, in how many cases of leukemia, CML, without splenomegaly?
So very few, but it is not a criteria that is if splenomegaly is not there, you cannot find CML. We have very few patients, they do present to us with high WBC counts also. We have few patients who has only presented with 30 lakhs of platelet count. The WBC was normal and that lady got found out to have CML.
Yes.
So yes, it is not clear cut, but yes.
Yes.
Is there, is there any association? I had read somewhere that there is an association of TKIs with diabetes, new onset diabetes. Probably, TKIs probably increase the risk of developing diabetes, but they haven't really proved its association. What is your take on that?
Ma'am, we generally counsel for the diabetic patient, we tend to monitor when we are starting nilotinib. So for the nilotinib single specific TKI, we generally counsel them not to use, so we give preference of dasatinib if we are using second generation TKI in the patients who are already having diabetes or any cardiac comorbidities. So it generally precipitates or it increases the threshold for diabetic populations.
One more thing, because in ये मेरा खुद का पर्सनल एक्सपीरियंस है, कुछ केस ऐसे देखे हैं मैंने. The infection is very problem in these patients. Okay, number one. Number two, in the last week, I had one patient. Her count was about 40,000, 50,000 WBC, presented with pyrexia. Okay. I sent for peripheral smear examination. One of my colleagues are here. The peripheral smear was non-conclusive, but at one another place, then it turned out to be some blast cells. So here, in presence of infection, it is very difficult to comment whether it is a leukemia reaction or early case of CML. What is your opinion? How to approach in such cases?
So
Because that patient develop further, there is increased hemostasis, dehydration, pyrexia because of fever. Then patient develop the multiple microinfarcts and presentation was with a like a encephalopathy and CSF was normal.
sir, here, although we have Dr. Ankit as an expert over here, but yes, basophils is something which is very peculiar for CML, sir. If you have basophilia, you tend to rule out the leukemioid reaction and then you concentrate more on CML. Plus, a blast cannot be missed. If at all it is a leukemioid reaction also, nobody can miss the blast in the peripheral smear. So somewhere there is a problem with the smear observation, sir.
Also, one point I want to make highlight here. So if you have infection and you are saying that there is leukemioid reaction could be there, so my point is you treat them with antibiotics in spite of giving adequate antibiotics. If the counts are still going up, no harm in sending one fish for BCR-ABL just to rule out the things. Just to complete the panel, you send one fish for BCR-ABL, turn out to be positive, it's clear-cut CML. And I have one question to Dr. Akshay. So in how many cases you are seeing this TKI related toxicity in terms of hematological toxicity? Because recently I have one patient, young lady, and diagnosed to have CML. As mentioned by sir, she had no spleen, nothing. The peripheral smear suggestive of CML, we sent fish for PCR-ABL, turned out to be positive, started on imatinib. But with the first dose of imatinib itself, she started having hematological toxicity. So what is your way to whether you want to change it, whether you want to reduce the dose or you want to give alternate day, what will you do that in such situation?
Sir, it is a problematic situation and it is not very uncommon. What we have practiced is either we reduce the dose of imatinib. Secondly, if at all they do not get over with the reduction of the dose, also we tend to switch the TKI. But once the patient has the sensitivity to imatinib, there are more likely chances they will be sensitive to nilotinib or dasatinib also. But few of our patients have survived with nilotinib, even they were sensitive on imatinib. So changing TKI and reducing the dose is only the two ways what we can practice. Sir.
So taking this pancytopenia is not uncommon. Sometimes yes, you give a hydroxyurea along with the TKI, so don't do that. And as soon as your blood counts are below 1 lakh, you stop hydroxyurea and start the TKIs. So give us some degree of this thing to cut down. And call them weekly. For the first few weeks, at least 2 weeks or weekly, you should call them. And giving a break in between to recover is an answer. Some people may not recover. I mean, they will have a pancytopenia. Eventually, they have a bad disease and may progress to the. So you should be worried about. Should do a close monitoring with the peripheral smear, BCR-ABL, just to make sure they're not suddenly going to the blast crisis.
That particular patient actually recovered with a break of 1 week.
Yeah.
So
mostly they will recover with this. I think we have to stop it. So.
Thank you. So next, I will request Dr. Vinay Bora for next speech. He is from Vishesh Jupiter Hospital, Indore. His work is on lymphoma and myeloma, and a specialist in BMT.
Thank you, organizers. Thank you, B.R. Srivastav sir. Thank you, Gunjan madam. My friends, Dr. Anil and Dr. Vijay, for calling me here. And of course, thank you, audience, for sparing your Saturday afternoon for this academic session. So I've been asked to speak on precision oncology and hematological malignancies. Very frankly speaking, this is more of philosophical topic, but because I've been asked to do so, I'll do it in next 10 to 15 minutes. So when we talk about practicing oncology in 2026, we cannot shy away from talking about precision oncology, because what we are practicing now is precision oncology. So this is basically right treatment for right patient at right time, and this is what is precision oncology. It starts right away from diagnosing patient with up-to-date diagnostic modalities, giving them targeted therapies, and of course monitoring their clinical outcome with precise technologies. Now, gone is the era. When I say gone, it is not completely gone, But now we have shifted from morphology to molecular based techniques when it comes to diagnosis. Now we don't talk about one size fits all chemotherapy. We talk about targeted therapies and immunotherapies, and that is what defines precision oncology. So as we discuss diagnosis, risk stratification, then treatment, monitoring, and post-treatment care, at every aspect we are actually following precision oncology. There is a basic difference when we consider pediatric as well as adult tumors. In adult tumors, as the patients grow, as the population age, there is high mutational burden, vis-a-vis pediatric tumors where there is lower mutation burden, and pediatric tumors are more amenable to practicing precision oncology. When we compare blood tumors, that is hematological malignancies, with solid tumors, the blood cancers would lead precision oncology in every field, right from diagnosis to treatment. We have seen in the previous lecture that CML actually is a flagship disease which defined precision oncology, right from diagnosing, identifying Philadelphia chromosome, identifying the mutation, devising, defining TKIs, and post-TKI care. Same is the case with AML, BALL, and so on. So many diseases in hematological field are now treated with precision oncology. In precision oncology, the diagnosis would start with newer technologies, newer advances like flow cytometry. Now we know that in 2025 we cannot diagnose any leukemia without application of flow cytometry. We use FISH, we use karyotyping, NGS to diagnose and to risk stratify, as well as when we monitor the disease during treatment. MRD is the most important modality when we talk about precision oncology. We regularly employ use of MRD in the treatment of ALLs, AMLs, and so many pediatric disorders. The MRD is assessed using flow cytometry, which can detect up to 10⁻⁴, -5 cell level, and so on, going up to NGS, where MRD can be detected at the level of 10⁻⁶ cells. If with NGS, if the MRD is negative, the patients are operationally cured of some particular disorders. So this is the tip of iceberg, and under the tip of iceberg we have MRD 10⁻⁴ with flow cytometry, -5 with PCRs, and still deeper we have NGS negative MRD, where the cell count is actually less than 10⁻⁶. CML is the baby which defined precision oncology. Probably 50-60 years ago, Philadelphia chromosome was identified. Imatinib got first approval, FDA approval, for the treatment of CML, because this was one of the first targeted agent, and now this actually opened the chapter of precision oncology. Over the years we had nilotinib, dasatinib, asciminib. Of course in pediatric population asciminib is not approved, and so on. So many molecules, TKIs, are being approved, and that is how CML actually opened the way of practicing precision oncology. Same is the way with AML. Of course in pediatric population we do not have approvals for so many molecules, but in adult oncology, when we identify particular molecular mutations, we have drugs like midostaurin, ivosidenib, and so on. And when particular mutation is identifying using precision oncology techniques, the treatment are devised so that ultimately PFS, OS would improve. And that is how in every disease where we practice, where we treat patient with hematological malignancies, we are somehow or the other employing precision oncology, right from the diagnosis, monitoring of the treatment, and giving them treatment. The flagship disease of pediatric population is acute lymphoblastic leukemia. If you look at the survival curves, 60 years ago the survival was very dismal. Over the years survival has improved. In fact, in pediatric acute lymphoblastic leukemias in standard risk group, the overall cure rate, overall survival has improved up to 90%. You can imagine, for pediatric ALLs, 90% of the patients who are diagnosed as having ALL would be cured of the disease if they are treated properly. Now this is not simply because of improvement of supportive care. Of course improvement in antibiotics, monitoring, improvement in antifungals has given this, but use of precision oncology at every step right from diagnosis up to the treatment, has written the success story of acute lymphoblastic leukemia. To give you an example, in acute lymphoblastic leukemia in pediatric population, those patients who have translocation 1221, those patients who have hyperdiploid chromosomal pattern on their karyotype are classically are classified into standard risk group vis-a-vis those patients who have infantile leukemia and particular genetic rearrangements would be classified into higher risk leukemia. Now this is where precision oncology will come into picture, because those patients who have higher risk leukemia would ultimately go ahead with bone marrow transplant vis-a-vis those patients who have standard risk leukemia. There at some point of time therapies may be de-escalated using MRDs. In ALL, pediatric ALL, of course this is not only for pediatric ALL, this is also for adult ALLs. There are so many targeted drugs which can be used in the treatment of especially B acute lymphoblastic leukemia. In pediatric populations we use blinatumab. In adult population we have Inonza, inotuzumab. There are certain other molecules, targeted drug, which otherwise were not available 20 years ago, and with the availability of these targeted drugs, the overall survival in pediatric as well as adult population has increased. Now when we talk about treating pediatric acute leukemias, we cannot forget MRD, minimum residual disease, because this is what would define precision oncology now and in coming years. There are different protocols by which we would be treating pediatric ALL, and we use MRD, assessment of minimum residual disease, at different time points like day 29, day 70 and so on. And depending on the MRD levels, because MRD actually is a game changer in pediatric acute leukemias, where for BLL specifically, if the MRDs are negative at particular time point, the therapies can be de-escalated, the therapies can be downgraded, and that is how ultimately the toxicity of therapies would come down. Now this can be compared with those patients who have MRD positivity at day 30, day 70. These are the patients, they would be classified into high risk category. These patients were actually missed when MRD was not available, and these patients would undergo allogenic stem cell transplants. So you can see the event-free survival, relapse-free survival for pediatric patients where MRD is negative. Almost 90% of the patients would get cured with MRD negativity, and those patients who have higher MRD, even at the end of treatment, during the treatment, almost 60% would relapse. These patients were missed when precision oncology techniques were not available. Now apart from ALL, AML, there are other disorders in pediatric population. Lymphoma is one of them. In pediatric population we see Hodgkin lymphoma, non-Hodgkin lymphoma. There we have targeted drugs which were not available probably 10 years ago, 15 years ago, and with this use with the use of targeted drug, the overall survival has improved. So what is the ultimate goal of using precision oncology? 20 years ago the goal was treat to progression, go on giving chemotherapies, treat till progression, till the time patient has progressed, patient has stopped responding, or patient is not tolerating chemotherapies. So that actually led to toxicities, financial toxicities and resistance. But now with precision oncology, with specific drugs available, with the use of MRD, the goal has increased, the goal has shifted to improving overall survival, reducing the toxicities, ultimately improving the quality of life. There is something which is called CAR T cell therapy, which Dinesh Burani sir would be discussing in the afternoon hours. But when we talk about precision oncology in 2026, we cannot forget CAR T, because CAR T would define the future. CAR T cell therapy, these are living cells which are taken out from patient's own body, they are modified and then injected. These cells are like army, they go into patient's body, they identify tumor cells and would specifically kill the tumor cells. Right now in India, we have CAR T available for two specific disorders. First is acute lymphoblastic leukemia, B variety. The second is DLBCL, NHLs. For other disorders like AML, multiple myeloma, we don't have CAR T available in India. Outside India, it is very much available. So CAR T is something which would define the future of precision oncology. Apart from that, there are so many newer things coming up. There are some antibodies, antibody drug conjugates. of course, for adult patients with myeloma, Hodgkin lymphoma, and other disorders where newer antibodies are coming up, bispecific drugs are coming up, this has actually revolutionized the way we treat these patients. So when we talk about precision oncology specifically in pediatric population, pediatric B-cell, ALL, acute myeloid leukemia, the picture has completely changed with the improved diagnostic modalities, with improved monitoring and newer treatment options. In pediatric population, we cannot forget about late effects, because these pediatric patients, when they grow up into adults, they would carry the burden of side effects of chemotherapies which they have received 15-20 years ago. So precision oncology definitely helps minimizing the side effects, because using precision oncology, we are actually avoiding some drugs, de-escalating treatment, and so on. So what is the future of precision oncology or hematology? Right now, we have antibody drug conjugates, we have BiTEs, we have CAR T cells. Probably 5 years down the line, we would have newer CAR T technologies. We would have improved genetic understanding of hematological malignancies, and maybe 10 years down the line, the whole genome sequencing would be a default test for each and everyone who is diagnosed with hematological cancers. We would have more and more indications for CAR T cell therapy and so on. But when we glorify precision oncology so much, we cannot forget about challenges. In India, where we practice, the challenges are many. It starts right away from availability of technology, quality control, cost, ease of access, and so on. But having said that, the future of precision oncology is bright. In fact, present is bright. We are 80% of the time what we are practicing is precision oncology, and as we have seen, there is a bright way ahead for precision oncology. Thank you so much.
Anyone wants to ask a question? Anyone? So I think Vinay has taken this subject from the now to the 10 years down the track, what we are expecting. Anything we want to know?
No questions.
I would like to add one thing as a hematopathologist is that now, because of precision oncology, it is our turn that we should know about the treatments, because they are changing the picture of what is happening in the lab.
Right.
So now with all these newer drugs which are targeted therapies, pathologists cannot be aloof from treatment and just sit and watch their slides and flow cytometries. We need to understand the impact, because as the treatment is changing, our panels are changing. So first CD38 was a marker. For example, now we have daratumumab in the precision oncology era, a targeted therapy. So we have CD38 negative cells. So then we have to change the type of antibody that we are using, just giving you an example. And we have to use additional markers like 229 or 319. Same for the BALL.
Right.
So a proper history given to us, and how we use the history to interpret is very important. So hematopathologists have to know the treatment side of things.
Right.
I think the technology is changing very fast. So we had even AI and the machine learning is coming in. We are getting more precise for the treatment, not the chemotherapy. Now we have the immunotherapies and living drugs, what you are talking about. With this, I thank Vinay.
Thank you.
We'll thank Dr. Srivastava for giving us the opportunity, and we close this session. Thank you all, panel.
I'll also request Dr. Akshay to please join us for the group photograph. I'll request Dr. Bia sir to join us on stage. I think we have had very scintillating discussions. Now, in the interest of the time, as Dr. Swati has a flight, I'll request the permission of Dr. Shalini ma'am and Dr. Yashodhara ma'am if we can have the panel discussion first. I'll invite the moderator, Dr. Swati Shah. Dr. Swati, she is a MAMC alumnus and has done her DNB surgical oncology from RGCI Delhi. Currently, she is practicing at Apollo, Ahmedabad, with keen interest in pelvic surgeries, laparoscopic and robotic oncosurgeries. We are very happy to have you, ma'am. We'll ask you to please invite your panelist.
Thank you for the warm welcome and for the opportunity. So here I first like to invite my panelists. So please Dr. Vijay Chaudhary, Dr. Anju Verma, Dr. Kishwar Sultana, Dr. Hiya Agarwal, Dr. Ravi Ambe, and Dr. Monica Diwan. Yes. So Dr. Vijay Chaudhary is pediatric hematologist and oncologist. Dr. Anju Verma is gynecologist and infertility specialist. Dr. Kishwar Sultana, gynecologist and gynec oncologist. Dr. Hiya Agarwal, gynecologist and infertility specialist. Dr. Ravi Ambe, pediatrician. Dr. Monica Diwan, gynecologist and gynec oncologist. Myself, surgical oncologist, basically doing uro and gynec oncology. So a slight difference in the topic that we have been discussing may not appear that much interesting to you, but let me tell you, this topic has been brought up because of the efficiency, or rather the survival rates that we have been discussing till now, because the survival in the childhood cancers has increased to such an extent that it is the time we have to discuss the sexual health and fertility preservation in these patients. So for pediatric cancer survivors, we have our next session, that is the sexual health and fertility preservation. So let us start with the first case. So a 15-year-old girl undergoes fertility sparing surgery for malignant ovarian germ cell tumor. Chemotherapy is also planned. Now parents are asking about the future menstruation, fertility and marriage. So my first question to Dr. Kishwar ma'am, as a gynec oncologist, in adolescents with ovarian germ cell tumors, how aggressive should the surgery be?
The germ cell tumors which occur in less than 30 years of age, though they are aggressive tumors, but they are very sensitive to chemotherapy and radiotherapy. So the treatment is not very aggressive. Moreover, they are young patients, so we want to preserve their fertility as well. So in these patients, we usually prefer fertility sparing surgeries, and that includes the usually one-sided salpingo-oophorectomy, peritoneal washings, and probably infracolic omentectomy, or in very early cases when the omentum is not involved, we may not even remove the omentum. Lymph nodes, if they are enlarged, then they are removed, because the incidence of lymph node metastasis in early disease is very low, that is 7 to 10% only.
So thanks madam. So it is very important to preserve the fertility, and please remember, this is the only cancer in which we can preserve the fertility even in stage 3 and 4 cancers if the ovary and uterus is normal. So now coming to the fertility specialists, what fertility counseling should happen before the chemotherapy? Dr. Hiya?
Ma'am, it depends as of your patient. She's a 15-year-old. Mostly patients with this age are menstruating, so I would like to assess the reserve, and a menstruating girl can be counseled about the standard approach of fertility preservation, that is oocyte cryopreservation. So if she's menstruating, her reserve is good, and I have time before chemotherapy, I would like to give her a random protocol, preserve the oocytes, and then go ahead with the chemotherapy.
So with this first, ma'am, how many of us do send the patients to you before treating?
It's definitely a novel approach, and definitely in Gwalior, it's not a norm. we are hoping as a reproductive medicine specialist to increase this as much as possible. That's the aim in the future.
So it is actually a lacunae. We should have this insight that this is a lacunae that we all have as the oncologist or whatever field we are related to the oncologist. It is very important to remember the fertility specialist which is available with us. So we should always have the consultation before starting any treatment. So thanks for your comments, madam. Now coming to Dr. Ravi Ambe. Sir, the parents are very anxious, patient doesn't know much. So how do you because you are the primary face to these patients. So how will you counsel? Everything they will come to you and ask. So how will you counsel these patients? First is cancer and the other thing is the fertility.
Yeah. Thank you, ma'am. As far as anxiety is concerned, it is part and parcel of cancer suspicion, diagnosis and treatment. So these ovarian germ cell tumors, malignant, usually these are rare but are more common in this pediatric age group, adolescent girls and the young women. And the prognosis with the contemporary treatment with BEP regime has improved a lot. So in stage 1, it could be better than 95% 5-year survival to 75 to 85% in the advanced disease. So cure is not a problem. We have a good cure, good treatment. As far as fertility and sexual function they are concerned, that is another area of concern. And in this era, when the cancer is far beyond the cure to survivorship, and that to a good quality life, I think this is the real concern of the parents. And we should be empathetic. I mean to say pediatrics, okay? We should be aware of that and we should be empathetic to that and should discuss it with the parents, and we can act as a sheet anchor, as a team member for this management. And this chemotherapy, though it is having good cure, but it is going to affect the endocrine function, ovarian function. And as the Dr. Hia rightly said that this is not a norm in our present era of practice. We need to sensitize ourselves as well as the parents. And as said before, the survivorship should be taken as a holistic, not limited to the cure of the patient. And I think this is going to boost the confidence of the parents as well as the patient. Thank you.
Thank you. So this was the first question. So with every question, the take-home message is, please do remember the holistic approach as said by Dr. Ravi, that it is the holistically the patient has to survive. It is not only the quantity of life, it is the quality of life also that we are responsible for. Coming to the next question. So testicular germ cell tumor question, a 16-year-old boy with metastatic testicular cancer requires urgent chemotherapy. So many a times we oncologists save ourselves from sending to fertility specialist by saying it was urgent. The surgery was required urgently, the ovary had to be removed, the testis had to be removed. So believe me, there are situations which are urgent, but we have to manage them. So the patient required urgent chemotherapy, and family asks whether treatment will affect fertility and the masculinity. So first question to Dr. Vijay Chaudhary, should fertility preservation delay chemotherapy in testicular cancer? Answer more regarding this.
See, we can delay for few days, but ideally speaking, should not be more than few days. We can't say that you delay for 2 weeks or 3 weeks and then do. There are methods available for fertility preservation. He is a male, he can simply do a semen cryopreservation, which is a very small procedure. 2 or 3 samples would be sufficient. Another method is testicular sperm extraction, but priority is cancer treatment. We must understand this. Unless you live, there is no chances of fertility. So please understand this. We can delay if we counsel them adequately. We give them option that okay, semen cryopreservation is available. We give them appropriate address and the name of the consultants. They will go there. They will cryopreserve the semen sample, come back in the same week, and we start the treatment. So not more than few days. I would say that's it.
So very correctly pointed out, though the message is quality of life is important, but first comes the quantity. So yes, the cancer treatment should not be delayed. So we should be aware of the fertility specialist available near to us, what all treatments are available, how fast they can be done. One sperm banking, how much time it should take. So now coming to Dr. Anju, please guide us regarding the same. How sperm cryopreservation is done, what are the practical aspects?
Thank you, ma'am. Just in this case, a male is 16-year-old. In most of the 16-year-old boys have ejaculation. So we can counsel parents to preserve the semen, but it should be preserved in the registered ART bank. I want to inform that our center is registered ART bank in this Gwalior Chambal division, and many cases we have also preserved the sample like in lymphoid and leukemia. So we can counsel parents that we can preserve the semen, but we should also coordinate with these oncosurgeons, oncospecialists, that how much time. Even one single sample have more values. So we can sample, preserve one sample, if there is permission 2 to 3 sample, and we again counsel the patient and parents that this may be used in future IVF-ICSI. We should also counsel the advanced treatment, what is the rate, what is the success rate, but we can do this because after therapy, there is very less chance of this availability of the sperm.
Thank you, ma'am. So the idea is whatever field we are in, but if we are related to oncology, we have to know about these fertility nuances so that we can help our patients. So Dr. Monica ma'am, what sexual health concerns are commonly overlooked in male survivors?
As the importance of today's this panel is again saying the importance. Basically, in the male survivors, at the time of treatment, starting from the treatment, we forget about their sexual and the psychological health. We mostly focus on the cancer-related treatment. As in this boy, the treatment, chemotherapy or the surgery leads to the decrease in the testosterone hormone, which further leads to effect of the decreased testosterone, like decrease in the sperm count, decrease in the libido, which further lead to affect her psychological effect, like the body image, their sense of masculinity, and this further lead to her personal and the social life. So we should focus over these aspects also at the time of advising the adolescent for the treatment.
Thanks, ma'am. So coming to the next case, pelvic radiation in different cases. So a 13-year-old girl with pelvic rhabdomyosarcoma requires pelvic radiotherapy. So now coming to the effects of Dr. Monica Divan, coming again to you. What are the long-term sexual and reproductive consequences in pelvic radiation?
So if we talk specifically about the long-term sexual and the reproductive consequences, so the ovary is the very sensitive organ. So radiations lead to effect of decrease in hormones, the estrogen hormones, which lead to the ovarian failure, which further affect her secondary sexual characteristics like the breast development, and the vaginal exposure of the radiation leads to fibrosis at the vagina, dryness, which further leads to the vaginal stenosis. And as I already told, the decrease in the hormones, specifically the estrogen, affect her puberty. The effect of radiation over the uterus again lead to the fibrosis, and the decrease in the hormones lead to the decrease in the growth of the uterus. So the uterus again small in size, which further leads to the obstetric complications like difficulty in getting pregnant. If she gets pregnant, leads to the abortion and other effects.
So much to discuss before starting any treatment in these patients. So coming to Dr. Kishwar Sultana, madam, as a gynecologist and gyneco-oncologist, what are the things that we can do to these patients before they are going for radiation?
If we talk about the surgery, we can preserve, we can protect the ovaries by doing ovarian transposition before pelvic radiation. And in this ovarian tissues, they are taken with their pedicle out of the pelvic brim, in the paracolic gutter or lateral to the psoas muscles, and so that their exposure to the radiation is minimal. And in this, like the ovary is stitched to the peritoneum, and it has been shown that the if the brachytherapy is given, on the ovaries, they regain their hormonal activity up to 90%, and if there is external beam radiation, around 50 to 60% of the hormonal activity of the ovary is preserved. And there is, in some cases, about 30 to 40% they may also conceive later on.
So yes, ovarian transposition is an option for these patients. So we should remember that this will take 2 to 3 days, because the patient will go to a surgeon, though it is done laparoscopically, but 2 to 3 days is the minimum. We can start with the main treatment, that is radiation. So things we should be knowing about before starting the oncology treatment. Coming to Dr. Yahia again, if ovarian function is lost despite transposition, what options remain in these patients for hormone as well as fertility?
First of all, I would like to add, like when we are planning transposition in this era, we can plan along with it ovarian tissue cryopreservation. That way, answering to your question, we don't have to go, because some things cannot be come back. We cannot return certain things to the patient. So definitely we can take some tissue when we are transposing and preserve it, so that we have something to answer to the patient at the time when we are, because how ovary will respond, nobody can predict. We can just make an estimation of it, but cannot guarantee it. Other than that, if we have not done, and the patient has come to us and she is slightly older in age, more than after 30 years we are doing, she is a young patient, most of the chances that ovary will respond, at least hormonal function will come back. And if not, we are not getting, then there is an option of donor oocytes if it's not, the ovary is not responding at all.
So, madam, regarding the OTC, we have been discussing about the OTC in various we have regular pelvic oncology and fertility conferences. So, the OTC is not available at most of the centers. That is what we know. We'll be thankful if you let us know, because we have been asking that whatever centers who have the OTC, please let us know.
Up until recent, it was experimental. It has become a clinical option in recent years only. So, coming to in India as a clinical option, it will take some time. My plan is to bring it to Gwalior, but
so
it will take
I'll
time.
just request, whenever you start it, please post it in the groups, so we know where to send the patient, so that OTC can be done. So that is the request from our side as the oncologist, though we don't send pre-op, but if you let us know, we might start doing that. So yes, so that was about this case. Now coming to the, since hemato-oncology, bone marrow transplant survivor, a 12-year-old girl undergoing BMT for leukemia requires high-dose conditioning therapy. Family asks about puberty, fertility, future quality of life, because the survival has increased now. Dr. Ravi sir, you have to answer the major long-term, whatever we can do for these patients, whatever are the concerns for patients undergoing bone marrow transplant regarding the fertility.
So again, here the results are very good as far as cure is concerned, treatment is concerned. But yes, long-term effect of conditioning therapy, bone marrow transplantation, immunosuppression, and chemotherapy are going to happen. So one of the major concerns, this is a 12-year-old girl. So there is concern for the premature ovarian insufficiency, and it will lead to, if the puberty has occurred, it may arrest the puberty, or if the puberty has not taken place in her, so it will delay the puberty. So that is the one of the concern. Then it may also cause the premature menopause. This is a girl and who has to who is supposed to go through the sexual life, but due to this she might experience those premature symptoms, and this is going to affect the growth of the child as well, because of central, as it is going to affect the HP axis, radiation as well as chemo, and it is going to affect the growth plate of the spine. So we need to monitor for that. And these are the other endocrine organs, especially adrenal, thyroid, they are also being affected by this. So as a holistic, these endocrine organs, especially ovary, thyroid, pituitary need to be taken care of, need to take care of the growth of the child, and accordingly this survivorship parents again should parents should be sensitized from the starting that this cancer is not up to the cure, it is for the survivorship. So holistic care of the child may require decades of dedicated follow-up.
So
Thank
well
you.
said. While managing pediatric cancer, starting from pediatricians, now up to the menopausal specialists are involved because we are dealing with POFI, that is ovarian premature failure. So coming to Dr. Anju ma'am, what fertility preservation options should be considered before BMT?
If we are talking about this particular case, we should ask the girl that whether she is menstruating or not, and should also coordinate with the oncologist that we have time 10 to 14 days if we can delay bone marrow transplantation. Because if there is 10 to 14 days and girls is menstruating, it's good to preserve the oocyte after stimulating the ovary. Because oocyte preservation is quite common, we are also doing, but ovary preservation in this era is still there is only experimental basis. Even some centers are doing, but it's good if we have menstruating girl and 10 to 12 days we stimulate the ovary, retrieve the oocyte, and we can keep for the frozen oocyte. But if not menstruating, then we should offer the patient for cryopreservation of this cortical tissue. We can retrieve either laparoscopically and preserved, stored, and after treatment we can reimplant. But because this is leukemia, this ovarian tissue may have the cancer cells. So again, after reimposition or implantation, there is little risk of again spreading. So we should counsel the patient. It's better to do oocyte cryopreservation.
Thanks for pointing out that, ma'am. So for the final discussions, I will ask Dr. Vijay sir, should fertility counseling become mandatory before gonadotoxic therapy in children and adolescents?
Absolutely yes. We regularly do this. Any kind of chemotherapy you are giving, the counseling is absolutely mandatory before that.
So for the final discussion, if we have questions or the panelists want to have some discussion on the related topic.
It is necessary and it is debatable as of now, because the infrastructure, the cancer care, the financial status, and the urgency to treat, these are the critical factors which need to be considered.
I think,
before
madam,
making it mandate.
Everybody should aware that whether treatment is available and where it is available. Because lack of knowledge, many patients, parents are suffering. But if we can spread the knowledge in our city, in our area, where we can do all this, it's always good to do multidisciplinary approach.
Ma'am, I agree. We should aware about this, but as our patients are not very financially strong, so we have to look this part also. We counsel, but most of the time, because of the cost of these all preservation effects, they are not able to afford these type of things.
I can say sperm cryopreservation is not very costly. 10 to 15,000 we can use 1 to 2 sample, and oocyte cryopreservation, because we required stimulation, so it is costing about one cycle of IVF about 1.5 lakhs. So sperm cryopreservation is not very much costly.
So I would like to say, whenever you are making us aware of various things that are available, like whenever the OTC is becoming available everywhere, let us know about the costs at various centers so that we can offer the patients in whatever financial strata they belong to. At least more and more patients can utilize the facilities which are available at various centers. Thank you. So, thank you.
Thank you so much, ma'am. And Hanji, please.
First of all, I think this was an excellent session and much needed because we often forget to talk about this aspect. Just one or two things I wanted to ask the IVF doctors, right? So how easy is it to create an embryo from the ovarian cryopreserved, which we have preserved for whatever 20, 30 years? Because
Uh,
what I understand, it involves a huge amount of cost also.
Ma'am, it's not easy. It's as of now, it was experimental till 1 or 2 years back. It has now become an option, but not so much available in India. Not so much in India. Outside only we have case reports. There are only around 200 live births from that cryopreserved ovarian tissue. So as far as the signs go, we cut the cortical pieces, we freeze them, and when the oncologists recommend and when we feel that it has been 6 months or 6 to 7 months after the completion of the treatment, after remission, we transplant them back for the ovarian function. Usually, if it's possible, we do it in the area where the ovary is in the adnexal regions, or if it's not possible, then in the subcutaneous fat. It's easier if we do it in the subcutaneous areas like arms and all, in the stomach, because then it's easier to get the oocyte. When we stimulate them, it's easier to get the oocytes. Because normal reproduction will not be possible. We will have to do IVF for these people.
Madam, tissue cryopreservation is difficult and impractical in India still now, but oocyte cryopreservation, and if the patient has partner, we can also cryopreserve embryos. So it's a very, very common, and nowadays it's very common to preserve the oocyte, preserve the embryo. We are also doing. But cryopreservation of tissue is still not very, very done usually. So it's difficult.
I can completely understand that. So that's why we get stuck in children and adolescents, because all these things are not available. Just one more thing I wanted to ask is, in the Indian scenario, I'm sure all of us observe, there's a girl, say germ cell tumor, and you start counseling them about fertility. There is a good chance that the family will say, "Jane do, why to treat if she's can't bear children?" So that is one big fear. I'm sure you will also agree that we need to assess with which parents we need to discuss this. If we're going to discuss it as a rule with every parent, we run a risk of abandonment. I just wanted to sensitize that.
I'm totally agree. Most of the time we counsel the parents and they say, no, जाने दो मैम, आप तो बस कैंसर का इलाज करो.
No, I'm saying about something else. I'm saying if you counsel that this girl, especially girls in India, that she cannot bear children, they will stop the treatment for cancer as well. You know, there's no point in saving her. That is
it is like that.
Yeah.
Madam, there is a one treatment if patient don't want to preserve the ovarian tissue oocytes, and we starting during chemotherapy, radiotherapy, we can give the GnRH agonist, leupride injection. Yes. This create little less damage. So if the patient is not ready for doing anything, you just give the leupride injection in every 3 months. It keeps on silent ovary and there is less damage because there is no active oocytes.
I agree to that.
Thank you so much, ma'am. Thank you so much to our panelists. Now, I would request you to come forward, please, for the group photo. I would like to call chairperson of next session on stage, Dr. Ajay Gaur sir, Dr. Ashok Banga sir, Dr. Ajay Pal sir, and Dr. Rajni Agrawal ma'am. Please join us on stage for next session. Yes.
Consultant and Head Pediatrics Surgical Oncology at Rajiv Gandhi Cancer Institute and Research Center. She is Chair Wilms Tumor Subcommittee of INPHOG, Country PI for SIOP Umbrella India's study. She is member of ARIA Guide Program for Wilms Tumor. Her area of interest is pediatric solid tumors, central venous access devices. Now, Dr. Shalini Mishra, please.
Thank you, chairpersons, for the kind introduction. And without any further delay, I think we are running already late. I'm really honored to be here today. Can you please put up my slides? The same one? Okay. Right. So can I just have a show of hands? How many are students here? Quickly, okay. Thank you so much. So I'm going to wake you up. I want this to be a little bit interactive sessions, and this session is mainly meant for you. All the other people, they already know what I'm going to talk about. And I'm really I'm very happy to see so many of you. So I'll be talking about the approach to abdominal mass in a child. We know that the abdominal masses in pediatric age group, they have a whole line of diverse origin and significance as well, right? And it can occur at any age. So unlike the adults, when we look at a child with an abdominal mass, the second thing after mass we see, what is the age? If somebody calls me up and tells me about a child, then my first question will be, what is the age of the child, you know? Because the pathology can vary depending on the age of the child. And also different clinical presentations. And another challenging thing is sometimes it's not easy to diagnose it alone. You need the whole team, pediatric oncologist, pediatrician maybe, the surgeon, and the radiologist and pathologist sometimes to sit down and crack the diagnosis. So they can be very challenging as well. So I'll be briefly discussing the various types of cystic and solid abdominal masses and also how to reach in diagnosis, kind of an algorithm I'll discuss. So as I mentioned, the site is very important. So you need to see where exactly this tumor is arising from. And also some of the, you go back to your general surgery posting and revise your abdominal mass examination, whether it's a mobile mass, whether it's bimanually palpable, which quadrant, can you get above it, can you get below it, all those things are very important. And the age, I've already said, and the duration of history, because if it's acute, then you can pinpoint that it's probably an inflammatory or infective etiology. And very often, at the end of examination, we can just about come up with a differential diagnosis, which is fine. And then we can decide which investigation to take. And what is our aim? We have to reach the correct diagnosis cost effectively. We can't just run a whole battery of tests on every child which comes with an abdominal lump. It's not possible. I'll discuss that later. And with the least distress to the child. This is again very important because often the procedures will cause pain if you're doing a biopsy or a blood sampling or will require anesthesia. So we have to try and plan it out so that the child, the parents do not get too distressed, too overwhelmed with the diagnosis itself that they will just, probably say no for the treatment. So some of the normal, can somebody tell me what are the normal abdominal masses in children? Some structures you can feel, oh, there's a mass, but actually it's a normal structure in the abdomen. Anybody? The liver, a soft liver can be palpable in an infant and sometimes little older child. What about a feculoma? Child has a constipation. I'm sure in general surgery exam or in clinics, all of you have faced a patient, especially a child with a feculoma, and you thought it's a mass, but it's actually just a feculoma. And a full bladder, of course. So we just have to be aware about the normal conditions and the less rare things before we just jump into a tumor. It's not necessary that every child which comes with a mass has a tumor. So very grossly, we can divide them into cystic or solid masses. So I hope you can see this table. So if you want, I can share these things with you based on the location of the mass. I have just classified them as solid or cystic. So flank mass, very obviously what comes to our mind is a renal mass. So you have all the benign ones which are much more common: hydronephrosis, PUJ obstruction, polycystic kidney, multicystic kidney. All those things are much more common than your tumors. But when you come to the tumor, you think about a solid flank mass, then Wilms tumor, neuroblastoma, and you could even have an adrenal tumor there because the location is similar. And of course, you can have, so things like unrelated to tumor or anything like renal vein thrombosis in a small child, right? Right upper quadrant, obviously, it will be more related to the liver, the benign cysts like choledochal cyst, hydatid cyst, abscess, amoebic abscess. All those are much more common. And then you have hepatoblastoma. Older children, you have hepatocellular carcinoma, and then you have the benign lesions like hemangioendothelioma and mesenchymal hematoma. Left upper quadrant, very simple, spleen. Usually it's just a spleen enlargement, and usually you don't have a tumor. We don't see a tumor arising from the spleen. It could just be a splenomegaly, part of a thalassemia or any other hematological anomaly, pathology, right? Epigastrium, again, stomach and pancreas. So if you are aware of what the normal anatomy is, you can think of tumors or cysts arising from that particular area. And you will notice that retroperitoneal masses like neuroblastoma, teratoma, these can arise in any quadrant because they just arise from the retroperitoneum, right? And mid-abdomen could even be a lymphoma, a non-Hodgkin's lymphoma, and sometimes a paraspinal lesion can be a primitive neuroectodermal tumor and a pseudotumor. Sometimes just a horseshoe kidney, which is a pelvic kidney, it has failed to ascend and got stuck in the ascent at the inferior mesenteric artery. That could be palpable like a mass because of fused anomaly in a thin-built child. And of course, pelvis, we have to be careful about ovarian tumors, cysts, or it could be just be imperforate hymen with hydrocolpos in a teenage girl, and of course the malignancies. You could get rhabdomyosarcoma, of course germ cell tumors, and PNET as well. So as I said earlier, we don't jump into all the investigations as soon as we see a child with a lump. So usually any child with an abdominal mass, the first thing we will like to do is an abdominal X-ray, erect and supine, just to rule out an intestinal obstruction, because the child may be crying, you don't know whether it's a mass or it's a dilated bowel or is it ascites, you don't know what it is. Very often we don't do this unless the child is having some bilious vomiting and inability to pass stool. And then next step is the simplest one is ultrasonography. Because again, these are non-invasive. You are not, you don't have to sedate the child, don't have to give anesthesia, maybe just oral pedicloral should do for these. And based on what you find on the ultrasound, I think ultrasound is a very important investigation. And I always think that wherever you're working, however small place or a big place, you have to have a good rapport with the sonologist, especially when you're sending a child. And if you have somebody who is specialized in that, it will be very, very helpful. It may not be a very senior person. It could be your colleague or your classmate from college or anybody, somebody with whom you can discuss. Because sometimes, they may see some things, it's very subjective. And they may imagine a few things and you know what you're looking for. So if you discuss with them, you will get a better answer. And whether or not to do further imaging, that's the biggest question. Of course, often, like in renal tumors, we couple it with the Doppler because it tells us about if there's a renal vein thrombosis or a IVC thrombosis associated, and then the CT scan. And sometimes if you're thinking of a cystic mass like PUJ obstruction, you will need a nuclear scan. Angiography very rarely. Can anybody tell me where we use a CT angio? Which tumor in children do we use a CT angio as a diagnostic method? Anybody? Something which encases the vessels, at least before surgery? Neuroblastoma, right? Okay. And then, of course, slowly more and more MRI is being done. We know it's good for soft tissues, so for sarcomas, we definitely do. For head and neck, we do. But for abdominal masses also, for liver tumors, sometimes we get a better delineation with and calculation of the volumes and, you know, multiple foci of the lesion in the hepatoblastoma. That is much better picked up on MRI. And even for renal tumors, like for bilateral Wilms or a horseshoe kidney, MRI is preferable. So, ultimate goal, again, we have to get the diagnosis, we have to get it quickly, and you have to improve, you have to get the child better, right? So, depending on the age of the patient and the presenting symptoms, you will decide which imaging process. So, I'll just quickly take you through some kind of a algorithm. I hope it's visible. Okay. So, you have a child with a suspected abdominal mass. So, first thing I said, we can do an abdominal radiograph. It's any intestinal obstruction, then you treat it accordingly. No intestinal obstruction. Can you figure out an abdominal mass on an X-ray abdomen in a child? Yes or no? Something, you just say. There's nobody marking you here. Can you figure out an abdominal, it's a huge abdominal mass. Will it show on the X-ray? Can it possibly show on the X-ray? You can get a, you know, a whiteout area where the mass is and all the bowel loops are pushed to the periphery. So that can give you an indication that there's a large mass over there, because all the bowel, which is usually seen in the center, is now pushed to the periphery. So you do an ultrasound, because X-ray is normal, and based on what you find on the ultrasound, what is the site, what is the organ of origin, you can get all your details based on the ultrasound, right? And if the ultrasound is normal, then that's it. It was probably the bladder you felt, or a fecaloma or something like that. Nothing more to be done. And if it is abnormal, you get more details. For example, you get a renal cystic mass, then you'll work up like a PUJ obstruction. If you get a renal solid mass, then definitely you need to do further imaging like CT, contrast CT. Again, non-renal retroperitoneal mass, again you will need to do a CT. Hepatobiliary mass will also need further imaging. And sometimes if you're thinking about a choledochal cyst or something, you may do a HIDA scan. A genital mass or a pelvic mass, again, sometimes if you think it's a rhabdomyosarcoma of the vagina, then you may need to do a genitogram or a genitoscopy and biopsy. And of course, sometimes for bladder masses, you may need to do a MCU. So based on the age, now I definitely want at least one or two answers. I know people are talking at the last row, but I want you to concentrate and just blurt out anything that comes to your mind. In a neonate, if I tell there's a solid abdominal mass, just name one or two things which are more likely to happen. Which tumors? Either it could be just benign, which is much more common, any, you know, malformations, duplication cyst of the genitourinary tract or gut, right? That is much more common. And if it's a solid mass, then neuroblastoma is the most common solid mass in a neonate. Every time we think it looks like a renal mass, but when you work up, it finally comes out to be neuroblastoma. And these are the ones which will actually spontaneously regress. So we don't need to really act on them, but we do need to classify and stage them and make sure that they are not progressing. Older infants, 1 to 5 years. Now this is where most of your solid tumors of the abdomen come. This is the most common age of presentation, right? The preschool age in the toddlers. And Wilms tumor, neuroblastoma, germ cell tumor, hepatoblastoma, all of them. And of course, sometimes non-Hodgkin's lymphoma. Adolescents, again, more likely to have inflammatory masses. And in teenage girls, you do need to rule out pregnancy as well. And of course, non-Hodgkin's lymphoma and germ cell tumors. So, based on the symptoms and signs, if somebody can answer this, I'll try and give you some chocolates. Incidental mass noticed by the caregiver and hematuria. A toddler. What do you think it can be? Yes? Wilms tumor, very good. Systemic symptoms like fever, irritability, failure to thrive, bone pains. All this is with abdominal mass. What is the most likely diagnosis? Very good. Excellent. You guys are good. Subcutaneous skin nodules in an infant and abdominal mass. Yes, again, stage 4S or MS neuroblastoma. Hypertension, it could either be abdominal mass and hypertension, can be both neuroblastoma or Wilms. Pelvic mass with bladder and bowel symptoms may not be palpable, but just presence with bowel and bladder symptoms. It could be a sacrococcygeal germ cell tumor, Alterman type 4. And a paraspinal mass with neurological deficits could be either PNET or neuroblastoma. So just some red flag signs before I take you through a few cases and then we'll finish. So any lower abdominal mass in girls, you have to be very, very careful about an ovarian mass. It could even be a torsion of ovarian cyst if it's an acute abdomen. A non-mobile mass will tell you that it's likely to be a malignant one. Any child with a skeletal pain or pathological fracture, you have to think about metastasis, right? Sudden increase in size in the clothing, abdominal distension, you have to definitely think about ascites or abdominal mass. A left-sided varicocele, although I rarely see one because we don't examine, that could lead you to a small Wilms tumor. I just want to mention, once I had a child who was kicked by his elder sister, a 5-year-old boy, on some festival day, and went to the emergency because he had abdominal pain, and they found he had a small Wilms tumor which ruptured with that abdominal trauma. So in the end, he actually landed up thanking the elder sister because that got his tumor diagnosed and we treated him. And of course, systemic signs, we don't need to neglect them, right? And we have tumor markers to help. Many times if you get a raised alpha-fetoprotein in a germ cell tumor or a hepatoblastoma, we don't need to do a biopsy. Biopsy is again an invasive test, so we really think carefully whether to do a biopsy or not. Also, a lot of parents, if you tell them we don't need to do the biopsy, we've got your tumor markers, we usually get the AFP reports in our institute in 4 hours, and we've done the imaging, we've done the staging, like just CT chest for a germ cell tumor. By that evening, the child can get admitted and start chemotherapy. And of course, these are very small children. I'm talking about 3 to 4, 5-year-old. We can't do fertility preservation. We can't even think about it. So it's actually reassuring also because the diagnosis is so stressful, and then you can start treatment quickly. They have this myth that biopsy will do something awful to the tumor and it's going to spread. So when you tell them no biopsy, it's not that I believe in that myth, but yes, biopsy is an invasive procedure. There can be rupture, there can be hemorrhage, and it can delay the treatment onset as well. So the decision has to be very, very, very carefully made by the whole team. And one important thing, if you're going to biopsy a renal tumor, please, suspected Wilms in a child, please do not do it transperitoneally. Please make sure, go there, go to the radiologist, make sure one of you is there and make sure it is done through the retroperitoneal route, because otherwise it will upstage to stage 3. You have to upstage the chemo, add Adria, and also give radiation, especially if it's a less than 3-year-old child. Okay, so quickly I'll go through 2 cases. Whenever you want me to stop, I will stop. So the 3-year-old boy, well till 2 weeks ago, and then mother noticed this left-sided abdominal mass while bathing and 1 episode of hematuria. No systemic symptoms. So you can see there's a nice flank mass over here. You can see the bulge over there. It's hard in consistency, smooth in surface, well-defined margins. You cannot get above the mass. It's bimanually palpable. And there is dullness over the left renal angle. So all these things are very important. The blood pressure, checking the blood pressure of a child with an abdominal mass. So again, this is telling us towards a likely renal origin mass, and in this age group, most likely will be a Wilms tumor. And you don't need to do, if you're following the SIOP protocol, you don't need to do the biopsy routinely unless there is a radiological discrepancy. Could this be a tense hydronephrosis? Yes, it could be. So that's why your ultrasound is going to tell you that it's a cystic mass or solid mass, and then you're going to proceed with a CT scan only after doing. And always, wherever you're thinking of Wilms, neuroblastoma is always lurking around as a DD, because sometimes there's a very small gray area between the two. So I will just show you the image here. Can you see my arrow? You can see a claw sign, and the great vessels are not disturbed. Although this is crossing the midline, it's very clearly originating from the kidney mass, and it's a very large mass and very clearly a Wilms tumor. You can start on chemo without even a biopsy or anything else. Another child, so I'm just going to skip this. This is a 2-year-old with fever, weight loss, poor appetite, and then abdominal pain and mass, and then this swelling on the right eye. The mother said the child fell down from the bed, and the child landed up in the neurosurgery ward because they thought he had head injury, right? So you see there's a huge abdominal mass as well. So it's very important to examine the whole child and not get misled by that orbital sign. What is it called? Raccoon eye, right? So this is how the neuroblastoma looks, very irregular and ocellated surface. And I'll just show you the imaging. And definitely here you will need to do a biopsy. You cannot proceed without biopsy in neuroblastoma. You can see there's a huge mass here, and this is called the seagull sign, where the celiac trunk is encased and the aorta is encased 360 degrees by the tumor. Here also you can see it. So based on this, we will proceed. I think we're short of time, so I will just end it at this. If there are any questions, I'll be happy to take. Yes, yes. So please raise your hands. Those who answered the questions from that side. Yes. Please come up on the stage quickly.
Thank you so much. We'll move to the next one.
Thank you very much, madam. Such very nice discussion. Definitely there will be questions, but we can ask the question during lunch hours.
Now I would like to invite Dr. Yashodhara Gaur. Madam is MBBS, MS, FICOG, and Madam is Professor, GR Medical College, Gwalior. And Madam West Zone Coordinator, Foxy Oncology Committee, Founder President, MP State Chapter of Agoy, and President Gwalior of Gynae Society 2019-20. Madam,
thank you. Hello, good afternoon. First of all, I am thankful to the Director, CHRI, our Professor B.R. Srivastav sir, and dear Gunjan, and the organizing committee for giving me this opportunity to interact in a pediatric oncology conference. Initially I thought why I was called, but listening the talks of the speakers and the panel discussion, it's obvious that each and every patient of ours need a holistic care, and for that multidisciplinary management is a must. We need to address the grey areas which are left, the gaps which are left in the management of the patient. Those areas must be filled. So starting with the my topic of germ cell tumors of ovary, they are derived from the primordial germ cell of the ovary. We all know the incidence is very less. We are fortunate that only 1/10 the incidence of malignant germ cell tumors of the testes are germ cell tumors of ovary. These malignant germ cell tumors not only they develop in gonad, but they are also found in the mediastinum and retroperitoneal areas, and this is because of the migration of the germ cell from the yolk sac to the dorsal mesentery before their incorporation into the sex cords of the developing gonads. It's very assuring and relieving that germ cell tumors are a model of a curable cancer. Management of the patients with ovarian germ cell tumor has largely been extrapolated from the much greater experience of treating males with the more common testicular germ cell tumors. So these tumors are less in number and they are curable one. These two important points are there. So this is the picture of a 3-week-old embryo showing the primordial germ cells in the wall of the yolk sac close to the attachment of the allantois. This is only 3 weeks. When we are doing urine pregnancy test to confirm the pregnancy, already the orchestra of the nature has set in the melody, and the primordial germ cell starts migrating towards the genital ridges. So this is the route through which germ cell goes from allantois, from near hindgut to the genital ridges. That's why the germ cell tumor can develop in mediastinum and retroperitoneal areas also. So germ cell tumor we classify on 2 points. One is the histology and other one is based on the tumor markers. Histological ovarian germ cell tumors are primary germ cell, primitive germ cell tumors, dysgerminoma, yolk sac tumor, embryonal carcinoma, polyembryoma, non-gestational choriocarcinoma, and mixed germ cell tumor. While biphasic ones are immature teratomas and mature teratomas, which remains benign, may be solid or cystic because of the differentiation of the cells. And then dermoid cyst may be there. Monodermal teratomas and somatic types are also there. That is thyroid tumor, stroma ovariae tumors, which may be benign or malignant, carcinoid tumors, neuroectodermal tumor, carcinoma, melanocytic. So these are very different types of the histological structure carrying germ cell tumors, and according to that they function and they give sign and symptoms, and their management is decided. The second understanding of germ cell tumor is the presence of the tumor markers. Tumor markers like alpha fetoprotein, beta HCG, LDH, and PLAP are there, which are used in diagnosing, in monitoring the treatment, and in monitoring the recurrence also. So these tumor markers are alpha fetoprotein, is we all know that it is the major fetal plasma protein which is produced by the yolk sac and fetal liver. Its normal value remains less than 5.4 nanogram per ml, and it remains elevated apart from germ cell tumor in the NSGCT, hepatocellular carcinoma, omphalocele, ataxia, telangiectasia, and in its levels are reduced in Down syndrome. The next marker which we use in the management of the germ cell tumor is the beta HCG, which is used in diagnosing and monitoring treatment response in germ cell tumors in which it is positive. Other tests of this marker we are already doing in our routine practice: pregnancy tests, gestational trophoblastic disease, management, diagnosis and post-treatment follow-up of the ectopic pregnancy, and as a component of triple test in antenatal care. The third marker which we use is the lactate dehydrogenase. The unique thing about lactate dehydrogenase is that it is a marker which is a reflection of tumor burden, growth rate, and cellular proliferation. So it may remain positive in all of the germ cell tumors. LDH, usually it is the first marker which shows a rising trend, but it is less specific compared to the other two markers, that is AFP and beta HCG. So these serum markers, how we influence their presence in the diagnosis and management. Both alpha fetoprotein and human chorionic gonadotropin are secreted by germ cell malignancies. Elevated levels can be used in differential diagnosis. Yes, one more marker is there, that is placental alkaline phosphatase and lactate dehydrogenase. It remains elevated in 90% patients with dysgerminomas, and serial monitoring of serum LDH level may be useful for monitoring in this disease. Embryonal carcinoma is composed of undifferentiated cells that synthesize both HCG and AFP, and it is the progenitor of several other germ cell tumors. More differentiated germ cell tumors like endodermal sinus tumor, that is yolk sac tumor, which secretes AFP, choriocarcinoma, which secrete HCG, and the immature teratomas, which are derived from the embryonic cells and do not secrete HCG but may be associated with an elevated alpha fetoprotein. So we incorporate this finding of tumor markers presence with the histopathology. So in primordial germ cells, the tumors which develop are the dysgerminoma and embryonal carcinoma. In dysgerminomas, AFP and HCG both are negative, while in embryonal carcinoma, AFP and HCG both may be positive. From this embryonal carcinoma, further differentiation into embryonal and the extra embryonic differentiation takes place, in which if in embryonic differentiation both AFP and HCG is negative in immature teratoma, while in yolk sac tumor AFP is positive, while in choriocarcinoma HCG is positive. So clinical examination, then the tumor markers, it will help us in reaching up to a diagnosis. You can see in this picture that LDH is positive in all these tumors, that is dyscerminoma, immature teratoma, yolk sac tumor, embryonal tumor, choriocarcinoma and mixed tumor. Sometimes it may be negative, but LDH is positive in most of the time, while HCG is positive in choriocarcinoma, mixed tumor and sometimes in dyscerminoma, while AFP remains positive in yolk sac tumor, embryonal tumor and mixed tumor. Why I am repeating it? Because to inculcate the idea of tumor marker in you people's mind. So when we see a tumor macroscopically or a gross examination of a tumor is done, even intraoperatively if we see, usually the tumors remains average diameter of 15 centimeter, while dysgerminomas are fleshy, grey, tan or white. Yolk sac tumor is tan or white with a small or large cyst and foci of hemorrhage and necrosis is there. Immature teratoma is white or tan with cyst, and sometimes they have hard cartilaginous or bony focus. Choriocarcinomas, they appear as tissue of hemorrhages and necrosis, and usually they are unilateral. Gestational, these germ cell tumors are unilateral one, but sometimes they may be bilateral in dysgerminoma. So how this patient presents to us with germ cell tumors? In women, we see epithelial ovarian carcinoma, which are slow growing tumors, but the germ cell tumors are rapidly growing tumors. So patient may present to us with subacute pelvic pain because of the capsular distension, because of the hemorrhage within the tumor, because of the necrosis. And because of the rapidly enlarging large tumor of average 15 centimeter, it puts pressure over the nearby organs, that is bladder and rectum, and patient may present with these symptoms also to us, and sometimes menstrual irregularities may be there. Acute symptoms are associated with torsion, as in case of the teratomas, and sometimes rupture can also occur. So what we have to see, first of all, is age is a very important factor in germ cell tumor. Patient with germ cell tumor, whether she is premenarchal or postmenarchal, it is the first point which we have to note. Then we have to see whether the lesion is solid or a combination of solid and cystic, and then radiological imaging investigation should be carried out, which may point that this may be a neoplasm, which is probable neoplasm is there, and a malignancy is possible. Then we have to look for the staging, higher stage of the disease, by looking at the whether ascites is present, whether any pleural effusion is present, or organomegaly is present. So these are the signs which we have to elicit. Now to reach to the diagnosis, important thing is adnexal mass, if it is of 2 centimeter or more in premenarchal girls, or complex mass 8 centimeter or more in premenopausal or reproductive age group or postmenarchal girl, patient usually requires surgical exploration. So if a girl is premenarchal, that is of 4, 5, 6, 7, 8 year, and she is having a 2 centimeter mass, or postmenarchal girl who is having a 8 centimeter mass with which is complex, maybe solid cystic, both of these girls, these cases require surgical exploration. So in young patient, preoperative, in all the patient we carry out all these investigation, but it is of much importance when we talk of germ cell tumor. We need to carry out the tumor markers, serum HCG, AFP, LDH and CA125 level, because it can be a case of epithelial ovarian cancer also. That too we have to exclude. And a radiograph is a must before taking the patient for surgery, to exclude the metastasis to the lungs or mediastinum. And the most important thing which, is here, in premenarchal girl, a karyotype should ideally be obtained preoperatively on all premenarchal girls because of the propensity of these tumors to arise in dysgenetic gonads. So the gonad which we are thinking is ovary may not be ovary. So a karyotype is must in premenarchal girls. So now our evaluation also includes the imaging modalities, in which the age of the patient is taken, tumor markers are taken, and the imaging results are taken. So in a premenarchal girl, if mass is less than 2 centimeter or with positive markers, then a karyotype is ordered and patient is taken for surgery. While if tumor markers are done and the age of the woman, the girl is postmenarchal girl is there, size is cystic on imaging modality less than 8 centimeter and tumor markers are negative, then this patient can be kept on hormonal suppression for 2 months and then re-evaluated after 2 months. If a postmenarchal girl mass is cystic or maybe solid, suspicion of malignancy is there, and positive tumor markers are there, such patient should be straight taken for surgical exploration. So this is how we will proceed with age, with tumor markers, with imaging modalities to plan the management of this patient. Whenever we thought of surgery in these germ cell tumors, fertility has been discussed, the issue of fertility. If fertility is desired, then fertility sparing surgery and comprehensive surgery should be planned. Fertility sparing surgery means that we have to remove the mass and we have to leave the uterus and the contralateral tube and ovary. If fertility is not desired, then we can do the complete staging surgery. As far as staging of ovarian carcinoma is concerned, stage 8 diagnosis, if in case of the dysgerminoma, in yolk-sac tumor and immature teratomas, it is seen that the patient presents, 66% of the patient presents in stage 1, with yolk-sac tumor 50% patient comes to us, and with immature teratoma 72% patient comes to us. So if a patient comes to us in stage 1, then the chances of survival with proper management is 99%. And with yolk-sac tumor it is 95%, with immature teratomas it is 98%. But if the stage increases, stage 2 or stage 4 is there, then the survival chances get reduced. In dysgerminoma, because we are discussing it is separate because it is the most common malignant germ cell tumor, and it's responsible for 30 to 40% cases of all ovarian cancers of germ cell origin. They represent only 1 to 3% of all ovarian cancer, but in case of the germ cell tumors, it is responsible for 30 to 40% cases. 75% cases occur in the age between 10 and 30 years. And the commonest ovarian malignancy which is associated with pregnancy is is dysgerminoma. Usually unilateral solid ovarian masses are the tumor markers LDL, PLAP positive and sometimes beta HCG positive. Histological picture shows uniform cells separated by fibrous septa, excellent prognosis for which we are concerned, and they are highly radiosensitive and chemosensitive. This is one of the pic of the dysgerminoma of the ovary, where you can see a solid tumor in the center. You can very well appreciate the cystic appearance with hemorrhagic areas. So treatment of early dysgerminoma is primarily surgical, including resection of the primary lesion and limited surgical staging. Limited surgical staging because they are highly chemosensitive tumor. So the ovarian staging which we perform for epithelial ovarian cancer is not required here. Limited surgical staging includes washings taken from the pouch of the Douglas, from the paracolic gutter, omental biopsy is done. Then the retroperitoneal surfaces are palpated. If any biopsy is needed, it is carried out, and then chemotherapy is administered in patients with metastatic diseases. So minimum operation is ovarian germinoma is unilateral oophorectomy. If there is desire to preserve fertility, as usually the case, which in the contralateral ovary, fallopian tube and the uterus is left in situ, even in presence of metastatic disease because of the sensitivity of the tumor to chemotherapy. If fertility preservation is not required, then staging with total abdominal hysterectomy and bilateral salping oophorectomy can be done. One more important point is here, which I want to emphasize, that in patients whose karyotype contains a Y chromosome, because we have carried out karyotype in perimenarchal girl, both ovaries should be removed, or the uterus may be left in situ for possible future embryo transfer. Because 5% of the dysgerminomas, they occur in phenotype females with abnormal gonads, and if there is a Y chromosome, then the contralateral ovary should be removed. Chemotherapy is the treatment of choice for the following surgery, and the commonest chemotherapy regime which is mentioned in the textbook and in use is the bleomycin, etoposide and cisplatin, which can be used. Radiation loss of is associated with loss of fertility, and secondary malignancy is important late effect of radiation therapy. So it is no longer used for primary treatment. The dysgerminomas are very sensitive to radiation therapy also, and dose of 2500 to 3500 Cgrs is curative, but we do not use it as a primary treatment. It can be used for recurrence, local recurrence if it is occurring, then radiotherapy can be used. Then there are other tumors where the plan of management is similar, that is immature teratoma. But immature teratoma is the important thing is the grading system which we use is the presence of the immature neural tissues because it decides the prognosis of the tumor. Along with the tumor markers alpha fetoprotein and HCG, alpha fetoprotein may remain positive while HCG remains negative. Again, the surgical plan is similar to the dysgerminomas. Then coming to the major cystic teratoma, that is dermoid. This is the commonest tumor which we get in our day-to-day surgical practice, where we get hair, teeth, sebaceous material in the tumor, and complication patient presents with torsion, sometimes rupture, and it is managed very well with the by the surgery by performing cystectomy. Then there are other tumors also, endodermal sinus tumor. Treatment is similar, that is the plan of the surgery, and then chemotherapy. In rare germ cell tumors of the ovary, that is embryonal carcinoma of the ovary is an extremely rare tumor. Patients are very young, that is of 4 and 28 years. The patient exhibiting symptoms and signs of precocious pseudopuberty or irregular bleeding may be there. In choriocarcinoma of the ovary is a very rarest tumor, but when it is diagnosed, already the parenchyma of the tissue is involved. So choriocarcinoma of the ovary is always treated as a high-risk tumor, and it is managed, and treatment is followed by the levels of the HCG. Overall prognosis is excellent. Stage 1 disease survival is very good in gestational cell tumor, germ cell tumor. Chemotherapy dramatically improve the outcomes, and that's why we need to discuss, is already been discussed in the panel discussion, long-term fertility preservation is achievable in these patients. So we should focus on this in management of the germ cell tumor, but surveillance is required for years, year 1, 2, 3, 4 and at least 5 years by physical examination, serum tumor markers and the radiographic imaging. So take home message for germ cell tumor is it requires multidisciplinary treatment. It needs the gray area, the vacuums in the management needs to be addressed well. Germ cell tumor diagnosis, management and follow-up is required for years, and it's an essential component for that particular patient. Tumor marker staging and the menarchal status are important determinants in management of these cases, and fertility issue needs to be addressed well. Thank you. Thanks a lot for giving me time, for listening me.
I'll request Dr. Shalini ma'am to also join us for the group picture. Well, I know it is way past lunchtime, but I'll request the patience of the audience for just a little more while as we conduct the inauguration ceremony of our conference. Well, a very good afternoon to all of you. What an honor it is to be addressing this august gathering of academic stalwarts, senior physicians, and dear students. This amalgamation of so many doctors across multiple specialities with a singular focus of enhancing care of children suffering from cancer or other hematological disorder can only have been possible by the will of the mighty God. To spread the light of knowledge and seek the blessings of Ma Saraswati, I'll request the dignitaries, our patrons, Dr. Ashok Gaur, Dr. Dinesh Purani sir, Dr. R.K.S. Dhakar sir, Dr. Harish sir, Dr. Patro, Dr. V.K. Sharma, Dr. Anil, Dr. Vijay, to please come forward for the lamp lighting.
Pani
been set long back by our pillars of strength, Nana, Nani, and Raju Mama. I'll also request the dignitaries to extend a floral tribute to late Shri Rajeev Sahai ji, late Srimati Kamla Sahai ji, and late Shri Sheetla Sahai ji. After seeking the benediction of Goddess Saraswati, the guidance of our ancestors, it is time now to move ahead by expressing our pride in our nation. I'll request the dignitaries on the dais and our esteemed guests in the hall to please stand up for Vande Mataram. to please resume your seats. I hope that very soon we learn the entire lyrics to the song and we can hum along. Well, till then, so we are indeed privileged to have with us this assembly of eminent personalities who are revolutionizing healthcare and health education. To extend our gratitude, I'll request Dr. B.R. Srivastav sir to please extend a floral welcome to our chief guest, Dr. R.K.S. Thakur sir. A big round of applause for the floral welcome of our guest. I'll request Dr. Anjula Jain ma'am to please come on the stage and extend a floral welcome to our esteemed patron, Dr. Ajay Gaur sir. A big round of applause for our esteemed patron. I'll request Dr. Sabah Ahmed ma'am to please come on the stage and extend a floral welcome to our beloved doctor and teacher, Dr. Burani sir. A big round of applause for the welcome of our patron. I'll invite on stage Dr. Pankaj Gandotra sir to welcome Dr. Ishan Patro sir, representing National Academy of Medical Sciences. He has served as former Vice Chancellor at Ravenshaw University, Cuttack, is the immediate past president of Indian Academy of Neurosciences. Among his various achievements, a big round of applause to welcome our guest. Now I'll request Dr. Rajni ma'am to please come on the stage and extend a floral welcome to Dr. Harish Gupta sir, Deputy CEO, Cankids India, who has more than 25 years of experience in public health, hospital administration and project development. Thank you, sir, for coming today and for all the help you extend to the Institute. I'll request Dr. R.K. Jain, sir, to please come on the stage and extend a floral welcome to Dr. V.K. Sharma, sir, President, Gwalior Academy of Pediatrics, who has been most supportive in the successful execution of this CME. A big round of applause, ladies. We are fortunate to have gathered this constellation of luminaries, leading experts from the field for today's CME. This conclave of academicians would have been impossible less the support of a director, Dr. B.R. Srivastav sir, who is constantly pushing us to pursue excellence, be it in academics, research, hospitality, or caring for our patients with empathy and sympathy. I'll request him to please come on the mic and share his words of wisdom in this august gathering.
आज के इस भव्य साइंटिफिक प्रोग्राम में मुख्य अतिथि के रूप में पधारे हुए मेरे प्रिय अनुज डॉक्टर R.K.S. धाकड़, विशिष्ट अतिथि के रूप में उपस्थित डॉक्टर दिनेश भूरानी, जो कि इस अंचल से आज राजधानी में इस अंचल का नाम पूरे देश में रोशन कर रहे हैं। डॉक्टर ईशान पात्रो, फॉर्मर वाइस चांसलर एंड renowned साइंटिस्ट, डॉक्टर दिनेश जी, विजय चौधरी जी, इस कार्यक्रम के पैटर्न डॉक्टर अजय गौड़, नाम बाद में इसलिए लिया कि ये जवाहर कॉलोनी मेरे पड़ोसी हैं और रोज़ हम एक दूसरे को चाय पीते हुए देखते रहते हैं। मेरे छोटे भाई हैं, मेरे स्टूडेंट भी हैं। डॉक्टर V.K. शर्मा, डॉक्टर अनिल शर्मा, सभागृह में उपस्थित इंडियन मेडिकल एसोसिएशन के पूर्व अध्यक्ष डॉक्टर राहुल सप्रा जी और देश के विभिन्न भागों से पधारे हुए अति विशिष्ट साइंटिस्ट, डॉक्टर्स और सभागृह में उपस्थित प्रेस एवं प्रिंट मीडिया, इलेक्ट्रॉनिक मीडिया के सभी सम्मानित सदस्यों, अतिथियों, प्रिय छात्र एवं छात्राओं, देवी और सज्जनों, निश्चित रूप से कैंसर चिकित्सालय एवं संस्थान में स्थापित इस शीतला सहाय सभागृह में यह जो आयोजन किया जा रहा है, उसके लिए मैं आपका स्वागत बंदन किन शब्दों में करूं, यह मैं सोच नहीं पा रहा हूं। ट्रेडिशनली जो मेरे मुंह से दो पंक्तियां निकलती हैं, उन्हीं से मैं आपका स्वागत करता हूं कि स्वागत ही है शब्द यहाँ जो बोला जा सकता है, इसमें छिपा सम्मान भाव नहीं तोला जा सकता है, फूलों जैसे कोमल शब्द नहीं हो सकते, फूलों जैसे कोमल शब्द नहीं हो सकते, किंतु स्वरों का कंपन समझा तो जा सकता है। आप सभी का स्वागत है, वंदन है, अभिनंदन है। साथियों, ये समारोह इस सभागृह में आयोजित जो किया गया है, यह इसलिए भी विशिष्ट है कि दिस CME इज ऑन पीडियाट्रिक कैंसर। ये जो बीच में आप फोटो देख रहे हैं, स्वर्गीय श्री राजीव सहाय का, we count pediatric age from 0 to 19 years. At the age of 15 years, when he was 15 years, he developed osteosarcoma. उस वक्त कैंसर के ट्रीटमेंट की, इलाज की सुविधाएं इस क्षेत्र में नहीं थी, तो स्वर्गीय शीतला सहाय जी को उनके इलाज के लिए टाटा मेमोरियल हॉस्पिटल जाना पड़ा और दुर्भाग्य से उनके प्राणों की रक्षा नहीं हो सकी। दुखी माता पिता, जैसा कि हम सुबह से डिस्कस कर रहे हैं कि पीडियाट्रिक कैंसर इज डिफरेंट फ्रॉम अदर कैंसर इन द सेंस कि यहाँ एक 4 साल के बच्चे को, 5 साल के बच्चे को जब कैंसर होता है, तो हम सिर्फ इस बात की चिंता नहीं करते कि उसकी बीमारी ठीक हो जाए, बल्कि इस बात की भी चिंता करते हैं कि उसका भविष्य सुरक्षित रहे, उसके आने वाले जीवन में उसको किसी तरह की इन्फीरियरिटी महसूस नहीं हो। यह एक अत्यंत महत्व का विषय है। साथियों, स्वर्गीय श्री शीतला सहाय दंपत्ति के इकलौते पुत्र की कैंसर से मृत्यु हुई 15 इयर्स की एज में। माता पिता का दुख का आप अंदाज लगा सकते हैं, लेकिन जैसा कहते हैं कि सच है विपत्ति जब आती है तो कायर को दहलाती है, सूरमा नहीं विचलित होते, क्षण एक नहीं धीरज खोते, कांटों में राह बनाते हैं, विघ्नों को गले लगाते हैं। और श्री शीतला सहाय जी ने एक संकल्प लिया कि इस क्षेत्र में कैंसर चिकित्सालय की स्थापना की जाए। जगह की कमी थी, सरकार ने मदद की, एंड दिस हिल, पहाड़ी, जहाँ पहाड़ थे, उनका चयन किया गया। इकबाल ने लिखा है, नहीं तेरा नसीमन खुसरो सुल्तानी की गुंबद पर, नहीं तेरा नसीमन खुसरो सुल्तानी की गुंबद पर, तू शाहीन है बसेरा कर चट्टानों पर, पहाड़ों पर। यू आर एन ईगल, यू शुड रोस्ट ऑन द रॉक्स एंड माउंटेन्स, नॉट ऑन द इम्पीरियल पैलेस। और इस पहाड़ी का कैंसर चिकित्सालय के लिए चयन किया गया। जहां पानी की एक बूंद नहीं थी, वहां आज इलाज रूपी अमृत की धारा बह रही है और हजारों लाखों लोगों को इलाज का लाभ मिल रहा है। बहुत महत्वपूर्ण विषय पर आयोजित इस CME में हमें हर्ष इस बात का है कि देश के अत्यंत जाने माने विशिष्ट डॉक्टर्स जो कि इस फील्ड में अपना पूरा जीवन समर्पित करके कार्य कर रहे हैं, वह आज इस CME में पधारे हैं। यह इस बात की प्रमाणिकता है कि पीडियाट्रिक कैंसर पर आयोजित इस साइंटिफिक प्रोग्राम का कितना महत्व है। और बहुत सारे डिस्कशंस हुए. आई विल नॉट टेक मच टाइम, लेकिन सिर्फ इतना कहना चाहता हूँ कि यह CME पीडियाट्रिक कैंसर के लिए, पीडियाट्रिक एज ग्रुप के मरीजों के लिए एक नई दिशा इस क्षेत्र में प्रदान करेगा. मैं डॉक्टर भूरानी साहब से बात कर रहा था तो उन्होंने कहा कि इतने सारे पार्टिसिपेंट्स हैं, ये देख के बहुत अच्छा लग रहा है. मैंने कहा सर आप आए हैं तो लोगों को अगली साल भी उम्मीद रही कि जितने गेस्ट स्पीकर राजीव गांधी कैंसर हॉस्पिटल एंड ऑल डिफरेंट प्लेसेस से आए हैं, तो हो सकता है कि अगले साल आपको इससे, ये पीछे पर्दा लगाया हुआ है कर्टेन, इसकी जो सीटिंग कैपेसिटी है वो 300 है, 350 के करीब 250 कर दी है. मुझे लगता है कि 100 की कैपेसिटी और अगली कॉन्फ्रेंस में बढ़ानी पड़ेगी, जिससे कि ज़्यादा से ज़्यादा डॉक्टर्स इस CME का लाभ उठा सकें. मैं आप सभी का स्वागत करता हूं, अभिनंदन करता हूं, वंदन करता हूं. और डॉक्टर गुंजन ने वैसे मुझसे घर पे तो कहा था कि आपको स्वागत भाषण देना है, और यहाँ अनाउंस किया कि वर्ड ऑफ विजडम बोलना है. तो वर्ड ऑफ विजडम में क्या बोलूँ, एक ही चीज़ कहना चाहूँगा कि एनी नॉलेज, एजुकेशन which we acquired, once it is used for the welfare of the society, then it is wisdom. Acquiring knowledge is not enough until unless we use this knowledge for the welfare of the society. It's just only knowledge, no wisdom. So word of wisdom for today is that whatever we learn here, let us apply that knowledge for the welfare of the society. Then really our aim will be successful and goal for organizing this CME will be successful. Thank you very much for my time.
Thank you, sir, for those wonderful words. We are happy to share that today's CME on pediatric oncology and hematology is been attended by more than 100 delegates. We have had quality abstracts for paper and poster presentation, and we are eagerly looking forward to the quiz that is about to happen in the coming hours. This, along with a pantheon of more than 50 experts from across the country, has happened thanks to the support and guidance of our patrons. Our first patron, Dr. Ajay Gaur sir, is a household name in Gwalior city. He has touched many an innocent lives and set the foundations for healthy life for lakhs of children, if I'm not wrong. A clinician par excellence, he is also a stellar academician who has held multiple research projects, held many eminent posts through his illustrious career, and has been most generous in his support for this CME. I'll request sir to please come on the mic and address the gathering.
Thank you, Dr. Gunjan, and good afternoon to all. I will not take too much of your time. मेरे आदरणीय डॉक्टर BR सर, मेरे टीचर, और जैसा सर ने कहा, मैं हमेशा सर को एक बड़े भाई के रूप में देखता हूँ, और वो मुझे उसी तरह जो है वो मेरे करियर में जो है वो गाइड करते हैं. मेरे दो बड़े पुराने डॉक्टर दिनेश, मैं जब रायपुर में AP था तब दिनेश PG कर रहा था, तो हम लोग साथ साथ रायपुर का ट्रैवल करते थे, यहाँ से रायपुर और रायपुर से ग्वालियर. तो तब से हमारी दिनेश के साथ जो है वो दोस्ती है. और डॉक्टर धाकड़, अवर डायनेमिक डीन, ही इज़ वेरी इनोवेटिव इन academics and all the dignitaries. I just met Dr. Harish for the first time, very genuine person. Dr. Patro, I know him since long when he was in professor of zoology in the J University, as my father was also professor of zoology in Jivaji University. And Dr. Anil, Dr. VK, all my dear friends and students. And जैसा कि डॉक्टर गुंजन ने बोला इस एसोसिएशन के लिए, and we have so many cancer patients in our pediatric department, but unfortunately we don't have the registry system, we don't have the licensing with other institute, as well as we don't have anyone who can hold the hand of the diseased as well as their family. So we are just discussing with Dr. Harish and with our dean also, and we are thinking we have lot of practitioners also of pediatrics here, Dr. VK is president, VK Sharma is president of GAP, Dr. Rahul, Dr. Gopi, all are sitting here. So we should, Dr. Banga sir, so we should have, I think, one system in the Gwalior so that at least the patient who is suffering with this can have something, so that we can assure him, we can counsel him, we can show him some path, so that he will not go here and there. And as you know that these pediatric cancers are very unique in their diagnosis, and early diagnosis and early management is the crux of this. Thank you very much, sir, for inviting me here, and thank you very much. Good day.
Thank you, sir. We are indeed too elated to have with us Dr. Dinesh Purani, sir, Director, Department of Hematology and Bone Marrow Transplantation, RGCI, Delhi. His immense knowledge, vast experience, his gentle tone and his calm demeanor are exemplary and set a benchmark for us to aspire for. Even though his education at work has taken him across the globe, he has still remained deeply rooted to the city of Gwalior. His mentorship guides us and strengthens our confidence. I'll invite Dr. Dinesh Purani, sir, to please come on the mic and address the gathering.
आज गुंजन खाना खाने नहीं देगी किसी को भी, लग नहीं रहा है कि हम लोग खाना खाएंगे. डॉक्टर श्रीवास्तव ने जब यहाँ स्टार्ट किया था, there was no cancer activities here. Imagine the many years back. Now we are sitting with the pediatric specific conference with so many people attending it. So I really congratulate Dr. Srivastav, Dr. Gunjan and his whole team that we have reached to the level that in Gwalior city we are able to do a specific focused CMAs, and we are going to do it regularly. I am the only person who is practicing outside and is still the part of that 6 photos or 8 photos are there. So I am really thankful. I feel honored that I am the part of the same. I've been considered as a part of the city, and I really thankful for this. I congratulate everyone and thank you for inviting me.
Thank you, sir. Well, we are immensely proud to have with us our dashing and dynamic Dean, sir. Not only a great surgeon, he shines as a teacher and a leader of even greater credence. Under his leadership, GRMC Gwalior has seen monumental transformation with drastic developments in hospital, enhanced patient care, advanced training for students, and initiation of landmark clinical projects like registry. सुनकर कर दे अनसुना, ऐसी इनकी आवाज़ नहीं, मिलकर भूल जाए कोई, ऐसे इनके अल्फाज नहीं, किसी महफिल में छुप जाए, ऐसे इनके अंदाज नहीं, सूरज से दमकते हैं ये, किसी परिचय के मोहताज नहीं. Ladies and gentlemen, a big round of applause. I'll invite Dean, sir, to please come on the mic and address the gathering.
Thank you, Gunjan, for your words, and I can say proudly, she is a bright future of this Cancer Hospital and Research Institute. B.R. श्रीवास्तव सर, वो अनुज कह दिए तो मेरे बड़े भाई हैं ही, पहले से हैं, उनसे बहुत कुछ सीख रहा हूँ. दिनेश पुरानी सर का साथ छात्रावास से लेके और उनके दतिया वाले घर से लेके और अभी तक वैसा का वैसा आशीर्वाद बना हुआ है. डॉक्टर अजय गौड़ सर हमारे मेडिकल कॉलेज के एक टीचिंग और रिसर्च के बहुत बड़े पिलर हैं. अभी एक हिस्टोरिकल फर्स्ट टाइम रिसर्च मेथोडोलॉजी फॉर फर्स्ट ईयर पीजीज, अभी वो एक डॉक्टर बृंदा जोशी और वो दोनों फर्स्ट टाइम वी स्टार्टेड इन आवर मेडिकल कॉलेज. डॉक्टर I don't know about first time I'm meeting Dr. Hars, Dr. Chaudhary, and Dr. Patro, Dr. VK, Dr. Ajay, and all ladies and gentlemen. Research, especially for the clinicians, is always an integral part. As I came to know, you are talking on pediatric cancer. बड़ा ही एक किसी के सर ने एक जो बहुत ही एक ऐसी घटना जिसकी वजह से हम यहाँ बैठे हैं, हम लोग कई बार देखते हैं कि एक छोटा सा बच्चा जिसने अपने जीवन का कुछ नहीं देखा और वहाँ पर पता चलता है कि उसको इस तरह का कोई बीमारी है। बुरानी सर चूँकि उसी सेगमेंट में काम कर रहे हैं और यहाँ से ऑस्ट्रेलिया जाके और वहाँ से लेके जो इंडिया में अभी राजीव गांधी कैंसर इंस्टीट्यूट में, ही इज़ टोटली डिवोटेड टू द पीडियाट्रिक कैंसर. He did lot of bone marrow transplants and he is saving lot of lives of the kids. But कभी कभी जो एक भविष्य सा दिखता है और एक ही क्षण में पता चलता है कि वो भविष्य अंधकार में है. कभी किसी के बस में ये चीज़ें नहीं होती कि उसे वापस लाया जा सके. बट मैं कह सकता हूँ कि अभी हम उस रिसर्च के टाइम में हैं जहाँ अर्ली डिटेक्शन एंड आई थिंक टारगेट थेरेपी, जीन थेरेपी, बहुत सारी चीज़ें हम रिसर्च के माध्यम से जल्दी डायग्नोस कर रहे हैं, उनको ट्रीट भी कर पा रहे हैं. अभी सर मैं बताना चाहूँगा कि कई बहुत सारी चीज़ों को, जैसे जीनोम सीक्वेंसिंग हो गया, मॉलिकुलर जो कैंसर से रिलेटेड कई मॉलिकुलर बायोलॉजी है, HLA टाइपिंग है. मैं आपको बताना चाहूँगा भूरानी सर कि इट इज़ गुड न्यूज़ फॉर ग्वालियर. आई थिंक in the month of June we will start all these investigating tools in our institute very soon. तो रोज़ाना कहीं ना कहीं चीज़ें बढ़ रही हैं. सरकार भी, जो मैं देख रहा हूँ पिछले 10 साल से, जितना हेल्थ और मेडिकल एजुकेशन पे भारत सरकार और स्टेट गवर्नमेंट ने जितना फोकस किया है वो कभी होता नहीं था. जितना बजट पूरे 8 या 10 मेडिकल कॉलेज का होता था उतना आज एक मेडिकल कॉलेज का है. और सारी सुविधाएं सरकार उपलब्ध करा रही है, जिसमें कभी कभी तो 60-40 के रेशो में, जो 60% सेंट्रल गवर्नमेंट कर रहा है और 40% स्टेट गवर्नमेंट कंट्रीब्यूट कर रहा है. एक और चीज़ बताना चाहूँगा कैंसर से रिलेटेड, हमारा टर्सरी केयर सेंटर जो काफ़ी दिनों से चल रहा था सर, एंड सून वी विल गेट, they are on board, they are in the SIP, new brachy, linear accelerator and CT simulator. All these machines, they will be start within 2-3 months in your city. So this is only possible because of the, the vision of the government and because of you guys. Because we are forcing government, we are forcing system, just bring it. क्योंकि हमें इसकी आवश्यकता है. जब हम किसी का दरवाज़ा नॉक करते हैं कि नहीं हम ये कर पाएंगे, तो फिर मिलता है, चीज़ें आती हैं और उसका फ़ायदा हमेशा समाज को मिलता है. BR सर का चूँकि बहुत बड़ा योगदान इस क्षेत्र को है, और मैं ये कहना चाहूँगा सर कि कई बार ऐसे कंपैरेटिव होता है कि नहीं ये प्राइवेट है और ये सरकारी है और ये ट्रस्ट है. हम लोग हेल्थ फैसिलिटेटर हैं, वी आर हेल्थ पार्टनर्स. कोई सरकारी और प्राइवेट का कोई भेद किसी लेवल पे नहीं होना चाहिए और ना होगा. और जो इन्वेस्टिगेशंस हम शुरू करने जा रहे हैं, हम आपको भी पूरे शहर के जो जितने क्लिनिशियंस हैं उनको बुला के, और जिन जिन में हम मदद कर सकते हैं, जो भी उसका मान लीजिए एक मिनिमम चार्जेस होंगे, तो उसके साथ भी हम शुरू करने वाले हैं. जो पैट सिटी अगले महीने शुरू, एक और आपने तो शहर में एक अलग सा एक बहुत ही शानदार सा एक पैट सिटी लाके शुरुआत की थी. JRMC में भी सर नेक्स्ट मंथ पैट सिटी विल स्टार्ट एंड इट विल बी एट लो कॉस्ट. सो मैं कह सकता हूँ कि जितने भी CMEs, research, it's just for the exchange of knowledge, exchange of thoughts and integration of the knowledge in between. तो मुझे उम्मीद है कि हम सब इस तरह की जो कार्यशालाएं हैं उनसे लाभान्वित होंगे और समाज को कुछ न कुछ दे पाएंगे. थैंक यू गुंजन फॉर योर वर्ड्स.
Thank you, sir. Well, this CME has been very special to us for multiple reasons, chief being the enthusiasm of our delegates and the host of illustrious guests. As a token of gratitude, I will now be executing the memento distribution ceremony, for which I'll first request Director Dr. B.R. Srivastav sir to please give a memento to our chief guest Dr. R.K.S. Thakur sir. A big round of applause, ladies and gentlemen. I'll request Dr. Anil Sharma to please give the memento to our patron, Dr. Ajay Gaur sir. A big round of applause, ladies and gentlemen. I'll request Dr. Vijay to please give the memento to our patron, Dr. Bhurani sir. I'll request Dr. V.K. Sharma sir to please give the memento to Dr. Patro sir. We are grateful to NAMS for their support in this CME, and thank you, sir, for visiting us. I'll request Dr. Rajput sir to please come on the stage and give the memento to Dr. Harish sir. I'll request Dr. Tripathi sir to please give the memento to Dr. V.K. Sharma sir. A big round of applause. We are grateful for all the support we have received from each and every one. I'll now invite Dr. Anil Sharma sir for a vote of thanks.
Respected Chief Guest, Guest of Honor, Distinguished Chairperson, Eminent Speaker, faculty members and delegates. It is my privilege to propose the vote of thanks on this occasion for the inauguration of our CME on pediatric hematology and oncology. First, I express my sincere gratitude to our esteemed dignitary for gracing this occasion and blessing the event successfully. A special thanks to all the department supporting staff who worked sincerely for this. After this inauguration ceremony, lunch will be served. All dignitary delegates are kindly join the lunch. Thank you.
Just one tiny thing. I'll request everyone to stand up for national anthem.
जय भारत माता की जय. can proceed